A very good morning and a warm welcome to all the doctors present at 5th IOA-IFAS 2025. We gather here to share ideas and open discussion. With this, I would begin the first session by inviting our chairpersons, Dr. Shaumitra Misra, Dr. Ajit Kumar, Dr. Dhaval Dilip Desai and Dr. Ramakant Gopalakrishnan to please come up on the stage and begin the session by inviting the speakers.
So we begin the session. May I invite the first speaker, Dr. Girish Motwani from Maharashtra, to speak on ankle and syndesmotic malunion. Welcome, Girish.
Thank you, organizers. Thank you, chairpersons, for this wonderful meeting. And this course is happening in 6 different cities. The presentations are made similar, and it is the same presentation happening all over the country today. This is not my presentation. This presentation was given to me by IFAS. So I am here to convey the presentation to the audience, and we will have a questions at the end. Okay, so I am Dr. Girish Motwani. I am a foot and ankle surgeon from Nagpur, and we are going to start with the neglected ankle trauma first. So this is a 30-year-old male. Let's make it interactive. This is a 30-year-old male, civil engineer by profession, twisting ankle injury. And this was the X-ray, which is showing fibula fracture infrasyndesmotic. It is showing the posterior malleolus fracture also. And this was the X-ray which was done non-weight bearing on day 1. Just wanted to have the opinion of our expert chairpersons that what should be our next step? Should we evaluate it more or treat it directly in this stage? Ramakant sir.
So his main symptom of pain, isn't it?
Yeah. So he had a twisting ankle injury, not able to walk.
This is a day 1 injury?
This is day 1 injury,
okay.
yes.
Okay.
X-ray of day 1. Not my presentation, sir. It is running all over the India.
I know.
So this is an idea which is given to us by the IFAS. There is a young patient, twisting ankle injury. So he might have twisted while walking. And so my question is...
Trimalleolar fracture, definitely it is a... I'm not sure, there is a lot of reflection. Medial side, maybe a deltoid injury, and definitely there is a lateral side injury and the posterior side injury. Information I'm looking for is whether the fibular height is reduced and the syndesmotic portion injury is there or not.
Perfect. Ajit sir, do you feel that this is a trimalleolar injury or the circle has completed? Because it's look like atypical because it's a infrasyndesmotic fibula fracture. Usually what we see in the trimalleolar is Weber B or Weber C.
Yeah. So not sure whether the forces have gone all the way across to the medial side.
Yeah.
So it could be grade 3, if not a 4.
Okay. So let's see what was the X-ray finding. And okay, so anyway, the surgeon has managed this injury conservatively with the Pilon plaster. Okay, and this was the X-ray which was done after 1.5 months. Acceptable to Naveen sir? Naveen sir, is it acceptable to you? Mike please. We have less audience, so let's make it interactive.
Not acceptable. We have to check for the instability. Static films will not show the stability. So we need weight bearing or hanging X-ray. So exactly to get whether there is a subluxation of the ankle or not.
Yeah.
Ligamentous injuries are there.
So
Dynamic study.
So that's a great message that we want to see whether this injury is stable or not stable. Increase in the medial clear space could be maybe plus minus in this X-ray. But let's see, 2 months the patient has started walking, okay, and now the patient has a persistent pain. This patient is walking since 2.5 months now, and this is an X-ray. Probably, yeah, this is again a non-weight bearing X-ray, which is showing a displaced posterior malleus fracture, which is showing a stable fibula fracture, but there is clear space between medial tibiotalar space.
Stress view or stress view, a gravity view or a stress view.
That's what Naveen sir want to say. So we want to see whether this injury is stable or not. So going back to the first X-ray, so yeah.
One clear-cut message. So in this kind of X-ray, we have to evaluate day one, not after 45 days.
Correct. Absolutely fine, sir. I totally accept. So now we are going that why did this happen and what should be our first step to avoid this complication. So John sir has given a very good idea, gravity stress view. Because we don't know, Ajit sir was saying it could be grade 3 or it could be grade 4. Dr. Ramakant is also saying that it could be a medial injury. So clinical examination, medial tenderness, medial ecchymosis is also important, but it gives you the idea of only 60% sensitivity. So what is more important is gravity stress view, or what is more important is weight bearing X-ray. So tell the patient to go back to home with the plaster, come back after 7 days so that he will be able to weight bear. And if on the weight bearing X-ray on 7th day, if you find that the medial clear space is this, probably you have treated the injury surgically on 7th day or 10th day. So this is a clear message that all bimalleolar or the trimalleolar definitely unstable, but when you see the two malleolus fracture and the stable ankle mortise, that means the injury may be complete and you are missing something. So always get done the weight bearing X-ray or the gravity stress X-ray. So this is now a 2.5 months. So now there is a clear cut instability, medial clear space is increased, it is more than 4 mm or it is more than a superior tibiotalar space. Posterior malleus is also displaced. So now what? Bedi sir.
Although I appreciate that 2 months have gone, but we can't afford to leave it in this kind of situation.
Absolutely, because he's a young civil engineer.
Absolutely.
Yeah.
So I think you'll unfortunately have to go and mobilize the fracture fragments.
Perfect.
So the magic lies now in the fibula, which needs to be mobilized. So you almost need to go
Perfect.
through the osteotomy, mobilize it as best as you can, try to shift the fibula along, put it back, hopefully it'll fix the talus. If it doesn't work, go with the idea, you might even have to make a medial cut, almost like a reconstruct the deltoid or a suture to pull the talus across to one
Perfect.
side.
So just a small question. Increase in the medial clear space indicates what? It indicates deltoid injury, it indicates syndesmosis injury, or it indicates both? In your judgment, increase in the medial clear space means what?
So syndesmotic injury almost definitely yes.
Yes.
A fibula pulling the talus to one side, yes. Deltoid now becomes a little doubtful. So the plan is that one part of the deltoid is gone, the other might be still intact. So you cannot say a complete deltoid just because the talus is.
Perfect. Naveen sir.
But once you fix the posterior malleus, syndesmosis will be almost okay.
Okay, perfect. Increase in the medial clear space. So, as long as the deltoid is intact, I am talking about the deep deltoid, as long as the deep deltoid is intact, it doesn't allow even 1 mm of movement of the talus laterally. Even 1 mm is not allowed, as long as the deep deltoid is intact. Only when the deep deltoid is ruptured, talus starts shifting laterally. But as long as it is intact, not possible to get even 1 mm. So if increase in the medial clear space, it indicates that there is definitely a deltoid ligament injury plus minus syndesmotic injury. Naveen sir is also right. If you have a malleolar fracture, probably the syndesmosis is stable, but you need to fix the malleolus to make the syndesmosis stable. Okay, so following the advice of
And
both.
most of the times,
Yeah.
this deltoid which is torn get interposed between the plafond and the medial talar.
Yeah.
So if you do only the lateral side, we may not be able to, and we'll be like not knowing why there is a medial clear space is not getting reduced.
Yeah.
So it's always important to open up and then probably
Yeah, that's what
see.
Dr. Bedi said, that you need to open the clear space and you need to take out everything what is fibrofatty tissue from the, because it's 2.5 months. Yeah, so that is a good advice. Okay, so now we have a clear picture that it's a trimallar injury. It's a posterior malleus, it's a lateral malleus, and it is a medial malleus component, I mean the deltoid component of the medial injury as well. So now the plan is to fix everything because he's a young patient. The deltoid is, I mean the talus is shifted. We know that 1 mm of talar shift, it increased the tibio-talar contact area by 42%. If you miss the posterior malleus fracture, the chances of arthritis in 1 year is almost 80%. So why we are waiting? So you don't accept the posterior malleus malunion, you don't accept the talar shift. So that is the reason of operating this patient. Surgeon wanted to have a good information, so he did a CT scan. In CT you find that your syndesmosis is widened. Why it is widened posteriorly? Because the posterior malleus is not fixed. So probably when you fix the posterior malleus, it will come on, to the way. Answer to the Ramakant sir also, more than a deltoid, it is a tibialis posterior tendon which goes to the medial clear space. And sometime it could be the reason of non-reducibility of the
It happens only with the deep deltoid getting injured.
Yeah, only when it is in. That's why the medial clear space is increased. Yeah, perfect. So he did a MRI also to make the final judgment, but we don't need that. You don't need MRI if the medial clear space is increased, but to see the quality of a tendon, to see the quality of a deltoid ligament, probably the MRI was done. But what we want is, don't miss the medial injury. Identify whether the injury is complete, it is stage 2 or it is stage 4. And now there is a reconstruction versus fusion. Just wanted to know the answer. Raise your hand. Who want to reconstruct? Okay. This is 3 months old injury. Who want to fuse it? Nobody want to fuse. Okay. So the answer is very clear that we need to see age, occupation, demand, everything. That when to reconstruct and when to go for the fusion. The idea is very clear that when it is arthritic, old injury, neuropathic patients, definitely you are going with the fusion first. But if it is a young patient, non-diabetic, non-neuropathic and non-arthritic, why to fuse in less than 6 months? And these are the some studies which are in the favor of salvaging this thing, ankle joint. Now, our understanding on the posterior malleus. I want to ask the question to the panelist that when you want to fix the posterior malleus, sir, when you want to fix the, any guideline, 25% wala guideline or any guidelines?
That guideline is gone. I think probably I will not fix the one which is a very small fragment not going to the fibular incisura. But that is the one which I will not fix. Rest of the posterior malleus I will fix.
Okay. So, do you follow the percentage?
No, not at all.
Okay. So, as long as it is fixable, fix it.
Yes.
Okay.
Only the small ones which doesn't go into the fibular incisura.
Okay.
I will not fix those.
But then how do you fix that small one? Because instability is
No, I
instability.
do not fix those.
Okay.
As I said, I do not fix those. Rest of the posterior malleus I
So, you'll
fix.
do the surrogate fixation by syndesmosis screw.
Yes.
Yeah.
Perfect. Okay.
So size does not matter.
Size doesn't matter.
Instability does matter.
Instability does matter because it is attached to the PITFL. PITFL is the strongest syndesmosis ligament. So if you don't fix the posterior malleus, you don't fix the syndesmosis. And if your syndesmosis is not fixed, your talar shift will remain continue and your patient will present to you with the arthritis within a year. So posterior malleus, so in my 12 years of practice in foot and ankle, I have seen those ankle going into arthritis because people do the fantastic fixation for medial malleus and the lateral malleus. And it is really not tough to do these two malleus fixation. The problem is judgment on the posterior malleus. So those who conserve the posterior malleus, considering that the fragment is very small, it is less than 25%, this is the old guideline. Usually these are the ankle which didn't survive for more than 1 year. So definitely following the Naveen sir, size doesn't matter. 25% criteria is gone. It is even removed from the literature that even a small fragment, fixable fragment should be fixed with the plate or the screw. And if it is a non-fixable fragment, you fix it by the syndesmotic screw fixation. That calls surrogate fixation of a posterior malleus.
Dr. Girish, can I ask one question?
Yeah, please.
Is there any difference between the posteromedial or posterolateral, or how it is, what you have seen, like whether it's all through, both posteromedial and posterolateral, or the isolation?
Yeah. So 80% of the time you find a posterolateral fragment only. But 20% of the time you find posterolateral fragment and the posterior medial fragment separately. That is called posterior pilon. That is a new term which is called posterior pilon, or in the posterior malleus classification it is called type 2 posterior malleus fracture, where you find 2 fragments. This is the only injury where you cannot fix by posterolateral approach only. When you have 2 fragments for the posterior malleus, posterolateral, you need 2 approaches to fix posterolateral fragment separately, posteromedial fragment separately. So that is really a good addition to the posterior malleus, that a type 2 fracture, they are atypical fractures, or when you find 2 fragments, it has to be treated by 2 approach.
So
Perfect.
Pre-op CT is important. Pre-op CT.
CT is important. So these are the cases where you find that the medial malleus is usually intact, and you find a double shadow of a medial malleus. I don't have an X-ray because it's not my presentation, but in that injury, you find a double shadow of a medial malleus. People believe that this is a medial malleus fracture, but it is actually the posteromedial fragment. Yeah.
So you are saying about the fixing the both posteromedial and posterolateral. I think the new tendency has come to go through the modified posteromedial approach, to use one approach to fix both the fractures.
But I think, sir, this is too extensive, and it's a surgeon preference. See, none of the literature has supported it, but it's a surgeon preference. Some of the US surgeons, they are doing some dramatic work. They are keeping the patient in the prone position, going to the center incision, central incision. They are separating the Achilles tendon. They are moving medial to the Achilles tendon, posteromedial fragment, lateral to the, but it is too much invasive. It's too long approach, and playing around the tendon, neurovascular, too close. I think 2 different approaches are a gold standard, and the world believe on 2 approaches for 2 fragments. Yeah. So why to fix posterior malleus? We have already discussed that it is attached to the PITFL. So this is the PITFL. So PITFL is the strongest syndesmosis. As long as the PITFL is intact, it doesn't allow the fibula to go posteriorly. So if you fix the posterior malleus fracture, it prevents the syndesmosis malunion. It doesn't allow the fibula to go posteriorly. Syndesmosis malunion is a 50% problem. So we are not talking about the rare things. If you don't fix the posterior malleus, there is a high chance of syndesmotic instability. And if you fix the syndesmosis, there is a high chances of doing malunion. So some of the literature says that there is a 50% chance of malunion. So that's why it's very important to fix the avulsion fractures of the syndesmosis. Because if you fix the avulsion fracture, you don't have to fix the syndesmosis. So this is...
And it is not detectable on C-arm.
It is not detectable. You need a intraoperative CT scan, which is our lacunae. Yeah, perfect. So these are all the normal criteria. How much should be the clear space? What should be the talar cruel angle? What should be the talar tilt? And this is a dime sign. We all are aware about the fibular malreduction. So this is how the surgeon has done his job. Medial incision, lateral posterolateral approach, fixing the, so he has mobilized because it's just 3 months, so he has mobilized the fracture. So this is fibula mobilization, getting the length. This is going to the between the peroneals and the FHL for the posterior malleus fracture, identifying the fibrosis, removing everything. So this is a fracture, okay? So you have to again refracture it by putting a osteotome or by putting a corpse elevator inside the fracture, break it, shift it down, and then you fix both fibula and the posterior malleus, any of them, by after getting the length, rotation and the alignment. So this is, he has written osteotomy for the posterolatus, but rather than osteotomy, it is mobilization. Reduction technique, so he has done a fibular lengthening. This is a way to lengthen the fibula. Lot many techniques are there. So this is a way, one of the way to to lengthen the fibula. And this is how the fixation was done. Fibula fixation, posterior malus fixation. Syndesmosis clamp application. I don't know why, but we should have one stress X-ray. So when you fix posterior malus, when you fix fibula, now again you will see the external rotation stress view or the valgus stress view to see your deltoid is opening or not, or the medial clear space is opening or not. So if it is opening, that means it could be a deltoid, it could be the syndesmosis, or it could be both. So a clamp application, medial, now medial clear space was open, fibrofatty tissue was removed. This is the instability. Here you can see this is the instability which is showing a increase in the medial clear space and the talar tilt. So that means the deltoid is unstable. So he has used 2 anchors. Usually the deltoid is rupture from the medial malar end. So he has put 2 anchors into the medial malleus and we repair the superficial deltoid. We don't repair the deep deltoid. It's not possible. So we repair the superficial deltoid in the full inversion and he put a syndesmotic screw also. But if I am a surgeon, what I do is fibula, posterior malus or any of them first, stress X-ray, fixing the deltoid first, and then you check the external rotation stress to see the syndesmotic instability. Because what Naveen sir said, when you fix all the component of the injury, the chances of syndesmosis screw fixation is very less. It is less than 10%. Yeah. So this was now 1.5 months showing good. See, the syndesmotic screw is also too high. So if you want to put a syndesmotic screw, it should be 2.5 centimeter above the joint line, where actually the AITFL, just above the AITFL. Okay. So if you are putting a syndesmosis, it should not be too high because it itself is a source of malreduction. Okay. So don't fix too high. And this is the ankle range of motion, 4 months post-op. This is how the patient is walking because he fixed all the component of the injury. So that's why the patient is doing well. The take-home message is you come out from the operation theater only when you find 0 talar tilt. Work till you find talar tilt or talar shift. If your talus is unstable, don't come out from the OT. And it means you are missing something, fix all the components of the injury. So this is the overall take-home message from the case. Thank you so much. Thank you, panelists and the audience. Thank you.
Thank you, thank you.
Dr. John Mukhopadhyay, please, with calcaneus malunion.
I'm going to try to get through a few more cases, maybe with little less detail, but again, this basic preparation's been made by Dr. Venkatraman, but I've added some cases of my own. And we all know that calcaneal malunions are a problem and lead to various issues, including deformity, broadening of the and loss of heel height, impingement, as well as problems with the heel pad and maybe even neurological problems. Okay, and I think the management remains controversial, especially in the initial part when they come to you 3 or 4 months down the line. When they come much later with symptoms and with problems of deformity, it's pretty clear what you have to do. So we'll start with the first case. This is an 18-year-old female with a 1-year-old calcaneal malunion with lateral sided pain, peroneal impingement, fibular pain, subtalar movements restricted but not painful, and there's the heel in valgus. Okay, so those are the pre-op x-rays. You can see the lateral that the heel is in valgus, and you measure the angles and you find that there is obviously a valgus angle of the heel. Okay, We would always do CT scans in this, and you can see the lateral bump there. So how would you deal with it? Yeah, Rama, since you're the foot and ankle guy here, we're going to concentrate on you.
Yes, sir. There are 2-3 problems here. One is the heel broadening because of the the lateral part has gone up and then causing that subfibular impingement and pain, and also the joint is arthritic and the heel height is reduced. So we have to get rid of the lateral bump there, so that will reduce the subfibular pain, and the heel height is reduced, so we have to have the subtalar fusion, probably the distraction subtalar fusion, and then at the same time we try to correct the heel valgus.
Okay. So she didn't complain of much pain. So the surgeon decided that just removing the bump and then osteotomy to correct the valgus was enough. So that was the plan. So valgus deformity correction with exhaustostectomy, and so that's what he did. He used a screw to fix the osteotomy, where he got it back into the neutral position, and he just took off the bump on the lateral side. So what do you think of that? Do you have to fuse all these cases?
We have to fuse because all these cases are mostly Sander 2-3. So there is a definitely intra-articular involvement is there. So if we don't do the subtalar fusion, they may end up in again having pain and then coming back with subtalar
Girish,
pain.
you want to comment on that? Because
the patient will definitely require the second surgery. Because a calcaneal fracture malunion, the source of pain is lateral wall, the source of pain is peroneal tendon impingement, it is subtalar arthritis, and more than that, if you see the future of a 19-year-old girl, look at the talus. It's a horizontal, sir. So because the bowler angle is lost, the posterior facet is lost, it is depressed, the talus is horizontal. He has lost the declination angle. So because of the loss of the talar declination, the talus is horizontal and it creates ankle pain.
so you would do something prophylactically, even if the patient did not have pain at this stage?
Absolutely, sir. Because if you are taking this patient for the surgery, at the end of 1 year, when you find so much of the bad, the posterior facet, I follow the Ramakant, sir, that I'll do the subtalar fusion, distraction block. I'll put a graft to make the talar inclination, plus what the surgeon has done, exhaustectomy and the valgus correction.
So I think that's what they've done in the next case, but in this case they decided not to fuse the subtalar joint. So the next case is one that is much more common, where you see the heel in varus with broadening, subfibular impingement, and subtalar movements painful and restricted. This is a 32-year-old male who had a 3-year-old injury. And those are the pre-op x-rays. You can see that there is a clear varus of the heel. The CT scans, which are not all the images that I would do, but you don't see the subtalar joint, but you can see that reasonably well in these images, that the subtalar joint is pretty badly destroyed. So I think here what they did was more or less everything that you said, which is remove the exostosis, correct the varus, do a TA lengthening, as well as a subtalar arthrodesis. Okay.
I have a point to make, sir. So, Dr. Girish, can you add on to the my query? So, whenever we have that medial side, some kind of comminution and the large the sustentaculum tali fragment being fractured, so there are some impingement of the nerves and the FHL tendon. So, how often do you approach medially also in some of these comminuted malunion cases? Is it required?
So that is the rare incidences when you find the involvement of the medial tendons or the medial neurovascular pain. So it's called checkering deformity when you find a grade 2 problem. So it could be, it can lead to the FHL tendinitis, FHL contracture, and sometimes, like I have done 12 cases of checkering deformity of a calcaneal fracture, where you find that it's like a Volkmann ischemia. So when you extend the ankle, when you do the dorsiflexion of the ankle, you find a great toe going into the flexion, it is non-correctable. But when you do the plantar flexion, you find that the great toe is extended. So in such cases, you do the FHL lengthening. So this is the only tendon problem I have seen in the calcaneal fracture.
So you can also rarely have a tarsal tunnel syndrome kind of situation, and so that's something you'd probably have to do EMG and NCS studies to diagnose, and then you would have to approach the medial side.
Yeah, few of the cases they have a tarsal tunnel also. Yeah, perfect.
So this is what they did. So they corrected the varus, and they did an osteotomy and a fusion. Okay, so we don't have the follow-ups, unfortunately. This is what they've got.
Having some impingement of the talus when walking.
Yeah, so unfortunately we don't have the follow-ups. This is what we've got here. So as I mentioned, these are cases which were there for the the workshop or the instructional course lectures from the Foot and Ankle Society. So this is another one. This is a 58-year-old male, 1-year-old injury, pain over the heel, difficulty in walking, clinically heel in varus with shortening and broadening. Okay, so now you can see the clinical picture there. You can see that the left, which is normal, is in valgus, the right is in varus, there's broadening of the heel height. And again, you would do your x-rays. So, not great x-rays, but that's what we have. And the CT scans. So what would you do here? The other panelists are welcome to speak up when they want to, please. I'm sorry, I'm concentrating on the foot and ankle guys.
This also looks somewhat similar to the previous case. The tendon Achilles is shortened because of the collapse there, and I think the articular surface is involved. So correcting the bump, correcting the arthritis, and also maybe a distraction which I have not seen or done.
Raj?
It's a similar plan, I said. So anything.
So what about TA lengthening? This is something which is more recent, where a lot of the foot and ankle surgeons like to do or lengthening of the gastroc or the TA depending on the kind of equinus they have. So what is your approach to that?
If it is a long-standing one, definitely the heel cord tightness is always there. But I have not done for the malunited calcaneal fractures, but other cases like Charcots and other things.
Yeah, exactly. So I've personally not actually done it for calcaneal malunions. So I was interested that in this case they did all that. They did.
But the one thing is there, John. The biomechanics of the foot will not get restored till the calcaneal tuberosity is brought down.
There's another foot and ankle guy here. I'm sorry.
Sorry, no, I'm sorry. I'm just a student of foot and ankle.
No.
So you still need to get the calcaneum down. So the problem with this is when you try to sometimes get the calcaneum, the tuberosity down, you sometimes are unable to do it. So that's why you can actually, along with this, you sometimes end up. But the problem is, you can only do a TA lengthening before you start off. Once you've done all your body corrections and all you got, it's slightly difficult to then push, because most of us do a percutaneous unless you're doing a stress kind of a release in there.
So why can't you do after you've done it?
Well, the amount of pressure that you need to put to stretch the TA if you're doing a percutaneous release.
Really? It's actually quite simple to do it, but I mean, I've done it for other things. But
the only thing is putting the pressure and all after you've been doing it, because you need to stretch it on table.
Okay, take it. So this was what was done. Again, unfortunately, we don't have the follow-ups. I do have them for the next two cases because, so there are a few things in terms of the management that you need to do a thorough clinical examination for the source of pain. 3D is, CT scans with 3D have become like a common thing or a necessary thing for these. And you also do MRI for suspected nerve or soft tissue involvement. Okay, the classifications for these subtalar non-unions, I think there's this Adeen's classification which has been done by Dr. Rajiv Shah from Baroda, if I'm correct. And there is also the Zwipp and Ramelt radiological classification. So the Adines classification looks at these 6 points, whether there is subtalar arthritis or not, looks at the deformity, the exostosis, any implant-related issues, nerve issues, and the soft tissue injuries. So that would include the heel pad and the peroneal tendons. While the Zwipp and Ramelt classification is a radiological classification based on which are the joints involved, whether there is heel varus or not, whether there is translation without heel varus or not, the loss of the hindfoot height, and talar tilt and dorsiflexion, which is what Gurinder was referring to earlier. Okay, so that's something that you need to pay attention to. So this is one of my own cases. This was a patient who was 1 year past his injury, and he came to us with those x-rays. These include comparative views, which I tend to still do, although people say it's not necessary anymore. You do the Broden's view to look at the joint. This is the x-rays, but today with the CTs probably becomes less important. You can see the deformity there, you can see the exostosis there, and you can see the heel varus. So what we did was, again, so we used the extensile approach. That's something which, what approach do you guys use for these?
For the malunion, the ideal approach is lateral extensile.
Yeah.
Because you can see all the components of the
Exactly,
deformity.
and to get rid of that entire exostosis, you really need that.
So lateral extensile is ideal, but for the
simple fusions,
for
you
the
don't need.
for the simple fusion, or when you don't have to do lot of lateral exostosis or heel valgus varus correction, a modified sinus tarsi approach where you just make a curve posteriorly can also serve the purpose.
So,
but ideal is lateral extensile.
So here, so what we did was we took off the entire exostosis. You can see that being nibbled off. That's the end of the exostosis correction. Now the fibula and the peroneal tendons are relatively free. Then you do your osteotomy. Here we used staples. So you put a shank screw into the heel, you correct it, and then put staples inside. And then you do a fusion of the subtalar joint. So that's what we did. And that was the post-op images intra-op. The post-op x-rays, initially we tend to still keep them in a cast for 4 to 6 weeks. Start mobilizing them after that. This is the follow-up x-ray. So Gurinder, is that inclination okay there, or you're still worried about that?
So I think you managed to get the calcaneum down quite well. The tail has definitely got much better declination. Don't tell me one thing. Most people would put a screw from the back area, from the...
Yeah, so I put one from the back and one from the front because of those staples. So.
Oh, right. Oh, staples were getting in the way. Okay.
They were getting in the way.
But otherwise, I think you managed to get the wrist. Is the heel still in slight amount of varus? I think this heel is still in some amount of varus, I guess.
Well, maybe, I don't know. But enough. He was able to walk okay. That's his movement and his gait. So he was able to walk pretty normally at the end of all that. This is about a 1.5 year follow-up after the initial surgery. Okay, and then the one last case. This is the situation where you really don't know what to do is when the patients come to you 3 or 4 months after the injury, and you find that there is a clear-cut problem on the x-rays and the CT scan. I'm sure the x-rays are here. Okay. So those are the CT scans. So Rama, what would you do here? You want to see the x-rays? They're there.
This is 4 months old, right?
Yeah. 1 month in a cast and 3 months after that. So this was this difficult problem for us which we've been dealing with, where you treat them conservatively, you give them injections. So then we started doing this intra-articular osteotomies on them and getting this, because you see there's almost a vertical line of the articular surface of the calcaneum. So that's what we did. So that was the fragment we wanted to rotate. So again, the extensile approach, you do the exostectomy, and then you actually take out this piece, okay? So you do an osteotomy, you get this piece out, and you can see even at 4 months, the articular surface is fairly clearly visible. and then you turn it round, you put your lag screws. Today we just use the bone we take out from the exostosis as graft, but this particular case we used corticocancellous bone graft from the iliac crest. We put the plate on. That's the immediate post-op X-ray. That's the X-ray at 1 year, 4 months. And this is him at 5 years, 5 months post-op, okay? So you can see, if you look at the lateral X-ray, the subtalar joint is still pretty good, okay? So you're able to salvage the subtalar joint in these situations where otherwise you would end up fusing it 1 year later or something like that. So we've now done quite a few of these, and we actually published this recently in Indian Journal of Orthopedics. And so we got, in the comments we got from the reviewers, why so few cases? We had 10 cases and they said, why so few cases? So obviously I told them that this is the biggest series that there is in the world, so how can we get more cases? So that was what happened eventually. So I think that's the basic gist of the talk. I think you need to look at your patients carefully, assess them clinically, get the appropriate X-rays and CT scans and MRIs. I think the silver scale test to judge TA tightness is becoming increasingly more important in the foot and ankle surgeons literature. They seem to do it for everything, but I'm still a little sort of not clear about which cases really need them. And you do the appropriate X-rays and MRI for any neurological problems that you might have. Thank you very much. Okay.
It's a very well done case, sir. So one last question. What is your cutoff time duration, whether to do that?
Yeah, so that's a real tough question. So the latest we've done it is 1 year, but I think that's really stretching it a bit. Because when we took out that piece, it was like the articular cartilage was beginning to get rough and things like that. So we did that. He did clinically reasonably well, but he doesn't have any subtalar motion. Okay? So I think probably up to about 5 or 6 months you're still okay, but you have to pick on the cases. You can't do it for the type 3, type 4 Sanders. You have to do it in type 1, type 2, where you have a clear depression of the articular surface. So I think if it's very comminuted, then you're wasting your time.
It's always worthwhile saving the subtalar joint.
Yeah, exactly, yeah. So if you can save it, and we've got a 7-year follow-up and he's still doing well. So I don't have that X-ray with me, but he's still doing well. Yeah, okay. So we've got now a fair amount. So in the article we've shown 2 or 3 cases, but we've got 10 cases we've done so far, including one which was 1 year down the line, which clinically did reasonably well, but I think that is stretching it a bit. Okay. Thanks. Great. Thank you very much.
Girish, one quick question to your case that you showed. It's not your case, obviously, but that fibula oblique with that syndesmotic injury, but probably wasn't too much displaced from the X-ray. I mean, even if you're at 10 days, a shortened fibula in that situation, it's a hell of a job to get it reduced. So, in the way that post-op X-rays, leg screws and plate put in with that, I think probably the reduction must have been not so difficult, because if you see a fresh fracture, you wait 10 days, everything is so tight at the back. So, we're talking of structures are quite distinct. So, I was just wondering.
No, I mean, I also agree to you that this patient, it didn't require...
It's like an easy malunion to show, that's what I thought.
Yeah. So if it is too much shortening, sir, you need this kind of, lengthening and all. But if it is just a spiral oblique, Weber-Beek routine fracture...
But even with that, you really have to dissect everything out, hell of a thing, at 3.5 months, it's a lot of soft tissue.
It unites, sir. I mean, the fibula...
No, fibula will unite, but the soft tissue disruption that you will create going in to do that, I know the outcome is really good, but I just wondered if you had a displaced fracture with everything.
So more time, more soft tissue mobilization. Less time you don't require. Just bony osteotomy and refreshening, it makes your job easy. John sir, just addressing your point
other question, one quick question. Yes. Very often we talk of a reduced ankle, and that's why everything looks not so displaced. But we don't need to take into consideration what the initial displacement was, and then we misjudge the injury.
Yes. Yeah. John sir, your point was, your question was when to add TA for the calcaneal fracture malunion. So why the foot and ankle surgeons, they do well, they do these things. If it is too much varus or if it is too much valgus, the TA is short. Plus it is the shortening of the calcaneum. The fracture morphology is shortening of a calcaneum. You make the hind foot lengthen. Plus you correct varus or valgus, whatever. So both, they actually stretches your TA too tight. I mean, if you do the TA, you don't have to add the osteotomy to correct varus, like you did in one of your case where you put a staples.
Yeah.
So fusion and osteotomy, this combination is rare. If you are making the subtalar joint free while doing a joint preparation for the subtalar fusion, you can bring the subtalar into neutral, valgus or varus, wherever you want, if your TA is relaxed. So adding osteotomy.
But the varus is in the heel. So the calcaneum is bowed this way.
Yeah.
So how do you correct that?
So that's what I'm saying.
Even a TA lengthening
Yeah.
will not correct that 1 year down the line.
So when you put a graft, you have to put a graft medially.
Okay, so then you have to graft the other side.
Yeah, yeah,
So that's
yeah.
the trade-off. Na?
Yeah. Usually you need a graft. I mean, in the calcaneal fracture malunion,
Yeah, but that you can put in the subtalar joint.
in the subtalar joint
Yeah.
to correct the varus.
Yeah. Okay, great.
Okay, thank you.
Thank you very much. So there was one thing which I wanted to say is, are we taking this medial ligament concept a bit too far? Because if you look at traditionally, long time ago, people used to repair the medial collateral ligament or the deltoid ligament, and then they stopped doing it altogether. And now there's a resurgence of people doing it, and I've done it a couple of times, but it's still very rare in my practice to have to go open the medial side. So I'm just a little, I think maybe it's going too far on the other side of the scale now.
So, sir, that you are absolutely right that the deltoid ligament reconstruction or the repair, this concept is since last 10 years only. And now the people have less threshold to open the deltoid. The reason is, if it is unstable, I mean, the same X-ray, medial increase in the medial clear space, to make it stable, you cannot accept the talar tilt on the stress X-ray inside the operation theatre. So to make the deltoid stable or the medial clear space stable, what you do is you put a syndesmotic screw. That is a surrogate fixation. You don't, the controversy is whether to open and repair the deltoid or to put syndesmotic screw and let the deltoid heal by itself. That is the query. So if you follow these patients for a long time, now we have a 14 years data, now it is published. The people, the patients who were treated by surrogate fixation, they have started creating a flat foot deformity, overpronation. And then they realized that actually the repair of the deltoid was done by fibrosis, which was not a good tissue. The deltoid is a very tight structure. So it is healed by the fibrosis, and which is actually given the overpronation at the level of ankle. So a significant number of the patients, they found almost 45% of the patients, they were overpronated or they were flat foot.
So we've done a lot of these late osteotomies similar, where once you fix the syndesmosis, then the clear space disappears. And you can't even stress, they are stable in valgus. So what do you do there? Do you still open the medial side, or do you?
So I don't do the syndesmosis.
So you open the medial side.
We open the medial side.
Okay.
So that's what.
Then
if
you avoid putting the screw.
Yeah.
Okay.
Because, sir, anyway you are doing a surrogate fixation, you are allowing a deltoid to heal by fibrosis. That's the one problem.
But you're assuming the deltoid is gone every time there's an opening of the medial side.
If there is a talar tilt, as I said, if the deep deltoid is intact, it doesn't allow even 1 mm of shift of the talus. So if there is an increase in the clear space, it has to be the deltoid ligament injury, 100%.
But that goes against what people talked about, the syndesmosis causing the problem.
Yeah. So it is 100% deltoid plus minus syndesmosis.
Okay.
Yeah.
Yes, I have just two questions. One regarding the tendo-Achilles lengthening. So in most of my cases where I have a malunion calcaneum, I almost always do the TA lengthening. So yes, so what's your preference? Is it percutaneous or the striatus? What's the consensus?
I really do the TA lengthening in calcaneal fracture malunion. rarely. But this is like the concept behind doing a TA lengthening, because most of the time my fixation and after doing a deformity correction, my ankle dorsiflexion is reasonable. I rarely require it, but I have done in some of my cases. But if you need TA lengthening, it's better to do by stairs, because the TA was not tight from beginning. It was tight after the fracture. So it's actually the gastrocnemius involvement more than a soleus. So let's do the stairs only.
No, I think that you can decide clinically.
Yes.
Because if with the knee flexed you can get the ankle up, then you know that the soleus is okay.
Perfect, yeah.
It's the gastrocnemius
So
that's
pre-operatively you should know that whether it is tight, whether you require it or not, and what should be your procedure, stairs or the percutaneous TA.
So that is dependent on the pre-op clinical assessment.
Usually it is
not on-
stairs. Usually it is a gastroc involvement only.
So it's like in CP.
Yeah.
You will not do a TA lengthening unless it's absolutely necessary. You will do a stairs or similar gastroc
For
lengthening.
the long-standing deformities, the TA is involved. See, this is a deformity since 10 years.
Yes,
Flat
malunion
foot.
and long-standing ones.
Yeah.
Like
So-
you said, where the varus and
I think
pelvis is significantly
we'll conclude here
more
because. Yeah. Okay. So we can start the next session.
Thank you so much for this wonderful session. We appreciate you sharing your time and knowledge with us. Now moving on to the next session, I would request the chairperson, Dr. Amia Bera, Dr. P.K. Pujari, Dr. Kushal Nag, Dr. John Mukhopadhyay. I request the chairperson to invite their speakers.
Okay, so we go on to the next session, which is on Miss Lisfranc and infections. And the first speaker is Dr. Saura Shekhar Saha.
Good morning, everyone. So this is a case on Miss Lisfranc. So just to get the background, this latest data says that 20% of Lisfranc goes undetected. So we should maintain a very high index of clinical suspicion. So the investigations of choice presently are weight-bearing X-ray, CT scan, MRI. So I would like to ask the panel, what about stress X-rays? What's the consensus? Bera sir?
Sorry? Yes?
I mean, do you always go for a stress X-ray if you suspect a Lisfranc injury?
So I'd say first clinical. Clinically, you can see whenever there is high suspicion with the swelling, the tenderness, as well as the hematoma in the sole, then always go for the stress X-ray, of course.
Stress X-rays.
Other thing is that with the CT available, I nowadays more opt for CT.
Always CT, sir, if you suspect?
No, it's a first stress X-ray, then go for CT.
Anything else?
I have a point on this. It's good to do a stress X-ray, but the limiting factor here is your infrastructure. Do you have a mini CM or a CM in your OPD? Otherwise, it's very difficult to take the patient to the OT and do a stress X-ray and figure out. And if you leave it to the technician, they will screw it up. So
or may I ask it otherwise? If
we
you
used
have
to
a
do
CT,
it in our fellowship days, but right now it can be done. It's a bit difficult in our OPD setting.
or if I may ask you otherwise, if you get a CT, do you need a stress X-ray?
No, I don't think so. I wouldn't do that.
I think that
painful,
there is
painful,
several subluxations which are only revealed on the stress X-ray. So it is in my clinic there is beside there is a X-ray technician. I always talk to them, like over the phone, direct him, so that some stress he can give.
Okay.
But that may not be adequate. In that case, CT I do.
So in the old cases, we always get weight-bearing X-rays. So yeah,
So ideal would be a weight-bearing CT.
Yes, that's what we have said, that the future is a weight-bearing CT, but well, that's the lacuna.
Weight-bearing CT, or because we don't have that in
We don't
Kolkata
have that.
at least now.
It's not that widespread now. Yeah. So the clinical presentation generally is either a high or a low energy injury where there is a longitudinal force with the angle in plantar flexion. So the foot deformities may be there is a pain, there is a swelling, inability to walk, rarely open injuries, and then this is the flex sign. Just we all of us know about this, but just to elucidate the classical flex sign of Lisfranc. This is the avulsion fracture. And there are also sometimes the subtle Lisfranc injuries which are low energy ones, mostly go undirected, and Mostly people do a POP followed by pain on weight bearing and then they realize about it. So in these cases, the patient may come to the OPD walking. So in subtle Lisfranc injuries, plantar ecchymosis is almost always there. There is a TMTJ tenderness and provocative test, that is the passive abduction pronation, is generally painful. So there is also the piano key test, which is classically described, but is it done in the, do you guys do it in the clinic?
No. Patients don't like it.
That's too painful. Really, that's difficult for me.
One more message I think with Choro you need to think is most of these patients who come with a Lisfranc, they usually report an ankle sprain. That's what they say. And in the ER, the X-ray taken is an ankle X-ray. Foot is never examined or even X-rayed. That's also why you miss it.
So I would do a clinical, the piano key test only if I can't see it obviously on the X-ray, etc.
Okay.
Yeah.
Okay. Okay, that's a fair point. Okay, so then the weight bearing X-rays are done to see the diastasis, and finally, if we have it in future, the weight bearing CTs. So further investigation is the CT, which evaluates the extent of bony disruption and help us plan surgically. And the MRI is to evaluate the ligament or tear and the joint condition. So coming to the case, this is not my case, this is Dr. Kishore Duda's case. It's being presented everywhere, in all the IFAS meetings together, so I have it with me now. So this is a female, 45 years, fresh injury, twisting injury. On examination, there is a tenderness on the midfoot, medial aspect and dorsal aspect of the foot, and there is edema, and ROM is painful. So let us start with, Dr. Kushalda. What's the first thing you would plan for?
How old is this? Old is the injury?
Fresh one.
Fresh one.
Yes.
No? So obviously I'll get a CT to figure out are there any associated fractures with this. It's very obvious Lisfranc injury. And do the radiological workup, and obviously this needs to be fixed because there's a very visible gap in the first web space there. And let the swelling subside, ice it, wait for a few days maybe. Look at if she has any other comorbidities, diabetic maybe, she's 45, could be. Look at other comorbidities, reduce the swelling, and then plan for a fixation.
Okay. So anything you would like to add, sir?
You of course do the CT. So you can see there is medial to the navicular some opacity, some flex of bones is there. So I have to look the tarsal bones, all the tarsal bones.
No, so there's a dislocation of the first.
Yes, navicular cuneiform.
Yeah.
Yes, navicular cuneiform with the fracture. Of course, to see the fracture geometry and other bones involved, I do first do the CT, then plan my operation at least. Okay.
Well, despite whatever is being said now, unfortunately, the management done was casting for 6 weeks and then non-weight bearing. So finally, we have, after 6 weeks, the patient is having pain and swelling over the foot, and it's very difficult for her to weight bear. So this is the present scenario now. I think the thing is very clear now. So Girish, anything you would like to comment now?
Understanding the injury is very important. Look at the shortening of the great toe.
Quite a lot.
Quite a lot. This
and the intercuneiform ligament also seems
absolutely
to be gone.
So this is actually it is not only the Lisfranc injury, it is not only the disruption of the tarsometatarsal joint, it is a disruption of the intercuneiform joint also, it is a disruption of the navicular cuneiform joint also. So this is a very unstable injury, having all these three components of the injury. If I want to, definitely the CT scan is important to look for the overall picture, but not for the diagnosis. This is clear-cut a case for the fixation. I will start my fixation with the reduction first. So what I'll do is, I'll do the intercuneiform reduction first. I'll put a shunt pin or the K wires into the metatarsal, into the talus, and will distract the medial column. Once I get the reduction or the length of the medial column, after mobilizing the cuneiform, NC joint and the TMT joint, I'll start fixing with the Lisfranc second TMT, and then I'll put a long plate from navicular to the first metatarsal medially.
So this is
Okay.
Now or at that initial stage?
Initial
now-
for now we need a fusion
This is
with the same
week,
technique.
6
with
weeks
the-
now.
Yeah.
6 weeks now.
6 weeks fusion, 100%. Fusion.
This is very
Okay.
difficult to me. So with such a shortening to go for plaster, that's very difficult.
Yeah. 20% of the time it is
So
missed.
who went for plaster? We don't
Most
know.
of the cases come to us at 6 weeks. And I don't fuse at 6 weeks. I think there's a window for us to reconstruct and preserve the joint. There's a window for us to preserve the joint. A CT would definitely help assess the joint condition. And I think this is reconstructible.
So, but what would you lose by fusing this at this? How much movement do you have at that joint?
No, fusing is not a big deal. You can fuse the medial column and the intermediate column. That's not a big deal. But I would like to preserve it if it can be preserved. It's just a simple.
I would like to summarize. Girish, you would fuse
100%.
at 6 weeks.
100%.
The first ray and the second ray.
First ray and the second ray,
Second
yes.
ray. Okay. Sir, what about you? What's your consensus now?
I will rather fuse it.
Fuse it. First ray, second ray, or just the first ray and
First ray.
and reduce the second ray and
Reduce
just
the second ray, put a K-wire or something.
okay. Kushalda?
I would like to know from all the ankle foot guys, they are masters. You fuse very often. You fuse the joints very often. So that causes some degree of loss of movement. With the rural people where they are walking in rough surface, that's I think the joint, other joints load station.
Sir,
So
45
by
year
6
female,
weeks, it's not too early because John has shown that in Calcaneal, we have done even that's very difficult. So that's I think that burn my many time. Okay.
So the way I'd look at it is that at that joint there's actually very little movement as it is. No, agreed. I'm not saying no, but so if it gets reconstructed easily, but I think it's unlikely that you will not have to take off the articular cartilage in this situation to fuse this, because this is slightly different from the calcaneal malunions that I showed.
Sir, if you miss the Lisfranc injury, the chances of having post-traumatic arthritis, if you miss the Lisfranc injury, allow the dislocation to remain for more than 4 weeks, the chances of having a post-traumatic arthritis is 80 to 90%.
With the deformity.
Because they are not a synovial joints, they are not a ball and socket joints, they are the hinge joints. So the John sir is absolutely right that on first day if you are getting this patient, definitely the open reduction, interfixation, length and everything without fusion should be the treatment of choice. And there are the 100 of the foot and ankle surgeon who will fuse on day 1 also. But we are not going for that debate. We are going for the gold standard.
Especially the American ones.
American ones, yeah.
It.
Okay, but now at the 6 weeks, this will definitely going to create arthritis, even though you realign them. And there is very less movement. What is a mobile column is 4th and 5th. First and second are there less mobile, and the God has made first, second, and the third column for transferring the weight, not for movements.
True.
Not for movements. So your dorsiflexion, plantar flexion will be full. Your rural patient will do the farming job. You can run, dance, jump. But it's a career-ending injury only for the soccer players, the high-level national players. It's a career-ending injury.
So, sir, John sir, fuse? Fuse.
Let's put it.
I would disagree.
Ramakant sir, what about you? Fuse? 6 weeks. Lisfranc still?
Yeah, definitely fuse. Fusion is the option.
Only the first ray or the first and the second?
First, second. And third seems to be okay, yeah. First and second.
Most of the comments.
Okay. So unfortunately, again something different happened. This is what happened. So the second ray was, plate was put, joint spanning plate, and the home run screw was put. So I think, if I may say, the intercuneiform joint seems to have been reduced. I mean, not perfectly, but more or less. But the Lisfranc is still quite open. So this is at 4 months. So now what?
So no CT was done for this case?
No. We don't have CT yet. So this is not my case, so can't comment on that. So we have to base our discussion on this.
Now
This is the situation.
Either day 1 or any other exit, that is not reduced. Still the navicular and the cuneiform is not reduced. Was it reduced at all earlier? No, you have no X-ray.
NC joint is not reduced.
That is not reduced in this X-ray, right? Navicular cuneiform. Got the point?
So that's not completely reduced. So
Yeah, and that is
this
already
shows-
irregular.
Was it reduced at all in the
No.
Never.
No. So now I think I think. So I think we have already discussed this, that this is not what any of us had planned for. So this would not have been done. I mean, if you were the surgeons. So finally, what now? Now what would you like to do? How to salvage?
Reduce the.
What are the symptoms of the, what is the patient saying?
Symptom is again the same thing: pain while walking and difficulty in ranging.
Difficulty in?
Ranging.
Okay.
Of course, the other joints will also have pain. So you have to look for other joints also, because by that time it's also 4 months. So other joints will have also changed with this kind of displacement. So after the localizing the pain, you must reduce the navicular cuneiform joint and fuse it, of course.
So
along with the
you would fuse the joint, but would you try to get length back?
100%, sir. We
So you
should
put
get
a graft and then
100%, because if you allow to heal everything fusion in this position, this patient will develop a cavo-varus deformity. So if he'll start walking on the lateral border, it is even more painful than arthritis.
So now remove all the implants and again redo the whole thing, or focus on the first ray and try to salvage?
No.
to remove the implants to get it reduced.
Okay, so
At least the screw, yeah.
So finally, I think that was done, revision surgery with a proper fusion. The implants were removed, bone grafting done, all gaps closed. Here you can see the intercuneiform thing which we are talking about, that has been reduced, and the fusion has been done. So after this, the patient is doing well. So firstly, I would like to ask for fusion, Lisfranc fusion, is this your implant of choice? We can start with the panel.
Depends on what you're
I mean the
comfortable with.
plate and home run screw, or just the plate?
Depends on what your plan is. It is no rigid sort of a guideline ki yahi karna hai karke. It depends on what you're fusing, what your plan is. Are you maintaining the length? The length is still shortened here. You know,
There's still
I would
quite
use
a lot of
implant.
shortening here.
Yes, I would use the implant, but I mean, depends on the merits of the case. कि क्या use करना है करके.
John sir?
Yeah, so I have not used this plate, so I can't say I will use this plate. So I would go for fusion, but
And these are 3.5 non-variable screws. Very
yes,
difficult
you
to
can
align
use
them.
whatever helps you get all those joints fused. Yeah, so you need to put screws across plus plates across those two joints. Yeah.
So Girish, anything different you would have done in this?
Yeah, I agree to Kushal sir that there is no fixed guideline. The principles are the implant should be low profile, it should not be more than 2.7 mm. So these are the principles that you need to follow for the all midfoot fusions. But I have used this plate, this works well for ORIF. Fusion also I have used this plate, but now we have shifted to more low profile plate, 2.7 mm, medially. So if I want to do the fusion of a medial column and the middle column, I put one plate on the medial surface, which is a workhorse approach for me, and one on the dorsal surface of the second TMT with one intercuneiform screw.
Okay.
And I think the length is not really restored. Right?
Absolutely.
So that's another
Yes,
thing.
length is not restored, so the naviculo-cuneiform joint doesn't look
It
good.
should be the part of fusion, yes.
So this is the follow-up. And the comparison views were done, and seems to be, I mean the patient seems to be satisfied. So the ranging and motion, everything is, patient is, I mean, managing well.
This patient will definitely require the NC fusion after 7-8 years, 10 years, 100%.
Or maybe earlier. Maybe. So quick comments on the controversies now. Now, does KOR still have a role in the column fixations in the present scenario when we already have low profile implants, home run screws and stuff like that? What's your opinion, sir?
Open reduction and stabilization, then yeah, K-wire and plaster for some time is important. Okay. We can still go ahead with that.
Okay. Kushalda?
Only for open injuries.
Yeah, so I wouldn't use it for the medial column for sure. Today, we would go for more sturdy implants, screws or plates or combinations.
Okay.
And maybe in poor skin condition, you may decide on KYs, but not otherwise.
Poor skin condition, I will wait and hope it improves.
For the
Only
medial,
for open injuries, middle
for the
column,
medial
only I will
definitely
wait.
the screws. For the lateral with in early stage to save the joint movement. So I'll put the KVR and remove it after earlier. Okay, of course.
So nowadays people generally go for KVRs in poor skin condition, compartment syndrome, etc. as a temporary fixation and move on to the sturdy ones later on. So now the controversies. Firstly, the controversy is that the fix or fuse the medial TMT joints. I mean, in this case, I think we all agree that fusion.
No, I don't agree. I wouldn't fuse it.
Not
6 weeks, casted, not walking, I wouldn't fuse it. I would give it a chance.
Ramakant sir, what about you?
Why the 3 joints? Because the third joint is relatively uninvolved in this particular case.
In general, I mean, in old cases, in general, the question is that.
So your question is for the acute.
Question is for the old missed Lisfrancs. Do you fix or fuse the medial?
No, always
three
fuse.
TMT joints?
Always fuse. There
All
is no,
three?
No, first 3.
Second.
First
Yes.
3. If it is third is involved, then we fuse. If only the first and second is involved, invariably in all cases first and second will be involved. It is the combo.
Of
So
course.
definitely first and second has to be fused. Third, depending on the whether it is involved or not.
So first 2 fuse for sure.
First 2 fuse
Third
for
one,
sure. Third
yes
one
or
is
no?
optional if it is involved. There is a subluxation where we see that cortical continuous line is not there in the oblique view.
But
based
in the
on
old
that.
cases, what I tend to see is that after you reduce the first 2 days, the third one still stays a bit off, which is not visible in the initial x-rays, but on table, when the first 2 days I have fused it, I mean the first 2 TMT joints I have fused it, the third one seems a bit distracted. Then I have to again clear up and fuse it.
This
Yeah,
has
it
happened to
means
me.
that it has
This
involved
has happened to me,
previously.
and I realized that my first 2 days reduction was not proper.
Okay.
If you see, it's like a Lego block, right? Everything will fit
A rigid
perfectly.
Lego
If
block,
you do
yes.
it right.
Yes.
If you don't do it right, something or the other will be off.
Okay. And the last question, I mean, this I think the most burning question worldwide. Transarticular screws still to be used or only joint sparing plates?
My boss used to say, if you have a knee dislocation or an ankle dislocation, would you put a screw through the knee joint?
So
I also
what's your
maybe imbibe his philosophy. I would put a transarticular screw.
transarticular screw?
Yeah.
Still there?
Sorry.
No.
Joint sparing screw. Sorry. Joint sparing implant.
Joint sparing.
Yes.
No transarticular
No
screws.
transarticular.
Okay, John sir?
So we still use that screw, home run
The
screw.
home run screw.
Yeah.
Girish? The second point.
fresh cases,
Transarticular screws still you use or just the joint sparing dorsal plates?
Transarticular means the Lisfranc screw.
Oh, home run screw, yes. Lisfranc screw.
No, I mean
No. Not at all?
4-hole plate, low profile, 2.7 mm.
Not at all? No home run screws anymore?
Rarely when I want to spare the first TMT. If my subluxation is at second TMT, only at the second TMT, which you show in one of the X-ray
Yes.
in your theoretical part. So only that case where the second TMT is involved, I put one dorsal plate and a home run screw.
Okay, got it. Ramakant sir?
Dorsal plate, no transarticular screw.
Okay. So that's about it. Thank you so much. Thank you for the wonderful discussion. Thank you.
Thank you very much.
Now it's Ramakant Gopal Krishnan, please. Infection and osteomyelitis around ankle. Magic.
First, I would like to thank Dr. Abhijit for giving me this opportunity and also IFAS. So, I will be presenting few of the barrage of cases of foot and ankle infection. The infection is always with a combo of osteomyelitis, especially in the foot and ankle. It's not only the joint is involved, but also the amount of bone is also involved. So this is the first case, 28-year-old male patient with this X-ray picture shows scalloping osteolytic areas in the calcaneum, and the subtalar joint is not exactly visible because of the bone destruction, and almost pain for 2 to 3 months presentation. He had some trivial injury, but he doesn't know what was the injury. So we had taken the MRI. This is his clinical, the MRI picture showing the area of destruction and also the signal in the MRI. So these are the pictures. So first, can you tell, sir, apart from the routine blood investigation and these things, what should be the plan for this patient and what could be the approach?
I'll look for the infective organism. So I'll go for curettage and take the material and see whether it's tuberculous or septic or whatever, fungal, whatever.
Okay. So what would just debridement alone is sufficient, or you want to add something else?
Yeah, and if there is a big cavity and big space, I can put an antibiotic loaded cement or something.
Yes, sir. So anything different, sir? Next.
You can put stimulant in. You want to get a tissue diagnosis, I think is better. MRI will at most say there's an abscess or something. They will not point out the etiology or the bacterial diagnosis. Go in, curate, take out all the dirty stuff that you see, and come out with stimulant if you want to.
Stimulant, absorbable stimulant with.
And then you need to look at what articular cartilage is left. So if there's no articular cartilage left, then you might even go for a primary fusion in this situation. Okay, so that's one thing. And of course, local antibiotics would be a good choice, either stimulant or whichever one you prefer.
So I think I will, in this case, go for the first thing, stop the antibiotics, at least ensure that antibiotics stop for at least 10 days. Number one. Number two, CT. I would like to have the assess my subtalar joint, so that while doing the procedure, I will go for biopsy, CS as well as fusion or not. Okay. With all probability, there will be destruction. Oh, of course, there is destruction. So my aim will be to put the stimulant, thorough curettage, debridement, CS, biopsy, as well as the subtalar fusion also.
So looking at this CT, I might go for antibiotic, cement, block, and then do a fusion later, but depending on how bad the infection is.
So joints looks already obliterated. There is no joint there anyways. So
Yeah.
I think the safest option would be to just sort of say, put a bone block, put an antibiotic cement in and come out.
So the message is clear. You have this punched out lesion. You can see that CT, and there is an extensive amount of bone destruction, and there are multiple punched out lesion even the way up proximal to the talus. So as joints are rightly pointed out, radical debridement is definitely needed. And in this case, just as a filler of this after the debridement, and also for the elution of the antibiotic impregnated cement was inserted. So this can be a permanent solution as well. So we can live it off like that. So the antibiotics will elude from the cement and then go all the way. But what is needed is the radical debridement. The infected granulation tissue has to be removed. That is the primary importance. And this is the 1.5 year follow-up of the same patient with the cement intact. And this is his clinical pictures. He is able to walk pain-free, and since he doesn't have any symptoms, or he doesn't want the cement to get removed because he doesn't have any recurrence of infection or anything, so he was left alone.
उसका एक ही प्रॉब्लम होगा, he has a virus of the
some virus is there, right? Yeah.
बाद में शायद we might need some.
So would you not like to, as ankle foot surgeon, to do something with the virus? When will you like to? When will you like to? When will you like to?
We will burn our hands now. So, not to do anything now.
Culture was Staph aureus in this case. So and it was given the antibiotics according to the culture report.
So one of the only problems with something like this, which we've had some experience with, is that 3 or 4 years down the line, that cement block is now working like a foreign body. And if you have any source of infection left by any chance, then that recurs and then you end up having to take out everything and fuse the joint. So that's something you should
That's
do.
why I shifted from cement block to stimulon. It's easier that it gets absorbed. Yeah, this is too big a block. Yeah, because it acts like a foreign body. Once the antibiotic is leached out, it's just a spacer.
Yes.
Sometimes it can.
So that was the infection in the calcaneum and the subtalar region. It's a similar case. 48-year-old male, again with some trivial injury, he doesn't know, but there is a collapse at the TMT joint and there is a destruction of the cuneiform, the intermediate cuneiform and the lateral cuneiform and part of the medial cuneiform. So does your approach anything differ from
Get
the
an MRI.
first?
An MRI will show you the full picture of how many bones are involved, what is the extent of involvement. It helps you plan your next step.
So the MRI had that destruction of the signals from all the 3 cuneiforms.
वो होने ही वाला है, देख के लग रहा है. If you ask me, what is the profession of the person? What does he do? The guy?
He's just a normal sedentary worker, nothing of sports or any high demand patient.
You may still try to preserve the food if you want to in these cases, but it's going to be a tough job. Very tough job. Open sinus nahi, no open sinus is nothing.
No
just
sinus.
a closed thing. So why did he come to you for pain?
Pain and swelling, and it was just 2 months of history.
No
He had a
injury,
severe
nothing.
pain. So these infection in foot, they have very severe pain. Initially it starts with mild dull aching pain, but then when they come to us,
Is he a diabetic? Why did it happen?
Immunocompromised.
he's not a diabetic. He had some trivial injury because he works in that village and things like that. But he doesn't remember of any gross injury as such. But
So
mainly the pain.
Not a penetrating injury.
Sir?
That was not
Not
a
a
penetrating.
that he doesn't
Person
remember.
is bound to have some other problems, medical comorbidities or other identifiable cause, because 2 months only, such an extensive involvement, we should think for any other systemic causes.
Abscess was there, but very mild amount of the collection. It is not like that aggressive fulminant infection.
But he's not diabetic or anything.
Diabetic, so
He's not diabetic. He's not diabetic. He's that village type who walks maximum amount with the barefoot. So very common in our country, where the people don't have the footwear and they have some trivial injuries.
Figure out whether there is actually osteomyelitis or this is something else, because there's no clue why this is happening.
Yeah, you have to again go in, debride, take biopsies, cultures. And
So before
also-
debridement, do you do any aspiration or something from the?
You can do a CT cardiac aspiration provided the radiologist is confident he can aspirate some material.
Yeah, I think my sort of, it depends on who's doing the aspiration basically. So as we haven't had great results with aspiration for these, so we tend to go in, get the cultures directly, and also, but yes, aspiration is definitely a choice.
Yeah,
okay?
that is very important one, because most of this
Fungal cultures,
especially in
and
our part of world,
and also
south, we do
atypical
find the mother of foot.
Also
So
atypical mycobacteria, because if he's had a penetrating injury, that's a
that could be
possibility.
the reason. So the thorough radical debridement is the solution for any of the foot and ankle injury, foot and ankle infections. So try to get as much of devitalized bones, soft tissues, and then definitely we can fill it up like this.
Did
In
you do an
this,
aspiration?
the infection was still bit extend to the cuboid also.
So did you do an aspiration?
No, we knew that it was infection, so we didn't do it. But if you have doubts between the charcoal and this thing, definitely we can try for aspiration, and it's very subcutaneous, so it's there's no harm in that. There was an extensive infection, including the part of the cuboid. So the radical debridement, like what in like tumor surgeries. So we have gone there and then we have removed it. The entire the midfoot area where the the cuneiforms and the cuboid was filled with this kind of cement. And this is a 2.5 years follow-up. So with radical debridement and antibiotic impregnated cement, he was okay. And I think in this case, it was a mother of foot. So if you see his foot, the dark nature of it and all those things, but then it was appropriately treated with antibiotic for almost 2 months, 2.5 months.
Which antibiotic?
Antifungal, yes. According to the infectious disease specialist, I don't remember now, this was operated almost 5 years back. So this was his last follow-up of 2.5 years. He was able to walk comfortable. He doesn't want to get that cement removal. Because he is okay, he doesn't have any pain or this thing. He do have that TMT little bit of collapse, but he is tolerant. So cement can be the one-stop solution for this kind of fulminant infections. And this is another patient with dorsum of foot, again involving the TMT joint. This was a little bit of abscess also, we can see here extending. Again, this was done with the similar kind of picture, and this is a 1 year follow-up. The message is radical debridement. This is a 1 year follow-up, very comfortably walking. So mid-foot infections, the cement can be the good solution or one-stop solution. And this of the calcaneum and the calcaneal cuboid joint. So one case we had a problem with cementing of the calcaneum. He had the extrusion of cement, then causing the skin ulcer over there. So so we had to go and remove the cement, and then the wound went on to heal. So another interesting case, I'll tell, this is a trauma case. He presented with the open talar dislocation. This was treated initially outside. So there was no fracture, but just the medial side he had a talar dislocation. They underwent just skin debridement, and the talus was reduced, Steinman pin was put, and he was started walking after 3 months, but 3 weeks, but then he presented to us after 3 months with no issue of fever or discharge, but very severe pain. Patient was unable to walk without support. There was diffuse swelling, healed scar on the medial side. There was local warmth, and ankle was very tender, and the painful movement of the joints. The distal pulse were intact. So these are his X-ray. He had an open talar dislocation which was reduced, and Steinman pin was put for this patient, but he presented 3 months after the injury.
Do you have an ankle AP?
I have the ankle AP, yes.
So the talar dome is sclerotic, which suggests there's AVN, but yeah, it's AVN, and whether he's got infection is something that you have to decide clinically. And
so definitely we want to do CT and MRI. So the CT, we can see that there is a gross destruction not only on the talus but also on the distal tibia. There is a punched out lesions. There is here you can see that there is a track involving the calcaneum. So this open fracture has led to kind of infection of the calcaneum, the talus, and also the distal tibia.
So that's because of the Steinman pin rather than the open fracture.
Yes. So you can see that pus tracking out posteriorly to the tibia and also to the calcaneum and to the plantar aspect. So 3 months after open talar dislocation, this is the picture. So again, the treatment plan would be to radical debridement would be the treatment of choice. We have to get all the devitalized necrotic bones, and the CT we can see that there is some sequestrum within the 3 months surrounded by the infection granulation tissue, and the ESR CRP was very high, 122, and severe pain, not able to walk. So the radical debridement, medial side also there was some infected granulation tissue which was open and debrided. Lateral aspect, through the lateral aspect, thorough curettage, pitted saline wash, and antibiotic impregnated cement was inserted. So this was done at the 3 months of injury. So this is an immediate post-op. So like in midfoot, we have seen that it was a one-stop solution. So can we do it for the same for the ankle and subtalar?
So you've actually removed the entire talus.
Yeah, I've removed almost entire talus. Only the part of head and neck is
Head
left.
part is there, but the
And also we can see that
body
there was
is-
a huge punched out lesion in the, the calcaneum and the distal tibia as well. Fusion at the late with the infection just, starting, yeah. So what is the timeline? How would you plan for fusion?
6 months.
What is the option?
Blood parameters and everything. 6 months. Wait for 6 months.
Wait for 6
Get
months.
the blood parameters and see if the infection is settling down. There's very little other than that you can do.
So if you take this as a mascale procedure, then it's 6 weeks to 2 months.
You are doing that work also.
If you are just
How to address the height, because there is, the
have to
entire
use-
talus is not there.
you'll have to use a chunk corticocancellous strut
You use
graft or
the
something.
fibula, no? You can use the fibula. You can get some iliac crest. Use a use your get the
Dr. Girish,
back.
you want to add something? This is after the infection, this is immediate post-op. So when you want to do fusion, or if at all needs, or just leave it alone like that?
Or
No, no,
can
you
create
cannot-
an ankle joint with the cement.
You cannot leave the ankle joint with the cement. I totally agree that this patient will definitely need the fusion when everything will
Timeline?
Sir, it depends on the organism and the resistance. Yeah.
So this was a Pseudomonas infection, which was sensitive to meropenem, which
Okay.
was given for 4 to 6 weeks. This is a 2 months, this is a 5 months follow-up, still holding up. So he presented after 1 year, 4 months. So he was lost to follow-up after 3 to 4 months.
Okay.
But we did tell him that needs secondary fusion. And this is, the presenting picture after 1 year follow-up. He was okay, but he just had pain. He was able to walk with this, but he had pain and kind of not comfortable walking on the cement. So what is the plan? We are going to remove the cement, but then we are going to have a huge gap.
Yeah.
And also the calcaneum, there is punched out,
Yeah.
broad punched out, almost I think 8 to 9 mm of gap is there.
Yeah.
Yeah, and so there's lysis
So-
around the cement as well. So now,
Yeah.
so I think it's getting loose as well.
This has to be taken out. There's no doubt about it. and
You have
then
to take it and fuse it, and you can slide down the so many options are there, including
Yeah.
sliding the anterior of the tibia or
Fibula.
with the Iliac, or you can do the
Fibula.
bone transport and fuse that talus with the tibia with the calcaneum. So many options are there. Even the fibula plus tricortical graft. So many options are there.
You can
So-
either do Elizaro if you suspect that it's going to cause you trouble and you want to avoid a nail or something, or you can do a hind foot nail.
Of course.
Okay, so this is the picture. There's a huge gap after removal of cement. The calcaneum is there, the tibia is there, but the calcaneum has a big hole in it. So first thing is to do a good debridement and also clean up, give a good wash. That is very important. And just open up all the sclerotic bones like this with multiple drill holes. And I did take a tricortical graft, but that is not going to sufficiently address the gap of huge bone. So we have the access of femoral allograft in our hospital. So I know it's an infection, but there was almost 1 year, 4 months gap after the subsidence of infection. So we did dare to put a femoral head allograft just to build a height to restore the height of the talus, because there's a huge gap, and also mixed it with the tricortical and some cancellous chip around that, and to maintain this space, so that will give the good height. And then the fibula from the cortical osteotomy, we have put it into that gap to fill that region, and then the TTC fusion was done for this. and you can see here the fibula from the transfibular approach, portion of small fibula was inserted here, and this is the allograft, and this is a tricortical graft, and some cancellous chips around. So this was done, and at this time of second surgery, we took just to be sure that we took a sample for culture. There was no growth, and this is the immediate post-op picture. And that is the piece of fibula from the transfibular approach. We have put it into and filled that region, and then just adjacent to that the nail was passed. This is a 2 months follow-up. This is a 4 months follow-up. We can see that consolidation of the...
So that screw is a...
This additional outside the nail.
Outside nail.
Just for additional fixation.
Additional fixation.
Additional fixation for the stability, because the distal fragment is held by the two interlocking screws, but they are through the our graft. So we may not have a good purchase, and also one from the calcaneum, the posterior screw. So I always put one screw outside the nail. That was a 6.5. Now we get the jigs with the the escaping nail, the jig also there, so we can use that escaping the nail technique as well as with the jig. So this is a 7 months good consolidation, and this was the first surgery, cement. After 1 year, 4 months, the height was built, the talus height was built, and then the TTC fusion was achieved. Of course, there is no talus here. The talus here is the allograft and the tricortical graft, and now it's 5 years follow-up. He sent this video, but this X-ray is of 2.5 years follow-up. He sent this video by the WhatsApp. So this is 2.5 years follow-up X-ray. So he's walking, he's comfortable, no pain as such.
Great. Thank you very much.
Yeah.
I think we are running out of time, so if there are any burning questions, we'll take them. Otherwise, we should hand over to the
I'll just show one more option. If you don't have the option of allograft, so we can build the height with the tricortical graft and the fibula. So in this case, the allograft was not used, but took a 2 tricortical graft and the fibula, and it's a combination of Dr. Rajiv Shah sir technique where what is that? Bamboo hut, yeah, similar to bamboo hut technique, where Rajiv Shah sir has used the bamboo hut as fibula as to get the height, but I have used the tricortical also, like in this fashion. So if you don't have the access of femoral allograft, then this can be the other option. Yeah.
Okay. I think we've overshot our time.
Yeah, thank you.
So we need to close the session. Thank you very much.
Thank you.
Great. Thanks.
Hello. Thank you. We are already start our 5th IOA-IFAS session, but at this juncture, this time we are going to present 2 oration. One by none other than our beloved President-elect Dr. Naveen Thakkar sir. He will talk the oration. One of our teacher, mentor, who right now not with us, Professor Biplab Acharya sir. So he will going to give this oration. This is the first time during this conference we are introduce this Professor Biplab Acharya oration, and on behalf of West Bengal Orthopedics Association as well as Howrah Ortho Club, we are grateful to him. He came here, and also today during this oration, late Professor Biplab Acharya's wife with us. We invite her. She is with us. So definitely I request Madam, please come forward. Ma'am, please come. And another oration will be delivered by another paper by Dr. Indrajit Sardar sir, who is known by everyone for last decades by decades. And he will talk on another living legend, Dr. M.S. Ghosh sir. He is still with us, and we pray for his long life. So first, I request our WBO President, Professor Gigi Kaur sir, and our Secretary, Honorable Secretary, Dr. Sobbosachi, Professor Sobbosachi Satra sir, please come dais. And I also request our Howrah Ortho Club President, Dr. Jagannath Bhattacharya sir, and our Secretary, Dr. Subra Chatterjee sir, please come in the dais. Professor Gigi sir.
पहला मेरा है पेंटर उसमें है ही ऑलरेडी ये कंप्यूटर में है डे 2 में है ना बिप्लो आचार्य और
हेलो I would request
इसमें तो डाला है बिप्लो आचार्य ओरेशन है तो
IOA President Elect Dr. Naveen Thakkar
बिप्लो आचार्य ओरेशन
to please come up on the stage
ऑलरेडी उसमें है वो
and deliver
it is there already sir
the Professor Biplab Acharya Memorial Oration. And I would also request Madam Acharya, wife of Professor Biplab Acharya, to be also on the stage with us.
it was there on the computer
Yes.
Can I start? Good morning to everybody. I am thankful to Howrah Orthopedic Club, West Bengal Orthopedic Association for inviting me here to deliver oration for a legend of West Bengal, none other than Dr. Biplo Acharya. He born at the 8th November 1951 and we lost him on the 6th April 2023. He was HOD, head of department in 1969 at NRS Medical College, and then he became the Dean of Kolkata Medical University. He was very much popular with students. Madam, thank you very much for coming and gracing the occasion. He was a selfless social worker and he had a last position at the Tripura Medical College in the orthopedic department, and I am very much thankful for allowing me to share my views on the subject in the memory of Dr. Biplo Acharya. What we are going to talk is something different. It is not absolute stability or it is not a relative stability. It is something in between, that is absolute fixation. A thought process. I am just igniting the thought process, something. So we can start with the case, supraisthemal fracture. Very simple things I am talking about this. This was the picture, and what type of the stability? Everybody will say that it is a relative or absolute, it is a relative stability. What will be the stress and strain at this junction? Intraoperatively, will the surgeon will be able to know exactly what will be the stress and strain on this fracture here? Can you judge, sir? Sardar sir? What will happen? On table, what will be the natural course of this fracture fixation? later on. He has fixed, he has interlocked all four, these screws and these screws.
A delayed union.
Delayed union will happen. What will happen? Can you judge what will be the stress and strain?
Yes.
That is the problem, that is the dilemma with the surgeon on table. Now, what is there? In the follow-up, at 8 weeks, some callus is there. Surgeon is in dilemma. What is happening? Do you find anything else here in this X-ray? Anybody wants to point out anything odd in this X-ray? Sir? Shift of medially. What is shifted, sir?
Distal part of the nail. Shifting
Distal
medially.
part of the nail. It is there from the very beginning.
No.
I am just showing you the...
the whole thing is undergoing a various strain.
I am giving you the zoom picture. Now do you find anything? There is a toggling happening in the nail. If you see, there is a toggling. There is a halo around this nail. And that toggling is also happening here. So there is an instability. Even after the fixation, which is invisible instability, which could not be detected even in the follow-up or on table. So surgeon was not knowing what is going to have stress and strain at this picture. So he tried to do the dynamization. He removed these 2 screws. And what is happening now? 24 weeks after the dynamization, this is the condition. Again instability is there. What to do next? There is a instability, and that further instability has happened. So what we did, we made a plate here, additional plate without changing anything, but the one of the screw was going through the plate, through the nail hole, and distal locking was done at the same place but with the washer, because there was a toggling and that was taken care by the washer. This is the picture after 6 weeks after the plate fixation. What will happen? What do you think, sir? Amiya ji. Again fail. Okay, let us see.
There is gap.
That is united. So, we do not know exactly how much the invisible instability is. Each fracture pattern, each patient with a soft tissue injury, different spectrum of the instability. Here, one relative stability is added to another relative stability, and that is not absolute. There is no compression. Still it has got united. We know that non-union needs compression. It requires only a stability, and that is the absolute stability for that particular patient in that particular case scenario. So the problem is the Pilon theory. It says all or none. Either it is absolute or relative. We all know these stresses. We all know this stress and strain pattern curve. This is the theory. Strain less than more than 10% tolerated by cartilage. Strain 0, no callus formation, and strain 2 to 10%. But 2 to 10%, we are learning theoretically, but how to know exactly on table whether it is 2 to 10 or more than 10? That is the problem. We know that this is the cascade, and we can change and get the direct bone healing and indirect bone healing, but the method of healing depends on the type of stability we produce. But there is a gray area, and this is the gray area where the surgeon can do this with a cyclic loading, dynamic in direction, and this is known as mechanotransduction. Once there is a stress and strain pattern where this channel plasma membranes get stuck and this signal doesn't go and there is no new bone formation. But at the some part of the fracture there is a callus formation, and some part there is no callus formation. So some part of the fracture zone has a good strain and strain pattern between 2 to 10, and some part has more than 10%. So there is a gray area even in the fracture zone. And this is the theory of mechanotransduction. This canonically opens at certain level only, and that calcium channel goes and the new bone gets laid down. So there is a mechanical theory, a mechanical pressure, mechanotransduction, where you can change the biology by changing the mechanical environment. Another case, surgeon has fixed, what will happen? Anybody? because here is a good positive reduction, here is a good positive reduction. Surgeon was happy after fixation. What will happen? Z or reverse Z?
Z is there because
Z effect. Let us see what is happening here. It is a M or W effect. So there is nothing like a Z or reverse Z effect. It is a just instability even after fixation, which we are not able to judge on the table or in the follow-up. Both screws has come down. So it is a sign of the instability. It is not a Z or reverse Z pattern. Either it goes in or either it comes out. The movement of the implant suggests that there is a toggling. This is the Z effect described, and this is the reverse Z effect. But we have studied that the implant which is holding well in the head and neck part gets ratcheted in. The implant which is not holding well in the head and neck part gets ratcheted out by continuous toggling. That is what we found. What about the one implant? We said that the two implant is not good, Z and reverse Z effect, but the single neck element, good fixation in head and neck type, it goes in. It is even worse because of the cut through. Another case, what we know that the serpentile movement, that is the ratcheting effect, toggling, the biomechanics of the snake movement. There is no legs with the snake, but by toggling it moves, goes further. By ratcheting effect on the friction on the earth, it moves. Again a case, surgeon has done a fixation, all positive reduction, 6 weeks, it is your case, sir. What will happen? What do you think? Everything is positive. Positive reduction, good anterolateral connection, but anything you find peculiar in this X-ray? Could you find anything? No, it's good. Okay, everything good. It's a Halifax nail with the 2 rings here. It's a good fixation in head and neck part. But if you see, there is a cement here. Surgeon thought intraoperatively there is a posterolateral breach. So he tried to fill up with the cement. He had not ready anything other fixation. And what has happened? That implant has gone inside on ratcheting and it has not moved in the linear direction. It has moved like a snake movement and made a big bogda like this. It has went in like this because of the ratcheting effect. This is well described in the literature. If you see this, the snake movements which has been described by the biomechanics, the scientist has tried to remove the friction here. They made a plastic sleeve on this body of the snake. It toggles, but it doesn't move. So, if you want to reduce this movement, what we thought that we can apply a plate on the nail, so that can remove the toggling and that can give rise to remove the toggling and implant movement will give the stability further which is required. Another case where there is nothing to support laterally. So we fix with nail and the screw is going through the plate through the nail and the distal screw is also going through the plate and through the nail and the trochanter is with the tension band wire. So complete stability is achieved. So again it is a absolute stability. 2 principles are fixed up. Another case where DHS was done, it was a MLC and it was failing. So again same principle we did with the vancomycin and meropenem bone graft. Bone graft is a local antibiotic delivery and at 6 weeks what will happen, sir? There is nothing here. If you see medially, there is nothing here. It is everything lost in the instability. But stability was given with the plate and the bone graft was done. And the mechanotransduction, once the stability is there, there is a mechanotransduction, the fluid level in the canaliculi changes, the sensing changes, and the new bone formation starts. And it has given a new bone formation. So once you change the mechanical environment, there is a gray area between the absolute stability and relative stability. Again a case, surgeon has fixed with the proximal tibia and this segmental tibia, but it was not uniting. 8 months post-op. These gates are closed, mechanotransduction is closed, no ion influx inside. Cellular activities change and there is a cyclic loading going on continuously. Surgeon changed the mechanical environment by just adding the plate, required stability, and again the cell signal starts and the new angiogenesis starts, and that gives rise to good union. Again, shear, torsional stress, strain are taken care of, and that strain is taken care of. Again, absolute stability, nail with the plate. Another case, peri-implant fracture. Flexible nail with the plate, and it has given a relative stability and it has got united now. And this is the clinical picture. At 16 weeks, surgeon has fixed with the short plate. We are thinking that we require a long plate because there is no callus here on the medial side at the 16 weeks. What to do? Whether it was required a long plate, just additional plate and the fibula was done without changing the lateral plate, and it has given that mechanical stability which was required for that particular case in that stress and strain environment, and that has given a good result. Again a long plate, but it has failed because of the combination here and the plate broken. Again the stability was given, the mechanotransduction started. Medial plate, short medial plate, 2 screws and 2 screws below, and the fibula. And gradually that stress and strain pattern changes, and that gives rise to the biological process, and ultimately surgeon could modulate the mechanical environment, changing to the biology changing and giving the callus. But it takes time of this long area to get filled up completely. So that amplitude has changed, and that has changed the gates of the influx on the cellular level at the mitochondrial level. So surgeon can change the mechanical stimuli and can work on the cellular level, on the mitochondrial level, and can change the micromechanics at the cellular level of the cell tension and canaliculi tension, and that can change it. And you can see here is the previous incision of the plate, here is the modified swashbuckler and the fibula, and this is the function. So once you get the stability, the new bone formation comes. But we do not know exactly what amount of the stability is required on the table. That is the big problem. Shortcoming of the interfragmentary strain theory of the Pilon, there is also a zone in between where is not absolute or no relative stability, and certain metaphysical regions you cannot do the compression. You cannot, if you want compression, you cannot achieve the compression. There you have to have 2 relative stability implants. Adding the whatever the stability is not there with the rotational stability, you can provide with another implant, and that gives rise to a zone, gray zone, where you can say it as an absolute stability, and it's not absolute complete stability. This exact mechanism through which the mechanical stimuli are sensed and incorporated in the healing process is not fully understood, and still remains the open question. It is changing, it is dynamic, and it is different at a different part of the fracture zone also. So we are not knowing exactly how it is behaving in certain case, and we cannot make the principle. But we have to be very cautious on table. When we are in doubt, we should provide little more stability than which is required. We do not know exactly on table. So surgeon has to balance between reduce the risk of the failure and optimum interfragmentary movement. We have to be very flexible. What is the future? Future is smart implants which can give you the stress and strain measuring implant, and what will happen on the cyclic loading. But till that time, the technology advances, we have to intervene early. If you are not fixed well, we have to do follow-up, and we have to judge exactly whether we require the additional stability, that is the absolute stability, whether we require or not. Then we have to add another augment whatever we have fixed and get the exact stability, because the spectrum of the instability is totally different each case to case. Soft tissue injury is different case to case. The vascularity of the local part is different each to each case. So if you want to generate angiogenesis and if you want to change the biological environment by changing the mechanical environment, you must take care in the follow-up and augment whenever it is necessary. So we have to learn from the nature. Stability has to be taken care of, but at the same time, the flexibility should not be lost. These bamboos are very high. It's stable, but still flexible. And that flexibility gives the biological reaction in that amount of 2 to 10%. And that part has to be taken care of, and no rigidity, so that new bone formation grows. And everywhere where there is the stability, growth happens. Where there is the instability, growth does not happen. Thank you very much for your support. And I bow down to the legend, Dr. Biplav Acharya, Madam, for his great contribution to the orthopedics. Thank you very much. Yeah, please come.
বলছি যে আমার হাজব্যান্ড বিপ্লব আচার্য, আমি আপনারা এত কথা বলছেন আমার ভালো লাগছে শুনতে, কিন্তু পাশাপাশি আমার রাগ হচ্ছে বিপ্লব আচার্যের ওপর এই জন্য, ও পেশেন্টের কথা এত বেশি ভাবতো, বোধহয় 10%ই পেশেন্টের কথা ভাবতো, যার ফলে নিজের কথা ভাবাটা ভুলে গেছিল। তার জন্য আমার মনে হয় সে যেভাবে মারা গেল, আরও চিকিৎসার মধ্যে থাকলে আরও 2-3 বছর হয়তো বেঁচে যেতে পারত, কিন্তু তা করেনি। যাই হোক, সেটা আলাদা কথা। সেই জন্য আপনাদের কাছে আমার রিকোয়েস্ট একটাই, আপনারা এলিট অফ দ্য সোসাইটি, কাজে আপনাদের সমাজের ওপর দায়ভার অনেক বেশি, সমাজকে সুস্থ রাখার দায়িত্ব আপনাদের অনেক বেশি, প্রত্যেক মানুষকে ভালো রাখার দায়িত্ব আপনাদের। কাজে আপনাদের নিজেদেরকে কিন্তু ভালো থাকতে হবে। প্রথম কথা, নিজেদেরকে আপনাদের ভালো থাকতে হবে, সুস্থ হতে হবে, তাদের যাতে একটাও মানুষ আপনাদের মনের খবরটা পেয়ে যেন দূরে সরে না যায়। আপনারা এই কথাটাই আমার একমাত্র বলার। এটা আমি আমার অভিজ্ঞতা থেকে বলছি এবং আপনাদের সবাইকে বলছি। আমার কথা শেষ।
Thank you very much, Dr. Naveen Thakur, our IOA President, for delivering such a nice lecture. The oration of Dr. Biplav Acharya. Biplav was a very good friend of us, and he passed away. So I am really thankful to you.
Thank you. A little bit of token from our side.
Thank you. Thank you, sir. Thank you. Thank you, sir. Thank you, sir. Thank you. Thank you. Thank you, sir. Thank you, sir. Thank you.
Now, Dr. M.S. Ghosh oration. And Dr. M.S. Ghosh was a legend person in orthopedic scenario, and he was our mentor. Indrajit is coming. Indrajit is a very good student, one of the best students of Dr. M.S. Ghosh. M.S. Ghosh was the pioneer of modern orthopedic era, and he was a great teacher, and he is still alive, and he was our teacher and our mentor. Myself, Indrajit worked together under him in Howrah Orthopedic Hospital as a postgraduate training. Abhijit is there, Sharoj is there, all work together. So Indrajit was the past president of Indian Hip and Knee Society, and he is also a very good organizer. Now I am inviting Indrajit to deliver the most prestigious Dr. M.S. Ghosh oration.
Thank you, Dr. Jagannath. It has been a pleasure to see you and other persons who worked with M.S. Ghosh at that time. Basically, this oration is a tribute to a teacher, and I must thank all the members of the Howrah conference of the Howrah Con for organizing this lecture. So this is basically, as I said, a tribute to a teacher. Basically, we are talking about safety and common sense, which marked his approach to life very much. I'll first start off with several stories. Story one, this is of, we are having an advent of newer surgeons with newer skills and newer knowledge, and above all, there is more competition nowadays. So this story one, this was a fracture of the 5th metatarsal bone, and one would normally disregard it and use a strapping on it to get a good measure. Unfortunately, this thing was fitted with a plate. The logic was that this plate is available, so it has to be used. And I wonder what he would have done in this situation. Story two. My brother-in-law, then 35, sustained a closed fracture shaft humerus, which was reduced by GA by a very senior orthopedic surgeon, and it was malreduced. It was advised an operation by Orif, brought to Sir, he reduced, but still was not in line. It was something like this. He advised to accept it, stated this will unite. I asked in all my youthful query, how can you be so sure? He replied that when I manipulated, I could feel bone on bone grating. So I was sure there was no soft tissue interposition. The patient is a young, strapping lad, and at that time, all humerus fractures were supposed to heal without an operation. So the possibilities of union is good. After 6 weeks, callus appeared, and it is still united after 40 years. Story 3, and this was one of his cases which he presented at the WBA meeting, our own clinical meeting. A fracture of the upper third femur was plated by him, resulted in non-union. The plate was broken. Our suggestions were all the ones that all of us contributed, replating, nailing, bone grafting, etc., etc. But lo and behold, what Dr. Ghosh did, he removed the plate and did nothing. The plate was a distracting force, and the fracture started uniting after that. I think all of us will remember this case, which we were shocked to see at initially, that such things can be treated without any operation. Story 4, and this is a story which is now developing. A pharma executive had a lower end radius fixation in 2020, and it was done what I thought reasonably well. He fell down on his wrist, the MRI revealed nothing. And he was okay with this, and he was continuing to be okay with this. And his orthopedic surgeon who saw the case was a highly skilled person. And he is the sort of person to whom I refer cases to whenever his special skills are required. Now, was this necessary? The MRI revealed nothing. There was no VC, there was no DC. And the problem was, he says it was his fault that he submitted a hefty insurance policy. So we put him on a wristband and made him to do active finger movements. So no wonder we started the story with common sense and, of course, rationality. This was another case recently which came to us. So this was a case which had a lower end of the tibial fracture and was treated with this. Plates on the lateral side of the fibula, plate on the medial side, and plate on the posterior side. Together with this, unfortunately, a talus fracture was missed. So when he came to us with this, with an infection, and the only thing was that initially he had a tendon Achilles repair, and this plate was applied there in spite of this. So now we are facing a complicated situation of infection, of pronounced plastic surgery, and ultimately maybe a tibio-calcaneal arthritis. So who was Dr. M.S. Ghosh? Dr. Mibanko Shekhar Ghosh, an MBBS, FRCS Edinburgh, FRCS England, MCH Ortho, FAIS, was born on the 1st of May, 1932 at Khulna of undivided Bengal. And he finished his matriculation from Khulna School. He passed his ISc from Scottish Church College, the famous Matia College, Kolkata, in 1950, and graduated in 1955. He was conferred the FRCS Edinburgh and FRCS London in the same year, 1963. He pursued his studies and was awarded the MCH Ortho by Liverpool University in 1955. He was married to another stalwart, Dr. Professor Ila Ghosh, ex-head of the Department of Anesthesiology, and they were gifted with a son, Shoibal Shekhar Ghosh, in whose name IOA has instituted one of the best paper prizes for tumors. And he himself was a name in the field of finance in UK. So after working in various orthopedic and trauma units in UK, he returned to India in '66. Dr. Ghosh joined CMC Vellore and worked as a reader and head of an orthopedic unit. In November '69, he joined the Railway Orthopedic Institute and Research Center at Howrah and turned the same to an important orthopedic institute in India, where lakhs of Indian people got the benefits of his treatment. He had an astute clinical knowledge and surgical skill with precision. He gave new lease of life to many young patients with congenital foot abnormalities and was one of the pioneers in Talus equinovarus treatment and the post-polio foot abnormality. He was associated with the development of sports medicine in India, realizing long before many others that this was an area in which to be explored. He trained graduates and paramedics as the course director of Diploma in Sports Medicine. He left the Howrah Hospital and joined Kotari Medical Center in '92 and developed that private center of excellence in orthopedics in Eastern India. He was also associated with the Nightingale Hospital and Amri Hospital, Kolkata. When he was fully active, he left Kotari Medical Center and other centers in 2020. He was elected as the president of the Indian Orthopedic Association in 1933. He was the president of the West Bengal Orthopedic Association. He was the overseas fellow of the British Orthopedic Association and reviewer of orthopedic journals. To the patients, he was godlike with healing hands. To the students, he was a candid teacher with unlimited knowledge. To the colleagues, he was humorous and inspiring. He has published more than 300 articles, mainly written in vernacular, on day-to-day problems related to bone disease. He is a prolific orator, both nationally and internationally, not only in his subject, but also on the history of science. We witnessed one such glimpse in the Asiatic Society of Calcutta, where he gave a lecture. He organized the annual conference of the Indian Orthopedic Association in 1985 and the first Asian conference in sports medicine in '87. He was also conferred the Professor B.N. Sinha Meritorious Award by Indian Orthopedic Association and a Lifetime Achievement Award by the Calcutta Medical Ex-Students Association. Our memories, we still remember his classes. As hundreds of patients lined up in the corridors outside his room, he taught us how to elicit a patellar tap, guiding our hands and determining what is the exact nature how to elicit a patellar tap, and not rely on an investigation like an USG or MRI. He taught us how to grade muscle power and muscle transfers in Hansen's disease. As the evening turned to night and we trudged home day after day, tired but every time inspired. What did he teach us? He taught us to be calm, to be rational, and never harm the patient. Operate when you have to, but embrace the new always. Lessons that are forgotten nowadays. He brought the AO school to Calcutta and India. And we know that at that time, AO group was believing in absolute fixation. And that is the thing that Calus was then thought not to be a good thing. Later on, AO changed to biological fixation, and again, that also came about. So these are lessons that are forgotten nowadays. So who is a teacher? The mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, but the great teacher inspires. So he was teaching personally to us all the time, not only in classroom lectures, but also in the room beside his room, where we used to sit down and present our cases. He taught us about life. Be calm, care for the suffering, feel for the patient and the family, and spread optimism. So who should be an ideal doctor? And his principle and his policy was he should be above all, above politicians, above most bureaucrats, which is not the situation nowadays, above pettiness of politics, devoted to his patients, devoted to medicine and nothing else. Are we doing this now? Ideally, he also showed us by his own life that above all happiness and sorrow, which is an extremely difficult thing to do, but he did it and showed it to us. So one of our receptions to Dr. M.S. Ghosh amongst many. So here he is with his wife beside him. And you can see on the background, Dr. Shivaji Chaudhary and Dr. Obijit Sharvadikari, a younger one, less traveled. And I was, and on my right was Dr. Ajay Mukherjee, who is no more with us, but who was a part of our gang. On the right-hand side is the picture of Dr. Tapon Chatterjee, who is in difficulty nowadays, but he was the first house surgeon of our orthopedic hospital. And here he is handing over it. Dr. N.D. Chatterjee is on the right. He was then president of the WBA. And below, Dr. M.S. Ghosh's wife, Dr. Ila Ghosh. And one can remember that she had an ejection fraction of about 29%. And when we was given the suggestion that some operation should be done on her cardiac status, she replied in clear words that I have seen the best of life, I have seen happiness, and I have seen the deepest of sorrows. So don't interfere with me. Let me be, let me go as I go, which she did. So with these words, as a short introduction of Dr. M.S. Ghosh, and to all the persons who were with us in our days there with him, in front of us, Dr. Jagannath was there with us, and the rest of us, we knew him very well. With this, I end this. Thank you very much for this patient hearing.
Thank you, Dr. Indrajit Sardar, for delivering an inspiring oration about an inspiring legend. And it's now our duty to present you a small memento of appreciation.
Good morning.
So we have finished those two orations, and now next session on tendons, ligaments, and fasciitis.
Thank you so much for this wonderful session. We appreciate you sharing your time and knowledge with us. Moving on to our next session, I would like to invite the chairpersons Dr. Girish Motwani, Dr. Shutanu Hazra, Dr. Ramakan Gopalakrishnan and Dr. Sanjay Keshar to please come up on the stage and proceed with the session.
Good morning, everyone. My name
So we'll move on to the next session of tendons, ligaments and fascia. The first talk is by Dr. Siddharth Sharma. Video lecture? Okay. So we'll run the video lecture of Dr. Siddharth Sharma. Yeah.
My name is Siddharth Sharma. I am from PGI Chandigarh. And I thank Dr. Abhijit and the Howrah Orthopedics Club for giving me this fantastic opportunity. I will be going through a case of tendo-Achilles rupture, which is provided courtesy of Dr. Aradhana Rathod, who is Assistant Professor at Bangalore Medical College and Research Institute. And this case, I believe, is being showed at a number of cities across India as part of this wonderful IOA-IFAS initiative. So let's do a deep dive into this case. So this is a 49-year-old gentleman who comes in with a history of pop behind the ankle. He is on methotrexate for inflammatory arthritis. He was diagnosed as insertional Achilles rupture. For some reason, he presents late. It is about 2.5 months since injury. And he is a working person who supports his family. So what are the key things to look for on examination? So to the image on your extreme left, it shows a Thompson's test. So the Thompson's test is done by gently squeezing the calf at the level of its maximum width. And in a normal case with an intact Achilles tendon, you should see a good amount of plantar flexion when you squeeze that calf. In this case, you will see that there is no plantar flexion of the ankle on squeezing the calf. The image on the middle shows that there is no resting tension. So what do you mean by resting tension? Now with the knee flexed to 90 degrees in this position, a normal ankle should demonstrate 10 to 15 degrees of plantar flexion. But as you will see here, this ankle is almost neutral. There is no plantar flexion. And when you compare it to the rightmost image, you will see that the normal limb ankle is in about 15 degrees of plantar flexion. This is the resting tension. So a positive Thompson's test and absence of resting tension indicate that this is indeed an Achilles tendon rupture. Now what are our treatment options here? Can we conserve this case with a plaster? Well, for an acute Achilles rupture in a young patient who has no comorbidities, this is an excellent option. You would immobilize this in gravity equinus, and over a period of time, it will heal. The results of a non-operative repair for acute ruptures are very, very good. Whether to operate. Now at 2.5 months, you would expect the tendon ends to be retracted. There would be some amount of gap between the two and fibrous tissue. So we cannot really expect non-operative treatment to work here. We have to choose an operative treatment. whether to go for an open or a percutaneous repair. So again, with a retracted tendon ends and with fibrous tissue in between, a percutaneous repair at 2.5 months is out of the question. But then we also have to ask whether we can really repair a neglected case. So well, if the gap is too big, maybe it is 5, 6, 7 centimeters or so, getting the two tendon edges to oppose to each other becomes very, very difficult. So what can you do in those cases? So now in the recent years, there has been a lot of interest in flexor hallucis longus tendon transfers for tendon ruptures with large gaps. So anytime you have a TA rupture with a big gap, it's been shown that if you do a flexor hallucis longus transfer and then suture the two ends of the tendon to the flexor hallucis longus, these people do functionally very, very well. Previously used techniques like the turn down technique or the VY lengthening of the tendon, they have been shown to have significant wound problems. So an FHL transfer has become more or less the gold standard for neglected Achilles ruptures in recent years, especially in 2025. So a short FHL transfer is when you take a shorter length of the hallucis longus tendon. The tendon is delivered from within the ankle and it is transferred to the calcaneus by means of a suture anchor or by means of a screw, an interference screw within the calcaneus. You can also do a long FHL transfer where a long length of the tendon is used. It is passed through a drill hole in the calcaneus and then sutured to the Achilles tendon. So in this case, we will be demonstrating the long FHL transfer, which is the gold standard really for neglected Achilles ruptures with large gaps. So to operate this patient, you would put them in a prone position and the incision is made just medial to the Achilles tendon, centered over the injured tendon for about 10 centimeters. It is very, very important to go directly to the paratenon. Do not raise any subcutaneous flaps. Incise the paratenon, retract it, identify the tendon and then debride the tendon till you see healthy edges of the tendon. In the next step, you would see how much is the gap. So if the tendon gap retraction after debridement of the fibrotic edges is anywhere between 2 to 3 centimeters, you could try to do an end-to-end repair. But here you can see this is a large gap already. It's about 3 finger breadths or about 6 centimeters. So in this case, doing an end-to-end repair is not possible without doing a turn down or a VY lengthening. These procedures have their own set of complications. So for these kind of cases, a long FHL transfer works very, very well. So as you can see here, the FHL tendon is visible beneath the fascia and you can confirm it by moving the great toe. Again, you see with the scale that the gap is about 6.5 centimeters. So to harvest the FHL tendon, we will develop the interval between the tendon and the peroneus longus tendons. And we try to stay lateral to avoid injury to the neurovascular structures. So the tendon is then released from its insertion on the great toe. You would make a small transverse incision at the toe crease on the plantar side, cut the tendon at that level, then go to the level of the sole at the level of the master knot of Henry. At this place, we should avoid injury to the medial plantar nerve and the artery, which is just deep to the tendon. So here you can see we have identified the tendon and pulled out the tendon at this level, at the level of the middle of the sole, and then we go back to our ankle wound and the whole length of the tendon can be pulled out, and this gives us a very, very good working length of the tendon. Now next we are going to make a drill hole from medial to lateral side in the calcaneus. Why medial to lateral? Because there are neurovascular structures on the medial side and you have a greater control on penetration of your drill bits if you start from a medial to lateral direction. So we'll use drill bits of increasing diameters, and generally a 3/8 inch tunnel is enough, although I would recommend that you size the tendon and make your tunnel just slightly wider to it. So once your tunnel has been made, the FHL tendon will be passed from a medial to lateral direction. It comes out at the lateral side and then from the lateral side it is pulled back into our original wound and it is sutured to the two ends of the tendon. So you will see here that we have not really repaired the tendon. We cannot repair a 6.5 centimeters defect, but we have bypassed that area by doing an FHL transfer. So this is anchoring one end of the tendon to the other by means of the FHL, and we have also anchored the FHL to the calcaneus, which gives us a good power of plantar flexion. Now you would close the wound in layers over a drain with careful repair of the paratenon, because that prevents wound dehiscence. And when you are suturing when you are placing the FHL tendon back, you should be very, very mindful of the resting tone. So we talked of the resting tone. Ideally, we should be draping both the limbs so that you can see them intraoperatively. Look at the resting tone on the normal side, and then in the same position anchor your FHL tendon. So you don't want your repair to be very tight. You want your repaired ankle to be in the same degree of equinus position as compared to the opposite side. So the post-operative protocol, so we give a non-weight bearing cast in slight equinus for everything, the soft tissues to heal down, and then we use a prefabricated brace with multiple heel lifts starting from about 3 inches. The heel lifts are gradually reduced over a period of every 2 weeks, so that by 12 weeks the ankle is in a neutral position. Now passive plantar flexion and slight active dorsiflexion up to a neutral position can be done after 8 weeks or so, but active dorsiflexion beyond neutral position and any amount of passive dorsiflexion is to be avoided till everything has healed very well, which is usually 12 weeks time. So a gradual return of activities is permitted with the brace, and as you can see here, everything healed down very well. The patient can walk very, very comfortably, and they had a good outcome. Now if you want to study the technique of a long FHL harvest, there is an excellent article in Foot and Ankle International by Professor Panchpavi. In fact, there is also a great video by him that you can peruse here as we have shown here. So thank you for your kind attention, and I am happy to answer any questions that you might have.
So if there are any questions, I think it's not live, right? So it was. So I would call on Dr. Kushal Nag to come with his talk on ankle sprain, and I would also call Dr. Rajiv Chatterjee to come up on the dais as a panelist and chairperson.
Good morning, everyone. So I'm going to talk about ankle sprains today. This is a very big topic, a vast topic. So today I would like to focus on the most common ankle sprain that comes to us, the lateral ankle sprain. There are many variations to it. There are many other medial sprains, other sprains also of the ankle, but I like to focus on the lateral sprains because they're the most common injury which we get in our OPD. Okay, so okay, so it's the most common athletic injury, 25% of all injuries in sportsmen. Worldwide, the risk of ankle sprain varies with the sport. You can see basketball, soccer and volleyball. They are the most common sports played worldwide. So this is the incidence of injuries in these sports. And ankle sprains account for almost 10 to 15% of all lost playing time. It's the same story with our patients in the OPD also. A lot of them come to us after playing cricket or soccer, and they end up getting downtime of almost 10 to 15% time they are down. This is a small survey done in the epidemiological survey of ankle sprain. You can see this is the sports and the incidence of ankle sprain on these sports. You have racket sports, soccer, ball games, others, running, and most of the cases, almost 50% is in competitive sports. Also you have recreational and other sports which also the incidence is not that less. So the relation of the tibia, fibula and the talus is maintained by an articular capsule and 3 groups of ligaments, the medial, lateral and the syndesmotic ligaments. So today we are going to focus on the lateral ligaments. The anterior talofibula, the posterior talofibula and the calcaneofibular ligaments make up the lateral collateral ligaments of the ankle. This is the relation of the 3 ligaments as compared to the ankle. The most common mechanism of injury is a combination of plantar flexion and inversion. The anterior talofibular ligament is the most easily injured, followed by the CFL or the calcaneofibular ligament. The posterior talofibular ligament is the strongest of the lateral ligaments and is rarely injured in an inversion sprain. You will get a PTFL rupture when you have a fracture, and you see that, we will discuss that in our ankle fracture session. So the eversion and the external rotation sprains, they are the least common mechanism of injury. Most fractures happen in eversion. If you look at the Lodge-Hazen classification, you have the PER injuries, which is exactly what we are talking about when we talk about fractures in ankle sprains. Remember, when a patient comes to you with an ankle sprain, don't just focus on the ankle. Look at the ankle as well as on the foot. There are many other injuries which are commonly missed or ignored if you just focus on the ankle in an ankle sprain. You have a fracture of the proximal fibula, which is commonly there. You have the fifth metatarsal base fractures. You may have an osteochondral talar dome lesion. Lisfranc fracture dislocations, most of these patients will come and complain of an ankle sprain. They will never say a foot sprain. And of course a fracture, a bimalleolar or trimalleolar ankle fracture. So whenever you look at an ankle sprain of varying degrees of severity, whether it be a fall from stairs or a sporting injury, please keep in mind these differential diagnoses so that you don't miss anything subtle. So the diagnosis is pretty straightforward. You look at the history of trauma, the swelling, discoloration, the pain tenderness, movement restrictions. The anterior drawer test may be positive, but it's difficult to elicit the anterior drawer test in the context of an acute trauma. And of course, you go and do an X-ray to figure out if there's any other associated injuries. So when you examine a patient, you can jolly well figure out what ligament is torn, and this is exactly the pictogram which tells you how to examine and which are the ligaments which you will be feeling when you put your thumb to the lateral ligament complex. You have the anterior talofibular ligament, the anterior inferior tibiofibular ligament, which is the inferior part of the syndesmotic ligament, and the CFL. So these are the three ligaments which you can palpate and get a fair idea of what injury the patient is suffering from. So we call it the Price protocol or the Rice protocol. Prevention, proper shoes and warm-up exercises. Don't go and play soccer in a chappal or barefoot like we usually used to do in our childhood. Rest, limit weight bearing, crutches if necessary. An ankle brace can help to control swelling and add stability. I prefer a crib bandage, which is easy to apply and easily available in every household. Ice, do not ice directly on the skin. No ice for more than 20 minutes at a time to avoid frostbites. One of the most common mistakes which our patients do, when I tell them to ice, they'll keep the ice on their ankle for half an hour, 1 hour, and then they will come and say, my ankle has become red, the skin has become red. So that's an early sign of ice burn. So no ice directly on the ankle, wrap it around in a towel or a cloth or a hanky or whatever, and do not keep it for more than 15 to 20 minutes. Compression can be helpful in controlling swelling and is usually accomplished with a crib bandage. You can do that. And elevate, of course, above the waist of the heart as needed. This is the acute management in an acute ankle sprain in the immediate setting. There are various types of ankle brace, depends on your preference also. The idea is to immobilize the ankle till the time the swelling subsides. You can also allow weight bearing as tolerated with these ankle braces to, at least from the bed to the bath or bed to the, dining room, you can allow after you are wearing these braces. Graded exercise regimens. One of the common queries that I get from many of my patients is, are you going to do a plaster on me? The simple answer is no. Unless you have a fracture and I need to immobilize, I will not put you on a plaster slab, because that unnecessarily causes two things. One is it prevents you from icing the fracture, because of course you don't have direct access to the skin. And secondly, it stiffens up the ankle unnecessarily for the next 2 to 3 weeks. You're going to apply a slab for 2 to 3 weeks, the ankle becomes unnecessarily stiff. So I tend to avoid putting a slab. Initial stages, I ask them to move the ankle as they can, the dorsiflexion, plantar flexion and circumduction if they can. And then once the pain subsides in 10 days to 2 weeks, I start graded exercise regimens which reduce the risk of ankle sprain. They are proprioceptive stretching and strengthening exercises. They're quite available in YouTube and any other digital media. You can look them up. Usually, depending on the severity of this pain, it takes around 2 weeks to 4 weeks for the patient to get back to the normal activities. Of course, graded normal activity doesn't mean you go back and play soccer in 1 month's time, but you can go back to your normal activities. But what happens if you have chronic instability? Patients have come back to me after 3 months and told me, I don't feel my ankle is stable, or I get repeated sprains when I go back and play cricket. The question that I get is, do you want to do an MRI scan immediately after you have an injury? My preference is not to do it, because there's so much of bone bruising and so much of soft tissue edema that it obscures or obfuscates your diagnosis, and you may not be able to appreciate the ligaments better. If you have chronic instability, please go ahead and do an MRI scan to figure out the state of the ligaments of the ankle. If you have an ATFL test, so what are the 3 red flags? So an MRI diagnosis is important. You see a ATFL which is avulsed or torn, patient complaints of instability, and then you have an anterior joint which is positive. If all 3 are positive, you know that you're dealing with an unstable ankle. I need to do something about it. I give them a trial of exercises, strengthening and stretching, and even after 1 month of doing all of this, if they still complain of instability, then you realize that something has to be done about it. The ligaments need to be reconstituted. So there are very many ways of doing that. Surgical options, you can repair it open or arthroscopic, or you can also use an autograft or allograft, which is not very available in India, but internationally you can do that. But in India, you can always use those synthetic synthetic tapes which are available. So open repair, what are the common go-to methods for open repair? You have Brostrom, you have the Gould modification of Brostrom, you have Watson Jones, Evans, and Christman Snook. It depends on the surgeon and his preferences, there's no gold standard as in which is the best procedure. If you ask me, I'm not sure, but it depends on which procedure you're comfortable with. Usually the consensus is the Gould modification or the augmentation of the repair is the better option to go to if you have to repair the ligament. And Watson Jones, Evans, and Christman Snook are slightly more morbid surgeries. Try to avoid them if you can, but they are also doable in certain scenarios. So this is the difference between a Brostrom and a Gould. The Brostrom is a simple end-to-end double breasting and a repair of the ATFL, while a Gould, you take the extensor retinaculum and you augment the repair along with the torn ligaments. So you can do it arthroscopically. My go-to procedure has always been arthroscopic because it's easy to do, it's quick, less morbid, and you can harvest the extensor retinaculum with the special suture lasso that is available in the market, and you can do that arthroscopically. You can put suture anchors readily available in every part of the world now. To put it, this is the fibula, the anterior inferior part of the fibula. You can either use 2 single-loaded or 1 double-loaded anchors depending on what your practice is like. You can also use a hamstring allograft or autograft tendon repair. I would prefer to leave them for failed repairs. For example, if you already have done an arthroscopic Brostrom or even an open Brostrom and that has failed for various reasons, and you need to do something much more stable, you can use either one of those tapes which are available in the market, or you can use an autograft or allograft for repairing. I would prefer to use a tape because autograft allograft nowadays are not very available, and I don't want to harvest a peroneal tendon to cause further morbidity at a different site. Thank you so much. If you have any questions, we'll be happy to take it.
How long is repair? How late can you do it?
So as late as you can. It depends on instability.
The problem is that sometimes they come after 6 to 9 months.
Yes, sir.
Can you still repair them?
Yes, correct, sir. So it depends on the activity level of the patient. Sometimes after a bad injury, the patient may not go back to the normal activities for 3 to 4 months. And even after doing that, they will have a couple of sprains, and then they will come back to you and say, okay, I've had 2 more sprains after the intake sprain, and now I feel my ankle is even more lax. And that may be 9 months or even a year after the initial injury. It's never too late to reconstruct or repair the ligament. 1 year, 9 months, better to reconstruct than repair because a simple Brostrom may not work in those cases.
What about using augmenting with internal brace?
Yes. So internal brace is a good way of doing it. I am not against it, but I feel it's difficult to achieve the level of tightness or the desired level of tightness with internal brace. Sometimes you can over tighten it, and the problem with internal brace, since it is a rigid structure, it will not stretch out. The advantage with a tissue reconstruction is you can tighten it with all your might, and it will usually stretch out over a few period of months, so the patient doesn't complain of stiffness. I'm afraid that if I stretch out too much, if I tighten it too much, the patient will complain of stiffness and inability to go back to the same level of activity.
Okay. One question, what about the post-op rehabilitation in this briefly?
Yes, so post-op rehab first 2 weeks.
In the chronic tear repairs.
So in repairs, when I do the arthroscopic repairs, my rehab protocol is first 2 weeks. I put them on a plaster slab, not for tissue, not for ligament healing, but basically for the healing of the portals. I'm afraid I don't want him to do this because that will stretch out the arthroscopic portals and cause a portal sinus. So after 2 weeks, once the stitches have healed and he's out of it, I put him on a walking boot and ask him to walk. I ask him to intermittently take off his boot and do dorsiflexions, plantar and dorsi. At 6 weeks from surgery, which means 4 weeks of boot, I'll ask him to start graded exercise regimens, which means circumduction, inversion, eversion, strengthening with a TheraBand. At 2 months, running and spot jogging, gradually increase the activity. My ballpark is sports at 5 to 6 months. Once your proprioception is back to your normal level.
5 to 6 months for active sports I mean
competitive sports.
Competitive sports.
Some patients have gone back earlier. If you have a competitive athlete who is a cricketer and they're very motivated, they can go back to their activities at 3.5 to 4 months also.
I think the more than the internal brace, I think the gold modification works well for most of the patients.
Right.
So the inferior extensor retinaculum is really a fantastic local tissue, which give you the good, the on-table stability as well as you can stretch it out.
Stretch it out, yes.
But if you are operating a athlete patient who is a career dependent on the sports, so in such patients nowadays like all the guidelines are towards the internal brace. Taking out the tendon or hamstring is too much for them.
Too much for them, yes.
But the internal brace, so what these people are saying that you don't have to keep the ankle in dorsiflexion and the eversion.
Correct.
Like we do for the Brostrom Gold. You have to, while putting the internal brace, you have to keep the ankle in the neutral position.
Neutral position, yes.
That's
you can do
it.
that.
Yeah.
So that's the trick.
So,
that's the sleight of hand. That's the skill of the surgeon to figure out how much tightness do you want and how much you don't want.
So no tightness. So you said how much there should not be no tightness. I mean no tightness.
It's difficult to assess that in anesthesia, under anesthesia on table, but you can do that. If you're good at it, please go ahead.
There's one question from the floor also.
Yeah, I've got two questions to Kushalda and the panel. First, when is your go-to technique for internal brace? I mean, in which cases will you go for internal brace for sure? Because what I do is that I do not use it unless it's a failed ATFL reconstruction. And the second question is, when I use an internal brace, I have found a lot of fibrosis 6 months to 1 year down the line. So what are the tips and tricks to avoid that?
I don't have much experience with internal brace apart from doing it in failed cases like you do. Primarily, I haven't done internal brace. I think Girish, you have any experience with
that? In my more than 250 cases of ATFL repair, I have used the internal braces only 4 cases. My indication of using internal brace were morbid obesity. So one guy was 130 kg. Second, previously failed. So 2 cases were previously failed. And one was high demanding sports athletes.
Okay.
Rest all the cases we use the inferior extensor retinaculum as a graft.
I'd like to add a note on internal brace. See, the concept of internal brace has come from the knee surgeries. So where they do a lot of internal brace in the knee ligament reconstruction, all those things. The basic concept of using internal brace is, it is just a brace. Like how we put an external brace, it is just a brace to maintain the space. So whatever the healing has to happen, it has to happen in the tissue around the internal brace. And eventually, when there is patients like athlete patient or whoever it is, when they start playing sports or anything, all this internal brace are synthetic material, they will definitely give away. It will tear. So it is just to bridge the space and hold the space so that the soft tissue heals. So internal brace is a temporary option where the tissues has to heal around. Once the tissues heal around, the brace either breaks or it is left alone, it doesn't matter. So as long as there is an infection, we don't have to go and remove the braces or anything.
So do you use it regularly?
No, in the ankle I don't use it. In the knee we have used it, but now we have slowly given away. Actually, we have published one literature in Journal of Arthroscopy, level 1 randomized control trial for ACL and MCL. So the results are same. So there were 3 groups. For the MCL, we have used the internal brace as isolated procedure, repair and conservative. The results are same. But the internal brace caused little bit of stiffness in the knee. So, but ankle, generally, I have not used it. Maybe in 1 or 2 cases just to hold space.
I think one more indication would be hyperligamentous laxity,
Hyperlaxity, yeah.
In those cases,
but
they
the laxity patients, they have even less chances of ATFL injury. They are even extremely less chances of having ATFL, unstable ATFL injury, because they are always unstable.
They are always unstable, yeah.
So when we organized 2023 IFAS Con, we had a good discussion on the use of internal brace with the people who came from 12 countries in Nagpur. So, after discussion with everyone, what was the final conclusion is, most of the use of the fiber tape or the internal brace, they are company driven. They want to sell the brace at the 1 lakh rupees, and they are mostly
company driven. Look at the articles. Majority, they don't have a randomized, the control trials, or they don't have a cohort group where these are the patients where the brace were not used and these are the cases where brace were used.
I think that won't be possible because the Americans always put a brace.
They
the
are
Europeans tends to avoid it. So
they are all company supported articles. Look at them. Go to the literature. They are all supported. Look at the last disclaimer. They have been supported by Arthrex.
Can I ask one more quick question?
Yeah.
So in most of these cases, there is an OLT, which is osteochondral lesion of the talus, which is already there. So if there is no cartilage breach, do you repair it concurrently or repair the ATFL and let it heal and observe later on?
If it's painful, you should consider doing it. And painful with bone edema, you have talar edema and it's painful and you're anyways going to scope it, so you might as well do a microfracture or whatever your go-to procedure is and then repair the ligament. If it's not symptomatic, I don't know. I leave that open to the house.
So sorry, it depends on the stage. So if there is a break in the cartilage, even though there
is no break in cartilage,
don't operate it. Just take care of the instability.
Okay.
It will
That's my
remodel.
question.
Yeah.
That's fine. Thank you.
Yeah, thank you all speakers. So this session is completed here. Inviting next speakers and the chairperson.
Thank you so much for this wonderful session. Moving ahead, I would like to invite our chairpersons, Dr. Kingshuk Mondal, Dr. Amya Kumar Bera, Dr. Abhijit Sharbidhakari, and Dr. Gaur Gautamkar to please come up on the stage and proceed with the session.
Hello.
পুরোটা কেন দেখা যাচ্ছে?
চলো,
ঠিক আছে,
okay,
ঠিক আছে।
thank you.
Good morning. I am Dr. Ashwin Chaudhary. I am going to talk briefly about a very common condition, which we all face in our day-to-day practice, plantar fasciitis. So, hello. So, plantar fasciitis is a painful heel condition. We all see that. It is caused usually due to the inflammation of the plantar fascia, the aponeurosis where it originates at the medial calcaneal tuberosity of the heel. Common people perceive it as a heel spur. I think that's a misnomer. The pain is not to the heel spur. The heel spur is actually an effect and not the cause of heel pain. There are many diagnoses, which we need to think of as a differential diagnosis of heel pain. However, plantar fasciitis is the most common cause of heel pain. It is initially difficult to treat. The good thing is plantar fasciitis is usually self-limiting. By about 12 months, 80% of patients become pain-free. Very few patients actually need surgery for plantar fasciitis. Less than 5% of patients need surgery for plantar fasciitis. Surgical results are very equivocal. In the US, people who have to stand for long hours, plantar fasciitis is one of the common causes of workmen compensation claims. So what is plantar fascia? The plantar fascia is a thickened fibrous aponeurosis that originates from the medial tubercle of the calcaneum, runs forward to insert into the deep, short transverse ligament of the metatarsal heads, and divides into fibrous bands which continue forward to form the flexor sheath of the flexor tendons at the toe level. The plantar fascia has three distinct parts: the lateral, the central, and the medial band. The central band is most commonly involved in plantar fasciitis. It is also the thickest and the strongest part of the plantar fascia. Normally, the plantar fascia, it acts like a windlass. It provides tension to the medial longitudinal arch and supports the medial arch. So biomechanical dysfunction of the foot is most common etiology which causes plantar fasciitis. Excessive stretching of the plantar fascia can result in microtrauma at the insertion at the medial calcaneal tuberosity usually, or anywhere else in its course. This microtrauma, if repetitive, can result in chronic degeneration of the muscle fibers. This also can lead, the adjacent muscles, the abductor hallucis, the FDB, and the quadratus plantae. They also originate at the medial calcaneal tuberosity, and they can get inflamed along with. Usually, plantar fasciitis is seen in the middle age between 40 to 60 years of age. Men and women are equally involved. They can be bilateral in a third of cases. Sometimes patients with seronegative spondyloarthropathies can have plantar fasciitis. However, most of plantar fasciitis, 85%, they are idiopathic. Risk factors for plantar fasciitis include obesity, activities which involve increased weight bearing and endurance such as dancing, running. Some risk factors for plantar fasciitis include pes planus, pes cavus, LLD, increased tibial torsion or femoral anteversion. Pes planus, it increases the strain at the origin of the medial calcaneal tuberosity and causes plantar fascia. On the flip side, pes cavus, it increases the strain on the fascia itself, does not allow the heel to absorb shock and cause pain. Tightness in the hamstrings, the whole posterior chain actually, from the hamstrings to the gastrosoleus to the Achilles tendon, they are a risk factor for plantar fasciitis. And this is important. Stretching the posterior chain has shown to decrease symptoms of plantar fasciitis. So plantar fasciitis is initially a clinical diagnosis. You don't always have to get images in the first stage itself. You need images or investigations if you start suspecting other causes of heel pain, or if the patient has not improved after a reasonable amount of time, or when you start thinking that you're going to start giving injections and things. You do want an X-ray before you start giving injections for plantar fasciitis. Common differential diagnosis for plantar fasciitis include calcaneal fractures, especially stress fractures, infections, neoplasms, space-occupying lesions, tendinopathies involving the TA tendon or the flexor hallucis longus tendon, entrapment neuropathies. Baxter's nerve entrapment neuropathy is very common and should be considered as an important differential diagnosis for plantar fasciitis. Other common conditions include tarsal tunnel syndrome and not so common Morton's neuroma. So once I see a patient who is beyond 3 to 6 months with heel pain and not getting better, that is when you start thinking in terms of investigations. You start off with getting X-rays, which reveals a heel spur. Like I said, the heel spur delineates the presence of abnormal stress across the fascia for at least 6 months. It is not the cause, but a sequelae to the process. X-rays should be obtained before giving injection to make sure that you're not missing anything else. Weight-bearing X-rays of the hindfoot may show structural changes such as pes planus, pes cavus. So 50% of symptomatic patients will have heel spur. On the flip side, 20% of normal population also have heel spur. Heel spur does not have anything to do with the plantar fasciitis, except that it's easily seen on the X-ray, and people start thinking the heel spur is causing the disease. MRI not needed initially. Once the patient is not getting better, you start getting X-rays, you start getting MRIs. You want to see whether the plantar fascia is actually inflamed or not. You want to make sure that the fascia is not torn or ruptured partially or completely. It helps you to plan things if you want to operate on them. Bone scans less commonly needed. It is important to rule out neoplasms, to rule out stress fractures sometimes. It can show an inflammatory focus around the plantar fascia origin. EMG is useful to rule out neurological entrapment syndromes, especially the Baxter's nerve entrapment neuropathy. Your abductor digiti minimi brevis, it will show abnormal signals in the EMG for Baxter's entrapment neuropathy. So like I said, plantar fasciitis usually is a self-limiting condition, and about 90% of them will heal without surgery by about 12 months of time. Treatment should begin early and should be multimodal. You add 6 weeks or more of icing, stretching, NSAIDs with physiotherapy, strapping, taping, and various forms of orthosis or splints. For icing, you tell the patient to freeze a bottle of water, put it below the foot, and roll it around, in a circular fashion for 5 or 10 minutes. For an ice bath, a shallow container filled with cold water is taken, and the patient soaks the heel for about 10 to 15 minutes. You ask the patient to alter his activity level, either decrease the exercise, stop running, dancing, modify exercise, and these help. These bring down the amount of pain. Icing is helpful. You add painkillers along with it, usually oral NSAIDs. So cushioned footwear, they are readily available in the market. They help cushion the heel and help decrease the symptoms of plantar fasciitis. Orthosis or shoe inserts are helpful. Night splints may be used. If the patient is having pes planus or pes cavus, you can use tapes or arch supports to help patients. So normally when people sleep, their foot tends to go in some amount of plantar flexion, which causes the plantar fascia to contract. And when they get up in the morning or when they stretch it, the plantar fascia stretches, it gets a micro tear which causes pain. What do night splint do? They maintain the foot in a neutral position, in a 90-degree foot leg angle, provides continuous passive stretching to the fascia. And studies have shown that a high percentage of patients with night splints have improvement in their symptoms. Physiotherapy, it does help patient in long-term relief. You teach them how to stretch their posterior chain, to stretch the hamstrings, to stretch the gastrocnemius, to stretch the soleus and the TA. So wall stretching exercises with the knee in both flexed and extended positions, stair stretching, using a towel to stretch, they are all useful. And there is a study which showed that 83% of patients treated with stretching exercises by itself, found relief. Shockwave therapy has been used to treat plantar fasciitis. What shockwave therapy does is it increases the blood flow locally and it simulates an immune response and simulates healing. Shockwave therapy is non-invasive, less side effects, and studies have shown that it does give some good amount of relief in patients with chronic plantar fasciitis. Once the patient does not respond to conservative measures, various forms of injections could be used, commonly being steroids, blood products such as PRP. Steroids can be given locally or with ultrasound guidance. The good thing with USG guidance is you prevent complications due to incorrect placement of steroid injections. You have to be careful with steroids because steroids can lead to infection. They can cause full thickness plantar fascia rupture. Repeated injections can cause fat pad atrophy. Fat pad atrophy is a bad complication, difficult to treat. So there are studies, there's one study which says steroids provide good short-term relief while blood products provide good long-term relief. There's another study which says that 2 years the results were equivalent, same. So what do blood products do? Again, the same thing. They stimulate an acute inflammatory reaction. They provide factors for stimulating fibroblastic activity and vascular growth, thereby lead to healing of the microtrauma. Results are equivocal. Very few patients of plantar fasciitis actually need surgery. Once they've been symptomatic for up to 12 months and once conservative methods have failed, one can think of surgery. Surgical procedures include percutaneous plantar fasciotomy, whether open or endoscopic or percutaneous, plantar fasciotomy with tarsal tunnel decompression, gastrocnemius recession, and bipolar radiofrequency microdebridement. So plantar fasciotomy can be done through an open, percutaneous, or endoscopic approach. The endoscopic approach has an added advantage of decreased morbidity and lesser complications such as nerve injury. Surgical results are variable, 70 to 90%. It does not guarantee a complete outcome. You can do a partial or a complete plantar fascia release. Complications are common. The commonest problem with the plantar fascia release is you do a complete plantar fascia release or the remaining fascia ruptures after the surgery and then the medial arch collapses. You increase the stress on the dorsolateral aspect and the patient keeps complaining of dorsolateral pain. There are people who say you do a Baxter's nerve release as well when you are doing a plantar fascia release. Gastrocnemius recession can be effective, especially in patients who already have a tight who've got a Silver's gold positive and who have not responded to conservative treatment. Isolated gastrocnemius proximal medial head recession or medial recession is supposed to be effective. It has less complications as compared to a plantar fascia release. My experience is very limited. The top 3 images actually are of one of my patients on whom I did a gastric recession of the medial head, of the medial gastroc actually, he did get better. His dorsiflexion improved. The patient continued to complain of some amount of pain even after 6 months. Bipolar radio frequency microdebridement is a new percutaneous treatment which applies a bipolar radio frequency pulse to the plantar fascia. It is supposed, the heat generated there is supposed to alter the nerve function to bring down the pain. It causes an inflammatory response over there, which causes healing and new vascular generation. Results are comparable to surgical release. Advantages being decreased morbidity and decreased complication rates. So to summarize, plantar fasciitis is often a self-limiting condition. Symptoms tend to resolve within 12 months. A comprehensive, multimodal and a patient-centric approach is necessary. Steroids may offer relief in short term. Long term, their efficacy is limited. PRP blood products may be used. Very few patients need surgery. Surgical results are equivocal. You cannot guarantee good results with surgery. Thank you.
Thank you, Ashwin. I think we can go over to the next, and then the questions might come together after the next session.
So now I invite Dr. Girish Motwani to talk on a subject whose name changes every 10-15 years, I think. Previously it was IOA-IFAS, then changed to...
Still the lovely word is...
Lovely word, huh?
Lovely word is still flat foot.
Still flat foot, but the...
Too easily understood. Doctor and patients and relative all are familiar.
Yeah.
Some patients, they come to us, that doctor, I have, what's your problem? So they directly say, I have a flat foot.
Mike.
So the word flat foot,
yes.
Now that we are discussing that this word is evolving nowadays. So initially it was called flat foot, then pes planus, and then tibialis posterior tendon dysfunction, then adult
PCFD.
acquired flat foot, and nowadays we
PCFD.
say PCFD, progressive collapsing foot deformity. So, so the names are changed, but the lovely word is still flat foot because it is familiar to everyone. So I'll show few cases like to have an overall idea. We are not here to understand everything. What is in flat foot or what is in tendon dysfunction in 15 minutes. But the purpose of putting this talk in this meeting is to have an overall idea that what are the patients who need surgery, what kind of surgery, how can we treat them conservatively and everything. So let's say what the patients say to us. 10-year-old boy coming to me in my OPD chamber saying that, doctor, I have a bad foot pain on a sports activity. See, when you see the 100 childs having a flat foot, 6 or 7 may have this complaint. And there are 2 to 3 patients out of them who are having a significant complaints. Like they are not even able to do the routine sports activities. See, walking is not a problem in flat foot. The problem is sports activities. The problem is high strenuous activity. The problem is overstanding or using the foot for long period of time. So only when you have this situation, it hurts. It's like a osteoarthritis of a knee joint. So you can live it throughout a life with a OA knee, but when it becomes create a disability pain, it needs attention. Now what we generally see is we tell the patient to walk on or to stand on toes. Now what do we see here is whether the deformity is flexible or not. The flat foot has a heel valgus. So whether this heel valgus is correctable or not, you can see on this tiptoe rise. See, my heel is correcting into neutral position or the varus position. That means the deformity is flexible. You are not dealing with sort of collision or arthritis or anything which creates a rigid deformity. So the X-ray was done for this patient because he has a pain, significant pain on the medial talonavicular joint.
This was the X-ray done, and what the X-ray is showing here is the pain is more than 1 year, so it need attention. Bilateral flexible flat foot deformity. There is no collision because we have seen that the deformity is flexible. Now you can see what you have to do in the initial stages. You have to give the orthotics and a stretching protocol. That should be the part of our treatment, although it never works. I am giving you the direct clear answer. It never works on the severe deformity once it is painful. But you can delay the symptoms or you can make it little bit better. And that's why the new term for the flat foot is called PCFD, progressive collapsing foot deformity. But because once you are flat, it is progressive. You cannot be normal or you cannot get the arch back by doing a orthotics or the stretching exercise. It is progressive. After 2 years, you will find more flat foot. After 5 years, you will find more flat foot. You will not find the regression of a flat foot to the normal foot. That's why the new terminology is PCFD. Anyway, so you have to give orthotics and the stretching. Okay, your treatment is done. Now you have to ask the patient to come on every 3 months. If the patient are responding, that's fine. Delay your surgical protocol or don't do anything. But if your patient is keep coming to you with a constant pain on the medial talonavicular joint, you have to assess few angles like talonavicular uncoverage. Look at here. The navicular is subluxated. More than 50% of the talonavicular joint are subluxated. Or you see the naviculo-cuboid overlap on the lateral view. Whole of the cuboid is covered by the navicular bone. Heel is in valgus. Recurrent talotarsal subluxation is sometimes the new word we use. And there is a medial column instability also. Sometimes you develop the forefoot varus also. Fortunately, this patient they don't have. And these are all the angles which we see. So these are first metatarsal and the talar angle. AP and lateral, whatever you are saying is what you have to see is the Meary's angle or the talar axis first metatarsal angle. That is the only one angle in the flat foot which all general orthopedic surgeons should keep in the assessment part. Talus and the first metatarsal. And what are the surgical options in a 10-year-old, painful, flexible, adolescent, having no other comorbidities? EOTTS is called extraosseous talotarsal stabilization using a stent. So we'll see what is it. So there are various options. What is the best option for a 10-year-old child is don't do too much invasive surgery. Don't do osteotomies. Don't do too much ligament reconstruction. There is a stent which is called sinus tarsi stent or the arthroresis or EOTTS, various words. And look at just a 20-minute surgery, putting a stent into the growing sinus tarsi can correct all the deformity. Now look at the talonavicular joint, it is corrected. Look at the lateral subluxation, it is corrected. Look at the arch, it is get back. And this is minimal invasive, just a 2-stitch surgery, no immobilization. You can keep the patient walking on day 1. They just walk awkward for 1 day, for 1 month. And this is a hind foot correction, showing a very good correction of the heel valgus. So these are all the benefits of using a sinus tarsi stent in a pediatric population. People are using for the adult also, but I don't use in adult, I use in pediatric population or in adolescent population. There are some disadvantages also. Pain. You may have a pain ranging from 5% to 46%, but they are generally short-term pain. You may need to remove the implant sometime when the implant is displaced, overcorrected, or you may develop infection. Infection can happen to any implant. And most of the studies, they are now low evidence level. But this is a future for the pediatric, because now we are having a pediatric meetings combined with the foot and ankle meetings, and the people are very happy to use this arthroresis in pediatric or the adolescent age group. So minimal invasive the flat foot correction in a pediatric flexible deformity is really a good option is this sinus tarsi stent. Coming to the case, second case, a 14-year-old boy having non-resolving medial foot pain. They tried everything. Again, this patient has a pain on the sports activity and the location of the pain is medial. Now look at here, he is also an adolescent guy, but look at a valgus, it is too high, the talonavicular angle are subluxated, but the arch is not very bad. So why the arch is not bad on the lateral view, but on AP view and the hind foot alignment view, you are getting a finding of flat foot deformity, but you are not getting the finding of flat foot deformity on the lateral view. In the lateral view, it looks a good arch. So if you offer the one X-ray lateral view, you may misdiagnose it. But look at this C sign. Look at this C sign. You are not able to see the sinus tarsi properly, and you are able to see the overlap of the talus on the calcaneum. When you find this C sign, it is actually a collision syndrome. It is a rigid flat foot deformity. Now this child cannot be treated with a sinus tarsi stent. You need to remove this the collision when you want to correct the flat foot deformity. Look at here, this is a big collision, and look at the opposite side, there is no collision. Now what is the resection criteria here is, so when you find no arthritis, when your hind foot valgus is less, or when your collision is less than 50%, you resect it. But if you have an adult child, or adult person, or you have heel valgus is too high, or when the patient presented too late, arthritis is already developed, then you have to do the fusion. There are only two options: interposition arthroplasty versus fusion. So after the collision excision, because he is just a 14-year-old, and a correction of a heel valgus by this osteotomy, look at this correction. This is, and now the foot is moving in almost all direction. Initially he was not able to do the circumduction movement, but now this child is able to do everything because the collision is removed and is doing well. So the take home message, if the collision is less than 50%, so the symptomatic relief is resection of the subtalar collision. It usually reduces pain, it improves the mobility, and corrective osteotomy, it gives the additional benefit of phenotypic correction. Early intervention is better for the prevention of subtalar arthritis. Excise this, fuse this. They are the two type of collision. So this is general the resection criteria. Now look at an adult patient here. Now forget about the adolescents. Look at a 50-year-old female coming to you with the pain since 2 years. Doctor, I have tried everything, medial arch, AFO, plasters, walker boot, everything I have tried. Now I have this progressive pain on the talonavicular joint, medial joint. Now look at this pain arrow. This is the area of pain. Usually the flat foot patient, if they complain of the pain here or laterally, they are usually because of flat foot. If they are complaining of forefoot pain, or if they are complaining of the ankle pain, they are usually not because of flat foot. The two main area of the pain is medial and the lateral to the talonavicular joint. Look at the angle here, it is disturbed, Meary's angle disturbed, Meary's angle disturbed, hind foot alignment view showing significant deformity. Normal hind foot valgus is 7 degree. So these are the cases where you need attention. As an orthopedic surgeon, our aim is to at least diagnose in a weight-bearing X-ray that whether this patient is a candidate for a conservative treatment or for the surgical treatment. Look at the phenotypic alignment. This is the location of pain. So if it is a pain over the talonavicular joint medially over the foot, this is a symptomatic case. Look at this hind foot valgus. MRI to see the tendons and the ligaments, they are all bad. Now this is the classification, there are various classification, but what is the classification we follow nowadays is PCFD. This is class A, B, C, forget about it, I will make it simple. So whether this classification helps? No, because it just actually helps to combine, or it helps to put a label on which kind of deformity the patient has, but none of the classification helps in the treatment. So it should be the customized treatment for all the patients. So assess the deformity, where is the soft tissue problem, whether the gastrocnemius is tight or not, what is your medial column, what is your lateral column. So this is overall a very good classification. Those who are interested to learn the flat foot deformity, this is the classification for you guys. Only follow this classification. PCFD, this is one of the best at present, 2025, this is the most acceptable classification. Now, you don't have to worry about the classification. This is stage 1. Stage 1 means flexible, and when you have a forefoot deformity or when you have a talonavicular collapse, it is called A and B. Anyway, so rather than going to the classification, how to manage this situation? This is flexible, non-arthritic, 50-year-old female, not a young patient, I mean not a adolescent patient. So you need to do the osteotomies, you need to do some ligament reconstruction, and you may need to do some forefoot osteotomy. Let's see what I have done here. But what is the medial failure? What is the source of pain? It's a tendon, spring ligament, or the deltoid ligament. There are only 3 structures on the medial axis. There is no lateral column shortening here. So what is actually the source of pain? It is very important to understand that this is a normal deltoid spring ligament. This is the abnormal deltoid spring ligament. So what is happening is basically the abnormality or the laxity or the tear of a tendon or a ligament which is causing this subluxation medially. So whether whether to use a lateral column lengthening or just to repair that ligament is your personal choice. Now look at a problem here. Okay. Now see, this patient had a failure of a flat foot reconstruction. This patient has undergone flat foot reconstruction by Americans in steps to walk, but unfortunately it failed. This is the laxity. Now look at here. Now I am stabilizing the deltoid and the laxity is gone. Patient is not subluxating the talonavicular joint. But look at now. Look at this. Talonavicular subluxation. When I don't stabilize the deltoid, the talonavicular is subluxated. Americans didn't fix the deltoid and the spring. They did an osteotomy and it failed. So nowadays the concept is deltoid spring complex. This is the problem in flat foot, in an adult acquired flat foot. If this structure is not working, which is sometimes called TBO calcaneonavicular ligament, or easier way you can remember deltoid spring complex. There is nothing deltoid, nothing spring. Both are same. Both are one and the same structure. So if you redo the reconstruction of this whole area, your problem will solve and you do the best reconstruction at present. So this is one of there are few articles which are working on this deltoid spring complex. Don't go in detail because the message is same, that this is our own article in the West Bengal, this Orthopedic Association journal. We published 20 cases in last year, and the foot, which was the British Foot and Ankle Society article, this journal, we published recently a novel technique of deltoid spring reconstruction in 40 cases, and we have given the algorithm to the world that what kind of reconstruction should be done. So I am quickly going into the procedure which we have done. The same case, okay. Now what we have done here is, look at this MIS hallux valgus, the MIS calcaneal osteotomy. So here we do we first start with the osteotomy, medial sliding calcaneal osteotomy, to shift to correct the heel valgus. So if there is a 25 degree of the heel valgus, you have to shift by 1.5 to 2 centimeter. This is the MIS osteotomy. This is shift. This is fixation with 2 screws, headless or the CC, whatever you want, from lateral to medial. And after doing osteotomy, this is the tendon. Now medial exploration. This is a tendon which usually are okay. Although it is said that tendon is a problem, usually it is fine in our Indian patients. What is the problem is deltoid spring laxity or the deltoid spring tear. So look at a reconstruction here. Don't go into the detail, but this is a sustentaculum and this is the navicular tunnel, and through the navicular tunnel we are passing the fiber tape, and now we are fixing the tape, both the ends, sustentaculum and the navicular, into the deltoid footprint, into the distal tibia, and this is a way of correcting this technique. This is, now look at the same patient and look at the alignment now. Everything is corrected from sagittal to the hind foot axis to the lateral view. Everything looks perfect. This is 2-year follow-up. Good arch, patient is doing well, and see how she is walking with the good arch. There is no collapse and the patient is really doing well. So I'm not going into the detail of the Evans osteotomy and all. There are few cases where you may need to add the forefoot osteotomy also. We called it Cotton's osteotomy or the first MTP fusion like this. This could be the part of the flat foot reconstruction, but not very commonly. This is the final outcome of doing the same reconstruction using a forefoot osteotomy or a fusion surgery. Sometime when the deformity is rigid like this, look at here, 52-year-old female, now she has a pain on the calcaneofibular region. She has a pain on the subfibular region. And look at the walking pattern. Now how she is walking. So adult patient, rigid deformity, severe deformity, arthritis already settled, don't do osteotomy, go for the triple arthrodesis or the double arthrodesis. Look at how they walk. They are completely rigid and it's non-correctable. So this is the X-ray which is showing a significant subfibular impingement, and look at the heel valgus and pushing the fibula and causing the lateral pain. So we do the gastrocnemius resection, we do the sinus tarsi approach for the subtalar arthrodesis, and then talonavicular arthrodesis. This is called double arthrodesis. Preparation of talonavicular joint, preparation of the subtalar joint, and then fusing everything into the aligned position. Look at here, this is well aligned with the fusion because it's a rigid deformity, and look at the phenotypic correction, pre-op versus post-op. Heel valgus corrected to neutral, the arch revert back. So this is a triple arthrodesis, which is double arthrodesis, which is very important when you are dealing with a rigid flat foot deformity. So these are all the supportive articles. Thank you so much, and sorry for taking the long time.
Thank you.
Dr. Motwani, thank you very much for the nice presentation.
Thank you, sir.
Sometimes we receive patients in our clinics, elderly flat foot. You never know whether this is a primary flat foot or because of ligamentous laxity. Often we find, but the patient presents with ligamentous, flat foot, but they don't know that they had flat foot. They present with knee pains, and with thorough examination we find that she has got significant amount of genu valgum, and then we discover that the genu valgum is secondary, the pes planus is the primary pathology.
Yeah.
Now we have tried with corrective shoes, etc., but it's very difficult at this age for the patient to tolerate the corrective shoe with the arch support.
Yes.
So what is your this thing?
I think it's a fantastic question, and it's a daily routine problem in our OPD that whether is the deformity is coming from the knee or it is a sole flat foot deformity at the foot. So I think it's a very fantastic question. So in general, if the 50-year-old patient coming to us, she may have a pre-existing flat foot deformity since birth, but generally they present at the age of 20-30 years. If she is presenting to us at the age of 50 years with a flexible deformity, usually it is because of the degenerative changes in the spring ligament or the tendon after the age of 40 years, usually. But those patients who are having a pre-existing flat foot, they develop symptomatic flat foot in the later age as well. But by the time they present to us, they already become arthritic. So if they are flexible and presenting in the late age, usually it is because of adult acquired flat foot. But if it is early presentation, it is usually because of pre-existing or the since childhood. Coming to your second question is whether the deformity is coming because of the because of the knee valgus or not. All the genu valgum patients, they do the overpronation of a foot, and when you examine them, they are generally they are not rigid deformities in the foot. They are usually correctable deformity because it is because of knee deformity. So arch, they never work if the pes planus is because of genu valgum. These are the usually cases which are very rigid cases, not even responding to the arch. In such cases, only the one thing which works is a stretching therapy. Otherwise, these are all the cases where if they once they are symptomatic, they need surgery. Surgery for the flat foot reconstruction. But symptomatic flat foot, only because of genu valgum, they are the rare situations. Yes.
Hello.
That question is there any change in your protocol in case of high Baton score patients, say Baton score 6, 7, 7 like that? Hypermobility disorders.
Hypermobility. So yes, so all the hypermobile children, they should have a flat foot.
Not children, I'm talking about say around 25, 30 years old persons.
So hypermobility, yeah, so hypermobility, they usually have a flat foot problem, but they are asymptomatic. Most of the time they are asymptomatic.
I'm talking about the symptomatic flat foot patients or PCFD patients.
Then you have
also
to
have this high Baton score.
Yeah, so if you are dealing with a symptomatic flat foot with a generalized ligamentous laxity, you have to involve more bony osteotomy and less soft tissue reconstruction. Like the way we have described, soft tissue reconstruction, deltoid spring reconstruction.
Because those will fail.
They usually fail. So you have to do the lateral column lengthening and all bony procedures.
Yes.
Yeah.
Thank you very much.
Dr. Girish, one last question. One last question. So, fantastic presentation, clear concepts. Want to ask one question. So, when do you recommend the spring? When the talonavicular uncoverage is more than 30 or less than 30? 30 is like the guideline we have kept. So, when it is flexible and it is more than 30, and in the AP view, when you see that the head is out, that is when do you recommend, or any other criteria?
So, that is the algorithm we have given to the foot, which was just published last month. So, the algorithm is, if your subluxation, talonavicular subluxation is between 30 to 50, you have to do only tibio-navicular reconstruction. Don't put a sustentacular screw. Tibio-navicular. This is also deltoid spring. Tibio-navicular component of the deltoid spring. But if you have a subluxation more than 50 degree, then you do tibio-navicular calcaneal. So this is quadrangular repair. First was triangular repair. So we have given
less than 30, no need for a spring.
Yeah. So more than 50, you need deltoid spring, quadrangular repair. 30 to 50, you need repair, but not too much. Tibio-navicular, triangular repair.
When do you add FDL? I know you will tell that tibial is posterior.
So if your tibial, so this is just about the ligaments. So if your tendon is not good, if your tibialis posterior is degenerated or it is rupture, then we have to add FDL. But usually, sir, whenever you are operating PCFD of our Indian patients, you find that the tendon is stretched out, but it is not rupture.
It's not ruptured.
It's not ruptured. It's a healthy tendon. It's a healthy tendon. So nowadays, people are doing a distal migration of a tibialis posterior tendon also. They take out the tendon from the navicular and they put it to the medial cuneiform just to make it stretch.
Yeah.
And it gives the arch.
Yeah, that's a very important point. This spring ligament is the hammock for the talar head.
Yeah.
Like we find the hammock in the shoulder.
Yes.
The inferior glenohumeral ligament, it forms the hammock. So that is why the PCFT and then the collapse.
And more than that, spring ligament, it is a static stabilizer. Tendon is a dynamic stabilizer. So if you rupture the static stabilizer, you are always deformed. Tendon can just correct it dynamically to some extent, but once it is flat, that means it is the rupture or the laxity of a deltoid spring complex. It has to be repaired.
Yeah. One last point. This internal brace stuff, I'm still not convinced. Rather, I would take tendon, soft tissue.
You can use the tendon also.
That should be the better way.
Yeah.
As I told, all these internal brace will break out eventually.
So that's what.
Because that's a synthetic material.
So it is not just the fiber tape. It is basically the Kairos tape, which is a scaffold. The people are using for the standalone ACL also.
Okay, that's a different debate.
Yeah, that's a different debate. Yeah.
Thank you.
The responsibility of a deltoid spring are less. It cannot be compared with the ACL. It is just a movement of one plane. ACL, it works on many planes, and it has the lot of responsibility. Why the tapes and the foreign bodies are itself enough? Because it has a less responsibility. Talonavicular direction, adduction and the abduction, that is the only job you need to restrict with the tapes. That's why. Yeah. But you can use the tendon, yes.
Okay, we finished this session. Let's go on for the next one.
Thank you so much for this wonderful session. Moving ahead to next session, I would request Chairperson Dr. Kushal Nag, Dr. Soumitra Misra, Dr. S.R. Bala to come up on stage and proceed with the next session.
Yeah. Good afternoon once again. Coming to the simpler topic, thanks IFAS. It's a part of the IFAS program which is happening across 7 cities across India. And this case and presentation is not from me, they have provided from the IFAS. Thanks Dr. Abhijit for this opportunity. So going to the case example, there is a 18-year-old male with no history of pain but lot of pain and disabling condition on the medial side of the foot, where there is a lot of pain for last 6 months, and the pain is intense after certain activities. So what do we look in the clinical examination? So the clinical examination, like excellent session by flat foot talk by Dr. Girish. So this case had the flat foot, the flattening of the arch, the heel valgus was there. There was a prominent tibial tuberosity. This was a flexible deformity, and the heel rise there was possible, but it was painful, and silver screw test was positive. So this was the X-ray where the talon Mary's angle, the axis of the talus to first empty shows that there is an increase in the Mary's angle, and also both in the AP and the lateral view. These are the things which we have to look for, and this obvious case of the accessory navicular, which causes a lot of severe pain on the medial aspect of the foot. So the radiological findings showed that disturbed Mary's angle in weight-bearing view of AP and lateral view, and in this case the talonavicular uncoverage was less than 30 degree, but there was a accessory navicular of type 2 GIST classification. I'll tell about the classification, what it is, and what shall be the conservative management in these cases. Main is to reduce the pain. Can give the orthotics, the arch support, the valgus insole, the thermal therapy, ultrasound therapy for a reduction of pain. We can try the conservative modalities. Most of the patient would improve with the conservative modality, but then a few subset of patients would definitely go on for a persistent pain, and then they would come for a repeated consultation of these conditions. So the indication would be the persistent pain despite the conservative management. The flat foot deformity definitely needs to be addressed with the heel valgus, and the symptomatic accessory navicular confinement in the X-ray. The standard approach for this would be the lateral approach, and then approaching it from the medial side, and for the silver skull positive gastroc release can be done at the musculotendinous junction and the MCDO medial. Since all these are being covered, it's just a repetition of just going through this. And medial displacement, calcaneal osteotomy. The supine position, we can identify the accessory navicular or the curvilinear incision over the medial malleus, the accessory navicular tuberosity, which is exposed, and it can be detached. So what we need is, and watch the spring ligament and deltoid, whether it is intact, ruptured or flattened out, and then try to preserve the plantar attachment of the tibialis posterior, because the tibialis posterior is the one tendon which is attached to all the tarsal bone, not only to the navicular. So the plantar aspect needs to be retained for the attachment, and excise only the accessory navicular portion, and then the remaining portion can be reinserted in after the excision of the navicular, can be reinserted into the navicular. But only thing is, we are trying to kind of take a little bit of tendon out and then do the advancement. So that gives the lot of stretch and pull to the tibialis posterior. That is the advancement of the tibialis posterior tendon. Either it can be attached with the suture anchor, or a tunnel can be drilled in the navicular and then passed through the navicular, and then can be fixed in this fashion. So this is a post-op X-ray where tibialis posterior is reattached, and the talonavicular uncoverage was less than 30 degree, as I was discussing with Dr. Girish. So only the tibialis tip posterior advancement was done. The post-op immobilization would be for 6 weeks, and non-weight bearing walking for 4 weeks, then full weight bearing after 10 weeks, and sports activity after 4 to 6 months. So this was the post-op follow-up X-ray after 4 months, where the MCDO and the tibialis posterior advancement was done. And then here we can see that definitely there is a arch recreation compared to the pre-op X-ray, and the hind foot valgus is also being corrected. The patient had a good normal gait as well, without pain, comfortable. So this accessory navicular as a part of flat foot is a bit of disabling condition, and generally after the failure of conservative management, if patient comes repeatedly for consultation for the pain of the medial side, it's a worthwhile simple procedure to be done. And generally if there is a valgus, then we have to go and do the MCDO as well, which has been where this procedure is called Kidner procedure, where it is done for the accessory navicular syndrome, for which the MCDO and tip posterior advancement surgery is done. So the accessory navicular is nothing but a piece of extra bone or sometimes cartilage located on the inner aspect of the foot, just above the arch. It is incorporated within the tibialis posterior tendon, and these are usually present since the birth, so it means it's congenital, and it is located on medial border of the navicular, associated with tip posterior pathology, tendinitis or tendinopathy, or they are because of unfused ossification centers. The synonyms are os tibial externum, or navicular secundum. Usually it is 21% of patients who have this incidence, and 89% have bilateral. So this is the GIST classification, where there is, you can see that there is a small sesamoid 2 to 3 mm. It's about 30%, but most common is about 50%. This is the failure of secondary ossification center to fuse, or there is a prolonged or elongated navicular where it is fused, and it's seen in about 20% of patients. These are very simple classification to be remembered. The signs and symptoms, there will be a medial prominence and sometimes reddening and swelling and vague pain and throbbing pain, which is not which can cause skin irritation and kind of swelling. The X-ray will definitely show. The MRI may be needed just to identify the spring ligament pathology, whether it is stretched out or not, or generally it is not required. It is usually associated with flat foot. The secondary Achilles contractures can be seen. There can be bursitis, redness, irritation, and usually it is seen in young adult patients where there is medial arch pain. So the conservative management would be rest, avoiding the athletic activity, anti-inflammatory, shoe wear modification. Usually it will subside. Around 20 to 30% of patients may not be responding to the conservative management, so which needs a surgical intervention. As I told, Kidner procedure, excision, and kind of advancement of the tip posterior tendon may be combined with MCDO, that is calcaneal osteotomy, if there is a hindfoot valgus. So to conclude, Kidner's procedure is nothing but excision of accessory navicular and tibialis posterior tendon advancement. The indications are for the failed conservative management, relieves pains and restores the tip posterior function, and osteotomy if it is a flexible flat foot, and proper patient selection and rehab are essential. Thank you. So I take this opportunity to invite to our institute. We are having arthroscopic course. So on 3 days, and we'll be doing 25 live surgeries and good learning opportunities from panel discussion and debates. Thank you.
Hi Ramakant, I have one small question for the entire house. What happens if that, wonderful procedure by the way, so what happens if that guy has an open calcaneal apophysis? Would you do the Kidner in isolation, or would you, how does your thought process change?
Girish, you want to answer that? In young adolescents, we don't do actually. Maybe all these are, considered for adult patients or adolescent
They are symptomatic.
patients.
I get a lot of kids at 10, 12 with accessory navicular pain.
So as I told, almost 70 to 80% of patients are relieved with the conservative management. It's only when the patient are not happy about the conservative or failure of it, and then they keep coming repeatedly back to us.
Would you recommend an isolated Kidner? That's what my question is.
So if we get the patient's symptomatic accessory bone with the open physis, I just do the hypercure, sinus tarsi stent. Only sinus, because it offloads the medial column by 70%, and there are the ample amount of study which say that the pain, which is because of the biomechanical overloading of the synchondrosis between the accessory and the normal bone, which is a source of pain, it resolves.
So you're approaching the problem from a different angle.
From the different, in the open physis, but when the physis is closed, then we do the same. Yes.
Since I'm a pediatric orthopedic surgeon, I usually get this type of patient with type 1 accessory navicular. So what is your take on that? Sometimes after even conservative treatment, the parent says or patient says that I'm having difficulty in the form of deformity and pain and tenderness. So do you advise excision of that accessory navicular? No.
So
Only
they are
excision.
deformed. So they are painful only because of biomechanical overloading of the synchondrosis. That's what we are saying. The cause of pain. Why a normal arch patient with a type 1 small looking accessory bone should cause pain? So only source of pain is when they are biomechanically overloaded due to pre-existing flat foot deformity.
That is
80% of the symptomatic 80% of the symptomatic accessory navicular bone syndrome patients, whether they are adult or whether they are pediatric, they are having an associated flat foot deformity.
Okay.
So just correct the biomechanics by putting a small stent inside the sinus tarsi and don't touch the medial accessory bone.
There are other alternatives apart from arthroeresis. Fusion, or do you advise calcaneal lengthening as we do in cerebral palsy valgus foot? Just calcaneal lengthening.
So again, sir, you are changing the biomechanics.
Yes,
that's what I am saying. So you are offloading your medial column.
Okay.
So rather than doing osteotomy, if you just put a 10 minutes job in putting into the stent into the sinus tarsi, which is equally acceptable for the deformity. It corrects the three-dimensional deformity, because flat foot is not just a problem of your hind foot valgus.
Yeah.
It corrects the three-dimensional. It gives you the arch, it corrects the talonavicular subluxation, it corrects the forefoot supination, it corrects the heel valgus also. So I think ample amount of studies, sir. I am not talking about my own experiences. There is ample amount of literature which supports that don't touch the navicular, accessory navicular, and just put
I got it.
stent. Yeah.
Since there is a Kolkata pediatric orthopedics, foot surgeon here, so I'm asking you, what is your experience with arthroeresis?
See, when I started doing that initially and I did my fellowship, I saw a very high failure rate. Extremely high failure, especially for those kids who are extremely valgus. These screws tend to extrude. They will come out and then they will impinge. So after seeing those complications of mine and others, I'm a bit skeptical. Maybe
so probably that is a first generation stent. Now they are having a fourth generation, which extrusion rate is extremely low. Sir, I might have done 110 cases and I have not seen a single extrusion. I have seen 2 failures because of my wrong diagnosis. They were collision, I put a stent. That was the 2 cases which were failed.
Thing, because they come at a cost. And the problem in private practice is unless you do something which...
Yeah, the cost is a problem.
Done
what is the cost of it in the 4th generation?
As of now, they are giving us 50,000 per stent. Because it's made by Michael Grams in US and they are charging us to it.
Which company stent do you use?
The Hyprocure. Michael Grams.
They're very expensive.
Gram Medica. Yeah, but now we have an Indian option, sir.
Yeah, we have Indian option.
Zeus company from Ahmedabad, they have made a similar copy. And
sometimes what happens, a pain, little bit of pain, flat foot, that becomes more painful because of wrongly done arthroeresis.
Yeah, I mean, if it is wrongly done
or failure of implant.
Arthroeresis, sir, almost 10 years back, it was the failure. It was even removed from the literature. But now if you see this Hyprocure, that's why I'm taking a company name. Hyprocure is a company name. Lot of Chinese article, Korean people, even the US people, the complication rate for the pediatric population are extremely less. I think
Often the children have bilateral problems.
Yes.
And if you have to put this stent, sinus tarsi stent, the cost may be prohibitive.
Absolutely, sir. I totally agree that cost is a problem. But otherwise, considering the minimal invasive and the correction potential, it is better than doing osteotomy and too much open surgeries for the pediatric foot.
Thank you.
Thank you, Dr. Amakan. And now, Dr. Kushal Nag on subtalar arthritis.
So we'll present a case on subtalar arthritis. Disclaimer, not my case. I've been asked to present this. Done. So it's a very straightforward case. The idea is not to discuss the case per se, but to discuss the fine points about subtalar arthrodesis and our experiences with it. So very simple case. Touch it. Sorry. 50-year-old female, gradually increasing pain for the last 5 years, not responding to analgesics, pain on both the medial and lateral aspect, difficulty in walking, heel valgus, loss of arch presentation, tenderness in the subfibular region or subfibular impingement, silver skull positive, no subtalar movements, no forefoot or midfoot pain, no medical comorbidities except controlled hypertension. So if you look at if you listen to the history and if you look at the x-rays, it's quite obvious that this looks like a rigid flat foot, right? But the only problem is the talonavicular joint is nice, looks good. So what's happening here? So you see the C sign there? That's what we were talking about earlier in the earlier cases. So what do we do next? Once you have an overview of the case, this is the clinical findings, these are the x-rays. Do you want to know more about it? And what are we going to do as far as next steps are concerned? The panel, anyone volunteering or from the house? She has a painful subtalar joint, painful hind foot rather, not forefoot. Painful hind foot.
The C sign itself tells that there is a mild subluxation of the subtalar.
Yeah.
There's a mild subluxation of the subtalar joint, nothing very. So what are the next steps? Do we need to do any more investigations, or are we happy with what we are seeing?
We need to do the MRI just to rule out other possibilities.
You can either do an MRI or you can either do a CT to find out what's happening here.
CT MRI.
So if you do an MRI, you will see this is, self-explanatory, nothing much to describe. A totally destroyed subtalar joint, subchondral cysts, everything, everywhere, everything is haywire. But if you look at the medial facet, you lose, there's something funny going on. There is something wrong there, right? So this is mostly, looks like a coalition, a fibro-osseous or a osseous coalition, mostly a fibro-osseous coalition, that's what is more common. PTT is okay, of course it's going to be okay. Doesn't have any medial side pain, that's as we mentioned earlier. Good talonavicular coverage, there is no subluxation. The spring ligament, delta spring ligament also looks good. So what's the diagnosis for us? It's quite obvious, it's a subtalar arthritis secondary to a coalition. It's amazing that she has managed to survive 50 years of her life with this, and that's why you have seen subtalar joint ending up in such a bad shape. So what's the plan or approach? What do we do? What's the next step? What's our plan? Anybody?
So fusion.
Of course, there's no way we are going to salvage this joint, and with the rigid flat foot and with the evidence that we have of arthritis, subtalar fusion. But before we do a subtalar fusion, we have to correct the deformity, and you can't do that unless you take the coalition off. So in these cases, you have had a dual approach. You have done a medial and lateral approach. With the medial approach, you open up and you debride the fibro-osseous coalition and take off the connections there, and only then can you move the subtalar joint back into its correct alignment. I can also see the surgeon has done a Achilles lengthening there. Yeah, it looks like an Achilles lengthening there. So this is the movement after you have taken off the coalition. This is the medial surface. And once you see that, you have good movements. And then you go to the lateral side, open up in the sinus tarsi approach, do good joint preparation. You drill, you denude the cartilage and everything, and prepare the joint properly, give the K-wires, C under C-arm, correct the deformity, and put 2 screws. It's all quite straightforward. So what are the complications, or what are the challenges in this case? Long-standing subtalar arthritis, right? She's been doing this for the last 50 years, rigid flat foot. What are the challenges that we expect to face once we do the joint preparation? So I think the most common challenge that everyone would agree with would be a very sclerosed and marbleized subtalar bone. And I've seen that happen when you're using an osteotome. You can hear the clunk, and the osteotome literally skids off the bone. There's very little, it's so marbleized, it's very difficult to go down to the cartilage, to the subchondral bone. It's totally marbleized. So in these cases, I think one of the important lessons that I have faced after my complications, in these long-standing cases, please use a bone graft. Otherwise, these joints never unite. So one of the things that I don't know what the other surgeons do, but in these long-standing cases of subtalar arthritis, any long-standing case, could be a malunited calcaneal fracture, it could be a coalition, use a bone graft. I've had to revise 2 cases because initially during my initial days of practice, I never used to put bone graft. But I've learned by burning my hands that 6 months, 7 months, 8 months, the joint does well. After that, it starts getting sclerosed, and then you do a very thorough joint preparation, drill, shingling, put a bone graft, and then you fuse and compress, and then that gives you the maximum chance of union. So if you look at the X-rays here, nicely done, very good screw placement, good compression there. This is what the patient's gait is, 6 months post-op, good correction of the deformity, and she's walking well. So this is the second case, 58-year-old lady with painful ankle and subtalar joint arthritis with no deformity, very clearly seen in the X-ray. Oh, sorry, I think I only had the X-ray. Oh, sorry, I'm going to present the one case only. Apologies. So any questions from the house? Anything that?
Sorry being stupid, not a foot and ankle surgeon. Why, since you're doing the subtalar, I've done a few subtalar fusions, and if you're coalition, why can't you do it from the lateral side, everything alone? Because
you
are
can
using
do
the
it,
hinge.
sir. You can do it.
I've done it so that
you can do it. I don't think, but it's easier to visualize and do a proper job if you open medially. Okay. I'm not saying you cannot do it, but it's easier to do it medially.
So the reason is, it is a collision on the medial side. So if you start doing your preparation from the lateral side, until and unless you reach to the medial side, you cannot distract the joint and see the cartilage. So you need to take out too much amount of the bone if you start from the lateral side. On the contrary, if you start from the medial side, so the morphology of a sustentaculum is actually disturbed in a collision syndrome. So it is not a simple preparation, sir. If you start from the medial side, you see the collision in front of you, and once you take out the collision, you can distract by putting one K-wire into the talus, one into the calcaneum, and Hintermann distractor, and you can see the whole joint. But if you start from there, seeing the joint is extremely difficult, unless you remove the collision.
Okay. Now I was just wondering, because once, if you've done very few of them, I've always done the lateral side, and what we have done is basically because I'm removing that wedge of bone to correct I've written an osteotomy to it, and I've put in bone graft. So I've got I've just recreated the whole thing without touching medial side. Main worry being that what's after so many years is a worry. Where's the medial plantar artery?
If it's a bony coalition, then it's very difficult to do it from lateral, because then the bone is totally stuck. Fibrosseous, maybe.
I'm talking of fibrosseous.
Bony coalition is going to be difficult.
Impossible. I agree.
Bony plug, you have to take it
Fibrosseous,
out.
they are generally not symptomatic. I mean, they are less symptomatic.
Yes,
but they are not arthritic.
So these are elderly. I'm talking of this elderly. I was doing a knee replacement later on for that, so I did this one first.
Okay.
So that I could have a better result.
Understood.
Because there's this, especially knee replacements can fail because of
flat foot. Absolutely.
So
that first.
Correct. So that's an interesting question. What would you do first, sir?
Get the foot done first.
So I see so many cases with the knee done first. I was wondering if yes, they will stretch out. I see so many patients with varus knees and valgus foots. Once the knee gets corrected, they can't walk. Then the foot goes into extreme valgus again. So anyway, thank you. Oh, one question, yes. Yeah.
I have one more silly question. But do you have any sequence of which screw you should put first while compressing the subtalar joint?
Not really. I mean, medial lateral screws, not really. I don't have any specific, I am not aware of any specific guidelines. You have to put one screw or the before. It depends on your comfort and which screw you want to place first.
Is it mandatory to give 2 screws always?
Yes, because it's a wide joint. If you give one screw, it's very difficult to achieve compression. 2 screws, good axial compression, you can maintain the joint reduction. It's recommended you give 2 screws.
Okay.
Thank you so much.
Thank you.
Thank you so much for this wonderful session. Moving ahead to next session, I would invite chairperson to Dr. Kushal Nag, Dr. Tithankar Bhattacharya, Dr. Raju Chatterjee, Dr. Kushal Nag, and Dr. Girish Motwani to come up on stage and proceed with the session.
Good afternoon, everybody. First, my disclosure: this is not my talk. This talk has been presented by Dr. Shivam Shah, who is a foot and ankle surgeon. I've just modified the talk to make it more in sync with the topic at hand, that is ankle arthritis. So, as we all know, that ankle arthritis affects nearly 1,300,000 population annually, with a prevalence of around 1%. It is much less common than osteoarthritis of the knee and the hip. So let's start with a case like a 35-year-old male with a chronic ankle pain of year duration with some restriction of dorsiflexion. So what do you think is the most common cause of ankle arthritis? And anyone from the panel, please?
Sorry, again, repeat your question.
What are the most common causes of ankle arthritis, and how do they differ?
So ankle arthritis, most common cause is post-trauma. Among the trauma, the most common cause is trimallar fracture, followed by pilon fracture. The second most common cause of ankle arthritis is chronic ankle instability, missed ATFL. And the fourth or fifth most common cause is of the ankle arthritis is primary. So what we see in the knee is completely different in the ankle.
So this is what we want to highlight, that the most common cause is traumatic, and much different from the knee and the ankle, where the main cause is primary osteoarthritis. So what are the important images which we want? What are the proper x-rays we order for any case of ankle arthritis? They are the weight-bearing x-rays, the AP mortis and the lateral view. And another important x-ray is the hindfoot alignment view, the Salzman view, which gives us an idea about the hindfoot alignment. The various angles which can be measured, and the important is the talar tilt angle, which is, if it is more than 10 degrees, is considered incongruent. MRI can help and CT scan can help. So when do you use an MRI or a CT scan? The panel. When do you use an MRI or a CT scan?
The bone-on-bone disease is enough. I don't need an MRI or a CT scan unless I'm trying to do an osteotomy to preserve the joint.
So you use an MRI as a prognosticating tool, or like to decide what's the stage?
If I see bone-on-bone, I don't do any other investigation.
Okay. So you don't believe in that?
Standing X-ray, both sides is enough. If you see bone-on-bone, a significant reduction in joint space, see, you have a varus deformity, one shoulder is impinging on the ankle joint. I don't think any other investigation adds value, in a sense. If it's early arthritis, mild pain, you're probably doing a plefonplasty or something to preserve the joint. Maybe you do an MRI to see the cartilage status.
Suppose you want to decide between the joint preserving surgeries and the joint.
Then maybe, yes. In early cases, yes, maybe. But those patients don't come to you for surgery.
Okay. So these are the indications for MRI and CT scan, if at all it is there. Okay. So what is the most common classification which is followed is the Takakura-Tanaka classification, which is based on the Mortis radiograph. Stage 1, there is only osteophytes without any space narrowing. Stage 2, there is no subchondral contact, but the medial joint space is narrowed. In stage 3, divided into stage 3A and 3B, there is abrasion of the joint space on the medial side, but the talar dome is still intact. In stage 3B, even the roof is affected. And finally, the stage 4, in which there is complete tibio-talar contact. So now coming back to our case, this is what we have, the X-rays. The 35-year-old young active male with a stage 1 osteoarthritis. He's a young and active individual. So what would you do? The panel.
Is this a standing X-ray?
The standing. Consider this is a standing X-ray.
Consider standing X-ray.
I told you this is not my presentation
So
exactly.
it looks like a medial chondral cyst there.
Yeah, it's a stage 1. We are saying
so
taking this to be a stage 1.
Probably do a scopy and microfracture. Or maybe some cartilage procedure if you want to.
Okay. So you won't try any conservative management?
Yeah, of course. I mean,
so this is for the general audience. This is not for
yeah.
the foot and ankle guys. This is for the general audience basically. So definitely each and every case we have to try 6 months of conservative management, which can vary from activity modification exercises, walking aids in the form of Arizona braces or rocker shoes. And there is some evidence for hyaluronic acid or PRP and steroids, but no consensus on these injections. Is there any consensus on any of these injections for ankle osteoarthritis in early stages?
Not that I'm aware of.
There's no consensus as such.
I've given a couple of injections long back. When I
Is there any consensus?
practice,
I'm asking the foot
patient
and
didn't
ankle
report
guys.
any
Any
benefit.
consensus on any injections? No, not yet. Okay.
Is there any consensus in the knee?
Whatever little what I read before this talk, I didn't find any consensus anywhere. That's why I'm asking you. So what are the surgical options which are available to all these patients once the conservative management fail? They're basically divided into joint preserving surgeries and joint sacrificing surgeries. So joint preserving surgeries can be tried up to stage 3A. That is before only the medial side is completely obliterated and less than 50% of the joint is involved. And the surgeries are like either arthroscopic debridement, as this suggested in the first case. Even arthrodiastasis may be tried, but done rarely. Then these are periarticular osteotomy. Of all the surgeries mentioned in the joint preserving surgeries, perhaps the periarticular osteotomy which helps the most. And in 2 and 3, both the second and the third surgeries can often be combined with arthroscopic debridement. And first to see the status of the joint and decide on the surgery, and it also helps in debridement. And the joint sacrificing surgeries is done after stage 3A, that is when more than 50% of the joint is affected, and arthrodesis is considered the gold standard, and total ankle replacement. And various ancillary procedures can be combined with these two procedures. So why is arthrodesis the gold standard in the ankle? The panel, please.
So there are so many things. Plasty versus arthrodesis. Arthrodesis is a treatment of choice, is still the gold standard treatment because of the high survival rate. If you compare the plasty and the arthrodesis, most of the implants which are available at present, the prosthetic implants for the plasty their survival rate is 15%, 15 years, sorry. So, and apart from that, there are the other complications. Arthrodesis, the only problem in the arthrodesis is the adjacent joint disease. So, there is nothing called best, but it has to be customized on the patient profile and the involvement of the arthritis of the other joint as well.
Does it have something to do with the fact that the ankle arthritis is more common in the younger age group, and so the patients which we have at hand to treat, they are young active people, and in them arthroplasty may not be the best option?
Yeah. So that's why I'm saying the patient profile is important. Disease. For example, I'm telling you a rheumatoid arthritis in a 40-year-old patient. What will we do? Plasty or arthrodesis?
That will depend on so many factors, as you say.
So the two factors are enough. Rheumatoid arthritis in a 40-year-old patient. So that is the situation where you will go with the replacement. Because if you go ahead with the fusion, you have to do the fusion of nearby all the joints in upcoming years. So that is the only condition where even in the young patient, the arthroplasty is better than a fusion. But look at another situation, 62-year-old female having a trimallar fracture, surgeon has done a good job, but the patient has developed the arthritis. 62-year-old patient. Now she wants movements. What is the best option? No comorbidities, no diabetes. Local skin, very good. She wants movement. She's an active lady, social worker. What is a good option? Fusion or a replacement? Replacement. Because 15-year survival, perfectly matched in a 62-year-old patient, non-deformed foot, arthritic, and she needs movements. So this profile completely sits on the patient's profile. Another example, 55-year-old patient, uncontrolled diabetic, ankle arthritis. Can you do the replacement? Age is up to according to the replacement. Can you do the replacement? No, because diabetes, presence of neuropathy or a risk of neuropathy, microangiopathies, you cannot do the replacement. So it completely depends on the patient profile. Not just a age, not just a grade of arthritis, not just a need of the patient that I need movement, not just a diabetes. You need to check the whole profile and the demand of the patient. This is very important. Yeah, sir.
At 77.
What will you do at?
When 15 years later, at 77, she's still fit and walk.
Sir,
Can you fuse that ankle?
Sir, again sit with the patient. And if the chronological age of the patient is 62, but the physiological age, 77, sorry, but the physiological age of the patient is say 70 years or the 65 years, then you can give the option of replacement to this patient.
No, I'm talking about that. You have replaced at 62, 15-year survival. So at 77, can you fuse that ankle?
So 15 years doesn't mean that 15 years. Okay. It can be 20 years. So this is overall 15 years survival is the maximum.
Let's say 15 years. Yeah.
So at the age of 77, she needs fusion.
So can you fuse that ankle when you
I've
so
seen
many bone loss
bad failures even in the hands of experts. Even in the US with Dr. Mayasan and even in Singapore, I used to see subsidence, failures, and board fusions, revisions.
What did they do to
so
the failures?
consensus was, what my bosses used to say, 60 plus, no comorbidities, minimal deformities, thinly built lady, you may consider an ankle replacement, but be prepared for revisions at 8 to 10 years.
So were they revising them or they're fusing? Coming to that Shomita's question, I mean, even if you need to fuse it, you have a big gap there. It's like nowadays we are replacing 8 centimeters of tibia. So I don't think there's a major problem with fusing them. Somehow just one question is, why has ankle replacement not taken off at all in India? That's my question to the foot and ankle people.
No good implant. So availability of the implant is the main.
Why have you guys not pushed for it?
Sir,
you guys are doing some wonderful stuff you're doing some wonderful stuff.
Indications are limited. As I said, the ankle arthritis is not primary. The ankle arthritis is always traumatic. Unlike knee.
We are getting a reasonably large number of rheumatoids now. Reasonably big number of rheumatoids getting
but again, the involvement of the ankle, it's a small bone disease. Involvement of the ankle.
So why not pushing for the joint? Sorry, I'm going digressive. We should be, because the other part of the world is really pushing. They're at some point in time, because knees went through the same cycle. 1960s, 60s, 70s, 80s, we had 5-year survival rates.
Correct.
I mean, the FS2 had the first one which was a 10-year survival rate.
So, sir, overall in the India, if you see the overall exclusive foot and ankle surgeons, they are less than 40.
Okay.
The second problem is, company needs a patients, they need a market. They will bring the implants, but they should have at least 2,000 surgeons.
It's all about economics.
Yeah, that's all about economics.
Can we move with the second case now? We'll discuss it later. Yeah, okay. So there is another case. This is again from the net. So this is a 36-year active male with pain in the ankle, all conservative means stride. This is 10 years after the vertical shear medial malleolus fracture fixation. It's a varus deformity with medial loading. So what next? 10 years, all conservative males failed. Is like stage maybe 3A, 2, 3A.
Yeah, we should try to conserve this. You can do a
severe pain.
Plaffonplasty, align the joints. If there is going to be varus deformity, cartilage thinning on the medial shoulder, take out this implant, do a plaffonplasty, put a allograft or autograft.
So some sort of an osteotomy, which is what you aim for.
Yes. Yeah.
So this case was treated with a dome osteotomy, and these plates have been put. Most likely they put plate on both the anterior side and they have. Is it necessary to do fibula in such cases? Especially the varus deformity?
Getting the motion is difficult otherwise. If you're doing like you're doing you're getting a motion difficult, it becomes very stiff to move it otherwise.
So that is mainly to do with the valgus deformities. Varus deformities, they tend to correct.
I mean, if you're doing a dome osteotomy, you'd rather do a fibula also, because otherwise the freedom of motion doesn't come.
Movement, fine. So the periarticular osteotomy, the ideal candidate is a person with asymmetrical medial or the lateral girdle involvement. That is there should be a deformity in the coronal plane. Then only we can go for these your osteotomies. Some joint involvement osteotomies are also been described with the perfundoplasty. And dome osteotomy is specially indicated when the deformity is more than 15 degree, which is to avoid translation, which will worsen the limb alignment. Otherwise, you can go with the open or the closed wedge osteotomies above. So another case, case of polyarticular.
Can I ask? Have you done an intra-articular osteotomy?
Yes.
Plaffonplasty, yes.
Yeah. Because that would be a much less aggressive procedure.
Yes. It is less aggressive, yes.
Intra-articular osteotomy.
Yeah. A 38-year-old polyarticular RA, pain, limp, ankle, no movements at the ankle. So what next?
Already looks fused.
38. So will you go for an ankle replacement here, Dr. Motwani?
That is the only indication of doing ankle replacement in a young age.
Okay.
Only indication of doing ankle replacement in the young age is presence of rheumatoid arthritis.
But then Siddhartha, remember, you do ankle replacement, 10 years later it's going to come back for a revision. Again 10 years later.
Again, remember, it's not been passed by, still not certified. That's the biggest problem. That's the biggest problem.
Indian drug.
So fast we move ahead now. So ankle fusion. So what are the approaches? It can be either anterior, it will depend a lot on the soft tissue condition, everything. So anterior, it can be like the lateral transfibular. Lateral transfibular, it provides an advantage of allowing the fibula to be used as a graft. And posterior in cases where the skin condition is too bad, so posterior approaches can also be done. Even arthroscopic fusions have been described. In literature, that is for minimal deformity, not for very significant deformities, or many incision approaches have been described. So what are the implants which are used? That can be done either with only screws or a combination of screw and plate, or even nails have been described. I think this is anterior grade nail which has been banged into the talus. It looks like an anterior grade nail. This is a normal tibia nail. Because this is just a subtalar arthritis, so a nail has been used from above basically. Sorry, this is just a plain ankle arthritis, so a nail has been used from above. So how will the treatment differ if suppose there was a subtalar involvement too, and so what would you do? If there is a subtalar involvement along with
joints,
the...
you're better off with the hind foot fusion, no?
Then, fine, leave this. So what are the indications of tibio-talocalcaneal arthrodesis? This is associated subtalar joint osteoarthritis, or where there is a severe loss of bone stock of the talus or the distal tibia secondary to a failed tibio-talar arthrodesis or a failed total ankle arthroplasty or infection or tumor dissection. Even in cases of avascular necrosis, when the talus is more than 50% involved, one has to do TTC fusion rather than just ankle fusion. Another case, a 52-year-old female, obese, inability to walk, 2 steroids injections, quality of life reduced, painkiller for 2 years. These are the x-rays. Both the subtalar and the ankle joints have been involved. The patient is around 52, 55. A patient is ready for ankle replacement surgery. So what next?
Patient is ready for ankle.
Subtalar looks okay to me.
The patient wants ankle replacement. The patient has come to you that I want an ankle replacement surgery.
I'll send him to Girish.
So,
54, 50
so,
to 55.
so as I said, you have to discuss with the patient, and when you have convinced the patient and you are convinced for the ankle replacement, I will do with the ankle replacement and the subtalar fusion both at the same setting.
At the same sitting.
At the same
So let's see what the surgeon did. So he tried all, yes, fine. So first, stage 1, he did a subtalar fusion with a lateral approach, gastrosoleus resection, subtalar joint preparation and fixed with 2 screws. At 6 weeks, when it was healing, he planned for a total ankle replacement, a change of subtalar screws and reconstruction of the lateral ligaments. So these are the steps of the total ankle replacement which he did. I think I can skip over all these. And this is the final post-operative x-rays. The shortened screws, your total ankle replacement and the lateral ligament reconstruction.
It is Switzerland based.
So post-operative protocol, and these are the results at the end of 3 months.
From them. No.
These are range of movements.
You got the clearance from the FDA.
So these are the indications and contraindications. The total, we know the indications now, but the contraindications like active infection or peripheral vascular disease, poor soft tissue involvement, neuropathies, poor bone stock, they are a contraindication for a total ankle replacement surgery. And I don't know how many has been done, but as per the slide provided, like 20-25 TS, how many TS total ankle replacement?
I think 20-25 has been done in India.
In India?
In India, yeah.
In our state? So, Kushal?
I don't think a single one has been.
Not a single one, fine. So maybe the 3rd generation processes that improve the outcomes. So the highlights. Approximately 80% of ankle osteoarthritis is post-traumatic and affects mainly the young in the working age group. So initial conservative management is effective in most and should be attempted. After failure of conservative treatment, there are either the joint preserving or the joint sacrificing surgeries. In the early stages, osteotomies can be tried, but ankle arthrodesis and ankle replacement can produce satisfactory functional results if correctly selected in the final stages of the disease. Thank you.
But then all of the work
I have a question for towards the panelists. Gentlemen, I have got a question towards the panelists. I am going back to the case which Dr. Gupta showed, 38 years female rheumatoid arthritis with ankle joint almost fused. You suggested replacement. My question, I slightly differ with you. My question is, 52 years rheumatoid, already joint is fused. Her activities are compromised. She is used to less ankle movement. And as Kushal has said, be prepared for revision after 8 to 10 years. How justified it is at this stage to do a replacement rather than doing an ankle arthrodesis?
Few advantages, sir. Few advantages. One advantage you have already told us, less demanding, because it's already chronically debilitated, less demanding. So these are the even better cases for the ankle replacement, for the longevity. If you are more demanding, if you are a sports guy, you are not an indication of for the indication for the ankle replacement. So the less demanding lady. Second, rheumatoid arthritis, why I am in favor of replacement is, if you do with the fusion of ankle in a rheumatoid, after few years you will have one bone below knee. because all the joints are fused. TMT are fused, intercuneiform fused, subtalar fused, talonavicular fused. The ankle is remained and the ankle is also fused. One bone below knee. That is a problem. So they develop lot of stiffness, and even it creates more disability for the patients. So this is a condition where you have to give at least an ankle joint for the patient, for the mobility. So that's why I am in the favor of doing ankle replacement even in the younger patient in rheumatoid arthritis only, sir. Rest all the cases I agree to you.
But revision at, she is 38 now.
Sir, revision is difficult.
At 48, 50.
Absolutely, sir. I totally agree to you. Revision is difficult at any stage. Young patient, 70-year-old patient, old patient. Revision is difficult surgery. But there are revision ankle replacement which is still possible, and ankle fusion with the bone graft after the revision, on the revision is also possible. This is also a good salvage option.
The only reason why ankle replacement is not very popular or commonly available is because of the durability of the implant. If he had had knee implant like a knee last 25 years, please go ahead and do it.
Do we have revision ankle implants?
Sorry?
Do we have revision ankle implants?
No, revision ankle implant nahi. Ankle implant they're just going to allow one.
Do we have it not in
They
India?
have bone they have.
Yeah.
They also have wedges and everything.
So it's
like
a very
knee.
popular surgery. If you just go, you will find more literature on the revision ankle replacement.
There's a question.
A Weber type A fracture with type 1 stage 1 arthritis, painful ankle. What is the role of correcting the malunited ankle fracture at that stage with an osteotomy?
No, so basically what is happening is because of the mechanical axis is not normal, no? There's more abnormal weight distribution within the joint. So one part of the joint is getting eroded faster than the other parts.
That's for the varus.
So if you once you align the joint, then the weight bearing axis shifts more centrally. There's equal distribution of weight, which theoretically should arrest the progression of arthritis. So that's the hope. So if you can conserve the joint and save the joint for maybe 5-6 more years, 7-8 more years, why not?
I mean, intra-articular osteotomies in the tibia, proximal tibia, distal femur, distal tibia do really well, and now 10-year studies have shown that they survive if done properly. But you need a very good planning, pre-op planning with a good CT scan, and you have to, where exactly osteotomy has to be done, this pre-op.
So the question next goes to, till what stage of ankle arthritis would you attempt doing intra-articular osteotomy in the ankle, especially? It's only involvement on one side of the ankle.
One side. So it's anywhere, like think of it anywhere. Femur, proximal tibia, distal tibia. So anywhere, wherever there's one side is still open and one side loading is happening, you do a corrective film and you see it's correcting. You also do a stress which is correcting. So you obviously something there, some cartilage is there, and then you do it. And it's not. What else you can give him? You can give him his fusion. It's better than if you do that. And if that fails, you have fusion in hand. But with the properly done osteotomy, it's been shown that they have at least 10 results have been very good so far.
So coming to your answer, very short. Young, deform, arthritis less than 40%. Corrective osteotomy. Simple. Young, deform, arthritis less than 40%.
Now, how do you judge this is 40%?
MRI, sir. MRI. Only MRI. MRI, axial cut.
Volumetric axial cuts?
Axial cuts.
Only axial cuts?
Only axial cut. If the involvement is less than 40%, correct it.
There is a very good
and just look at this, is correctable or not.
There is a very good algorithm given by the effort group basically. So it's a very good algorithm on ankle arthritis which clarifies most of these things. It's there on the effort group. I'm going to say your open papers basically. So you just open it up and read up that article basically.
Okay, I think we need to get on to the next talk. Thank you, Siddharth. Wonderful. Next talk.
So let's see what happens in the in presence of diabetes in ankle fracture. So can we treat the routine fixation or can we treat the routine fractures like a non-diabetic in a diabetic patient also? So this is our next talk. diabetic ankle fracture. So these are there will be some foot and ankle cases, and everyone has to participate. Same like Dr. Gupta did. So 70-year-old diabetic patient, he had some ankle twisting injury. This is a day 1 X-ray. Yeah, anybody from the audience? Conservative, operative, simple sir, or just give me the diagnosis. 70-year-old patient, diabetic, twisting ankle injury. Isolated lateral malleus fracture, okay? Isolated lateral malleus, yes sir, please, yeah.
Posterior malleolus is involved.
There is a posterior malleus, okay.
Look at the lateral view.
Sir, there was no posterior malleus.
Okay. That's part of the fibula.
Yeah, that's a part of fibula. Yeah, sir. We need a stress view to see what is happening on the medial side. Okay. Okay. So this was the stress view. External rotation stress view. Sir, surgery क्यों बहुत जल्दी हो जाएगा? Surgery. Just isolated lateral malleus fracture, sir. 70-year-old patient.
Skin and
Why it is
sensations.
unstable? Sir, why it is unstable? पूरा तो stable है, sir. Even it is syndesmosis, sir. It is just an isolated lateral malleus. Suppose a 20-year-old patient coming to us with the lateral malleus fracture like this. We'll give the walker boot, not even the cast. Walker boot. The guidelines are isolated lateral malleus fracture. Don't even cast. Look at the British guidelines, IOA-IFAS. Even walking on day 1 with the walker boot, it give you good compression in the union. Don't even cast. 70-year-old diabetic patient. This is just 3 weeks later. They did a stress X-ray and they found everything okay.
So that's the concern, the mechanism of injury. If it's an ankle twist and you have a fracture like this, I will always keep Charcot at the back of my mind. That's the...
Sir, but look at the first X-ray.
You can see a line actually. There was said about posterior malleolus. There is a line even in the AP.
Yeah.
Look at very carefully the line there. Get a CT done. I mean, in diabetics, a very low threshold for CT.
Absolutely right. Absolutely. So more than a stress X-ray, more than a stress, that message I want to give here is, more than a stress X-ray, in us diabetic patients, better to go with the CT scan directly on day 1. Because you don't know the profile of a diabetes. Patient तो बोलता है sugar control ही है. कब किया था तो 2 दिन पहले किया था वो 150 था. They don't know the HbA1c value. They don't know whether you are neuropathic or not. They say sugar control में रहता है. And in the OPD basis, you consider that this okay. This is just a lateral malleus fracture. We see the tenderness and we find that there is some tenderness and then we cast it. The day 1, all ankle fracture, even the subtle fractures, even the undisplaced fracture in a diabetic patients, those who are having a diabetes for more than 10 years, or they also having a less pain according to the fracture, you should do a CT scan on day 1 because there could be some subtle injuries which were missed because it at the level of molecular level. It is at the level of osseous level, which is not even visible on the X-ray. So the same patient was when he has started walking after 3 weeks, and 4 months down the line he presented to me with this condition. Now at the end of 4 months when the patient presented to us in this condition, HbA1c we found is 8.5. There is a history of heart attack. There is some retina issues. He undergone the surgery for retina also. His creatinine is 2.5. Now why I am saying this all is not for the surgical fitness. There is some role in our orthopedic management. There is the peripheral neuropathy. Look at the patient walking very comfortably. Why I have taken this picture is because he is able to put whole weight on the leg. He is walking very comfortably. Do we have video? No. So he is walking very comfortably at the end of 4 months. Now how can a deformity like this, even at the end of 4 months, can walk normally without any pain, without any brace or without any crutches, is a presence of neuropathy, which probably the first surgeon has missed. And there is no vasculopathy. Now there are the plan. Now we have options. or if with the plate and screw, ankle arthrodesis directly, or ankle and subtalar arthrodesis both. Conserve this because the patient has no pain. Ampute it. Okay, option number 1, raise your hands. Or if with plate and screw. Or if with plate and screw. Routine fixation, sir, right? Routine.
4 months post-injury.
4 months post-injury.
4 months post-injury.
4 months post-injury.
Even then I will go for or if. Yeah.
Okay. So the presence of neuropathy, nephropathy, retinopathy, it indicates it's a complicated diabetes. Now there is a term called ankle fracture in complicated diabetes. So if you want to write a diagnosis, don't write an ankle fracture in diabetes. There is a 2 terms, ankle fracture in complicated diabetes versus ankle fracture in uncomplicated diabetes. What we routinely see in just a presence of diabetes, control HbA1c, diabetes not insulin dependent, no presence of neuropathy, they indicates ankle fracture in uncomplicated diabetes. Do the routine fixation, what you do. Just improve the strength of fixation. But when you have a picture like neuropathy, nephropathy, retinopathy, ischemic heart disease, these are the cases where you have to do fusion on day 1. Even when the patient is coming to you with this picture, first X-ray, fusion on day 1. It is a very hard decision to do the fusion because of presence of neuropathy, nephropathy, retinopathy, ankle fracture in complicated diabetes. You have to go with the fusion. Now in the fusion, ankle or the subtalar also? This is the question. Option number 2, raise your hand, ankle fusion. Now that it is decided that we are going to fuse it because it's a neuropathic patient. He is developing Charcot in 4 months. It's a neuropathic. जो लगाओगे plate सब टूट के बाहर आ जाएगा. Everything will break out. TBW plates, everything will come out. So option number 1 is remove. Option number 2, ankle fusion. No. TTC fusion. TTC. Okay, maximum hands for TTC. Conservative, anybody wants to conserve? You want to conserve, sir? Yeah. Your thought.
I treat the patient, not the X-rays. And if the patient has no complaints, I'm just taking something on, and he is looking at his HbA1c, his average lifespan will be 5 more years.
Yeah.
If he is happy to wear an orthosis to prevent further deformity and live with it, I will leave it alone. I personally have a patient teacher.
Yeah.
Teacher, she is now 7 years down the line. She's teaching, and now she's like 4 times a week dialysis. Now she's going.
Yeah.
Like the same X-rays.
Can I?
Yeah. So sir, why?
Can I say, Rajiv, the one thing?
Yeah, please.
One moment, sorry for interrupting. I might sound very bad, but I will counsel this patient also for amputation. Because even after TTC, there will be a problem with fusion.
That's what I'm saying. Why treat the patient? Patient has no symptoms. So I just give him a brace.
Yeah.
You got a lovely moon boots nowadays. So whenever he's walking, you use a moon boot so that doesn't perforate the skin. That's the main problem.
So that's why I put this slide. Why not conservative? Look at the way in 4 months the patient is developing into Charcot. Look at the instability of that fracture. The small undisplaced looking fracture is so much displaced. So the way they are moving, if you don't fix in this position, they will lose the bone, and they will, next time they will come with more deformity.
Agreed, but is the patient complaining? That's my question to you. The patient, because here we are losing the focus, the patient is the focus. The patient is diabetic with the 8.5 cardiac history, retina, his lifespan is 3 to 5 years.
Yes.
So if you can give him, just don't leave him unprotected.
If it is a midfoot fracture, sir, I would probably go with the conservative, but because it is at the level of ankle, it is very unstable fracture. Yeah. So that is the criteria here. Yeah, that's why I put everything. Now you have a neuropathy, nephropathy, retinopathy with no vasculopathy.
Because ankle fractures in diabetes is completely different ballgame.
Picture, yeah.
So definitely these patients, whether to fix or to do TTC fusion depends on some of the criteria which you have to take
These
into account.
are all the criteria written here. HbA1c more than 7, presence of neuropathy, nephropathy, retinopathy, presence of vasculopathy, presence of peripheral neuropathy, and an insulin dependent diabetes. These are all the 5 to 6 points in that criteria. If that score is more than 6, you have to go with the fusion. If the score is less than 6, you can do with the ORIF, with the transsyndesmotic. Anyway, so we opt for the primary tibio-talocalcaneal nail fusion. Amputation is too much aggressive part in this profile, sir. There is no vasculopathy. Now, why we are looking for the wound complication? Sir, it's a neuropathic patient, it's a vasodilation. You have more blood circulation. Dr. Ramakant has done so many Charcot. He is a Charcot king. In how many cases you find a wound complication, sir, when there is no vasculopathy? Extremely less. So don't have a fear of diabetes if you don't have vasculopathy. But if you have a vasculopathy, yes, you are right that the option of amputation should be well explained to the patient. But still there are Elizaro people and stent and then revascularization, and then they are doing the same job also.
Doppler, arterial Doppler.
Absolutely.
So definitely we'll know whether there is a
100%.
atherosclerosis and what is the perfusion of the foot.
So that is why it is very important to check for the Doppler. Every point which I have written is according to the criteria and what we need in ankle fracture in diabetes. Okay, so moving forward, this is the articles. There are many articles. They are all from the standard American Orthopedics Foot and Ankle Society, IOA-IFAS, and majority of the articles, they are from the recent this thing. There are some meta-analysis also. Look at the final conclusion. The non-operative management of the ankle fracture in diabetes with the complicated diabetes mellitus, they have a higher complication rate, sir. They are higher complication rate. So the option number 1, conservative, is removed. In insufficient instability of an ankle fracture treated operatively or unoperatively can trigger the Charcot. So even a small K-wire fixation or a small screw fixation can provoke more Charcot arthropathy and may lead to bone loss, deformity, ulceration, amputation. That's why the rigid fixation is very, very important when you are having a high index of Charcot arthropathy, suspicion for the Charcot arthropathy. So this is a complicated diabetes mellitus according to the profile of a patient. That's why we have gone with the tibio-talocalcaneal nail fusion. This is the nail fusion, extra screws across outside the nail, and this is how the patient has started walking after 3 months of the surgery. But you have to give a brace, immobilization for 3 months at least, long prevention of the injury, and the control of the sugar and all should be continuous. Case number 2, 63-year-old female fell down from the stairs, treated conservatively by someone. This is a diabetic patient, 63-year-old patient. This is a medial malleus fracture, there is a talus fracture. It was conserved by someone. Considering that this patient is diabetic. Yeah. So Biloni cast was applied for 6 weeks. Primary orthopedic surgeon has missed to see her neuropathy status. It's totally painless. Patient came to me with the walking status. She was completely walking. Also there was a fear of wound complication of open reduction interfixation. That's why the surgeon avoided a surgery. Look at the 6 weeks. At just 6 weeks, patient has started walking with more deformity. And look at the bone loss here. Before 6 weeks, after 6 weeks. Look at the talus. That's why all the fracture, ankle fracture in diabetes, at ankle level or at the hindfoot level, on the weight bearing area, it has to be treated with the fusion as early as possible if they are having good vasculopathy. The same thing was done, fusion was done. I am not going into the detail. And this is how it is fused with TTC nail. We have a TTC workshop also. So the unstable hindfoot Charcot with a poor bone stock, ankle involvement, fuse them. Okay, TTC nail is the best option, but the restoration of a talar height is important. Otherwise, you will have shortening. More shortening, more overloading. So that may lead to implant failure. That is also important. Talonavicular joint, if it is not involved, don't fix it. Prolonged immobilization is very important. So learning point from first 2 cases is, ankle fracture and diabetes, they behave differently. Fracture in complicated diabetes mellitus, presence of neuropathy, nephropathy, retinopathy, fusion, 100%. don't do or if. Vasculopathy is an enemy. So if it is a vasculopathic case, conserve, send to the vascular surgeon, allow the person to go for the stenting, and then after revascularization, you can do the fusion after 3-4 months. Or you can go ahead with the Achilles arrow. I am not an Achilles arrow expert, but you can go ahead with the Achilles arrow. Treating deformity before the ulcer formation is very important. You can prevent the amputation. Once the ulcer is formed, high chances of amputation. Case number 3, 60. Do we have time, sir? Last case? Just go. Okay. Quickly I am going. This is a 65-year-old diabetic patient. Quickly, last case. Uncomplicated diabetes mellitus. This patient has a diabetes. Since how long, sir, you are having diabetes? 5 years. HbA1c 6.5. Neuropathy? No, I am very painful. Don't touch, doctor, don't touch, I am very painful. I don't have neuropathy, I have pain. So anyway, HbA1c 8, no vasculopathy, diabetes more than 10 years, takes insulin, no neuropathy, nephropathy, retinopathy. These patients are uncomplicated diabetes mellitus. Sorry, it should be less than 10 years and should not take the insulin. No neuropathy, nephropathy, retinopathy, uncomplicated diabetes mellitus. Okay? So this was a fixation done. See, the fusion was not done. This is a routine open reduction interval fixation with multiple transsyndesmotic screws. Even though there is no syndesmotic injury, that is called pro-tibial fixation. So if you want to save the joint, you can save in an uncomplicated diabetes mellitus. In absence of neuropathy, you can do this job and make this patient non-weight bearing for longer time. Don't fuse, fix it rigidly. Pro-tibial multiple screw fixation. Don't do routine fixation. High risk of failure on routine fixation. Immobilize for at least 3 months. अगर आपने वो नहीं किया, so you will, if you go ahead with the routine fixation, you will find this kind of picture. These are the few literature which support the articles. Thank you so much. Thank you.
Thank you for a wonderful insight in diabetic, different thought process definitely. The other thing is that the time of immobilization is into 2 always in diabetes.
Yes. Yeah.
Whatever you have thought for a normal ankle fracture before, for diabetes is 8. If you thought is 6, is 12. So that's a standard.
Yeah, yeah. So the standard guidelines are HbA1c less than 8, non-insulin dependent diabetes, no neuropathy, nephropathy, retinopathy comes under uncomplicated. More than 8, insulin dependent, more than 10 years, presence of neuropathy, nephropathy, retinopathy, complicated. It's like that. Yeah. Thank you.
Thank you so much for this wonderful session. Now we will pause this session here and we'll take 30 minutes lunch break and we'll resume sharp after 30 minutes.
After the heavy lunch, for next session, may I invite Chairperson Dr. Biplab Dalui and Dr. Gaur Gautam sir, and the first speaker, topic is challenging reconstruction in bone and soft tissue sarcoma and around ankle, Dr. Kaushik Nondi.
Good afternoon, everyone. Respected Chairperson, sir, senior teachers and colleagues. Thank you to the scientific chair and the scientific committee of this conference for giving me the opportunity. So, first of all, before going into the details of my talk, I would like to inform, I'd like to share a bit tidbits regarding the biomechanics of the ankle joint. This is the joint through which the not only the body weight, the body kinematics is grounded to the ground zero. So this joint is very important. And two more important information, while in the stance phase of the gait cycle, the ankle joint carries around 5 times the body weight, and while in the running phase, while running or brisk walking, it carries about the 13 times the body weight. So the reason behind emphasizing these two information is that we need a stable ankle. So with this background knowledge, we'd like to go into the details of my talk. What are the challenges in reconstruction around the ankle sarcoma? Number is the paucity of the soft tissue. Negative oncological margin, as in any other oncological surgery. We have to balance between the mobility and then stability of the ankle joint. We should be more biased towards the stability of the ankle joint, as I have already mentioned. Requirements of flap coverage is required in a selected few cases in fungating mass or any pathological fracture. Stable osteosynthesis is of utmost importance, and preservation of the vascularized soft tissue sleeve around the centralized fibular graft. In our series, we have selected 18 patients. The study period was October 2015 till January 2025. Total number of cases with follow-ups were 18 cases. 2 cases were excluded, one because one patient expired immediately post-operative during the adjuvant therapy because of the chemotherapy-induced toxicity, and another patient had florid skeletal metastasis. Soft tissue sarcoma and amputation cases were excluded from the study. Distribution regarding anatomical location, because this distribution is because where the epicenter of the tumor was in the distal tibia, 13 cases, 3 cases in the distal fibula, and calcaneum, 2 cases. Regarding histopathological diagnosis, osteosarcoma 11 cases, most of them were osteosarcoma. Primitive neuroectodermal tumor or Ewing sarcoma 5 cases, chondrosarcoma 1 case, and epithelioid hemangioendothelioma 1 case. So regarding the variety of surgical reconstruction we have performed, joint preservation is graft or mesh was done in 1 case, tibiocalcaneal arthrodesis in 3 cases. Most of them were arthrodesis with the centralization of the fibula, and ankle arthrodesis 11 cases. Recycled calcaneum with cryotherapy frozen autograft 2 cases, and 1 case of ECRT extracorporeal radiotherapy plus vascularized fibula reconstruction. A few tidbits regarding all these reconstruction techniques. In centralization of the fibula and ankle arthrodesis, we need to transfer the fibula with attached soft tissue sleeve, adequate circumferential detachment of the periosteum at the fibular osteotomy level proximally. We should keep the fibula inside the tibial proximally and distally inside the talar trough, and stable osteosynthesis with a locking compression plate is required. Regarding fibulo-calcaneal fusion, in cases of extra-articular resection, we need to do a fibulo-calcaneal fusion because the distal tibia and the talus is removed en masse, en bloc resection. Meticulous alignment of the foot and leg in the sagittal and coronal plane is mandatory. Regarding calcaneum recycling with the cryotherapy uses a minus 196 degrees centigrade, whereby the tumor cells are killed, and we can recycle as a tumor-free autograft. And that is the same with the extracorporeal radiotherapy also. We need to achieve the triple arthrodesis. Augmentation with the vascularized osteocutaneous flap with free vascularized fibular graft will, there will be less chances of wound complication and more chances of graft uptake. Regarding tibial-talar fusion in case of diseased fibula, we did a distal syndesmosis, tibial lateral cortex margin may get involved, so that has to be taken out with the en masse with the distal fibula. Stable osteosynthesis, as emphasized in other cases also, is mandatory in all the cases. Joint preservation in case of skeletally immature patient, where we can preserve the distal physis of the fibula, we can thereby preserve the ankle ligament attachments and accordingly reconstruct the bone graft or prolin mesh. This is the master chart. I will not go into the details. Regarding results, No patient had till date local recurrence till date. One patient with a Ewing sarcoma had poor response to chemotherapy, so developed graft, non-union and fracture following post-operative radiotherapy. This is an inherent complication of radiotherapy. Some patients, and the same patient developed pulmonary and skeletal metastasis and expired 4 years after the surgery. All resections were R0 resection, that is oncologically clear margin. All the distal junctions united uneventfully, which was a cancellous metaphyseal junction. Proximal, one patient only, we had to do a bone grafting in the proximal high cortical bone junction. 2 calcaneum cryo patients, one patient developed a post-operative cryo burn and osteomyelitis. That in that case, the total calcanectomy has to be performed. Average musculoskeletal tumor society score was 21, and lower fibulocalcaneal fusion was higher, that is the highest, 28. In skeletally immature patient with Ewing sarcoma, preservation of the distal fibular fasciitis was done. The patient didn't have any limb length discrepancy or there is no ankle instability or varus valgus deformity even after 3.5 years after the surgery. Complications I have already mentioned. One patient has osteomyelitis after the post-burn from the cryotherapy, and one patient that in that patient we have to remove the calcaneum, subtotal calcanectomy has to be done. And another patient had minor wound infections that was managed with debridement and wound irrigation. A few cases examples. This is the case where which were presented with the calcaneum Ewing sarcoma. As we can see, this is the Ewing sarcoma of the calcaneum. This is called the pedicle cryotherapy. This is the pedicle of the tendon Achilles that is preserved. And this recycled bone, this is a 196 degree centigrade, minus 196 degree centigrade. There is a cold burn, and this tumor bone is completely made oncologically tumor free, and this is used as an autograft, recycle autograft, and triple arthrodesis was made. And mandatorily in all the cases I have mentioned, this is a flap done, this is a reverse sural flap. Propeller flap is done so that there is no chances of post-operative wound complications. This is a case of osteosarcoma. We have done recycle. This is a second case of osteosarcoma calcaneum, which was also recycled with cryotherapy. As we can see in the MRI images, the triple arthrodesis was done. In this case, the patient developed cryobound in the immediate postoperative period, so subtotal calcanectomy has to be performed. This is the, even after subtotal calcanectomy, this is very hard to believe with the X-ray on the contrast and the patient walking. Hardly you can appreciate on the side which side is operated. DA5 means a disease-free interval. She is completely disease-free and quite acceptable range of motion and gait. This distal tibia or chondrosarcoma that was operated with a en bloc resection, reconstruction with ECRT. ECRT is extracorporeal radiotherapy. This is a hand-drawn diagram. Extracorporeal radiotherapy that was used as a graft, and a C-shaped shell was made, and inside that a vascularized fibula construct was given by our oncoplastic team. And this is the vascularized fibula osteocutaneous flap. And this is at the end of 3.5 years. We have achieved osteosynthesis proximal and distal and stable ankle arthrodesis. This is the amount of movement which is available in the forefoot under the subtalar joint. The patient is definitely having a limb length discrepancy of 2 centimeters, but the joint is absolutely pain-free. Then unassisted gait. This is a distal tibia Ewing sarcoma patient, en bloc resection of distal tibia and centralization of fibula. This is the trough over the talar dome. Distally, the fibula was centralized into the talar dome, and proximally it was centralized into acute docking with in the intramedullary part of the tibia, and stable osteosynthesis was done. This is a 8 years follow-up. Patient is disease-free.
Soja gate of the
This is a 7-year-old kid with a non-metastatic Ewing sarcoma. In this case, we tried to preserve the fasciitis. This is the hand-drawn diagram. This fasciitis was preserved, and this is a fibular graft from the proximal part of the fibula. Not the head of the fibula was kept undisturbed. It was preserved. This is the proximal part of the fibula, just from the resection, just cephalic to the resection level, and that was fixed with 2 syndesmotic screws to the tibia. That prevented the lateral rotation and proximal migration of the fasciitis of the fibula. Preserving the fasciitis of the fibula has an added advantage of keeping the soft tissue attachments intact so that the patient doesn't develop ankle valgus deformity. This is the ankle range of motion at the end of 4 years. Patient can jolly well stand tiptoe. This is the same patient cycling. Disease-free interval of 4 years. He is oncologically free and acceptable range of motion. To conclude, biological reconstruction with ankle arthrodesis with centralization of the fibula is a viable, cost-effective option in ankle sarcoma. In sarcoma around the ankle, small bone of the foot, if recycled, augmentation with the vascularized fibula tissue cover, there will be less chance of wound complications. Stable osteosynthesis is the most important thing. Wherever possible, joint preservation gives superior outcome and better long-term functional outcome. Volume reduction, post-resection, large soft tissue defects can also be managed without any plastic surgery flap. And in case of extra-articular resection, tibio-calcaneal fusion is a viable option. Thank you.
Questions from the audience? In cryo-recycling, is it a single-stage procedure or you need to do two-stage?
Sir?
In cryo-recycling of calcaneum, is it a single-stage procedure?
Single stage, sir. Single
How
stage.
long it will, you need to keep it in?
So 20 minutes in the liquid nitrogen. The liquid nitrogen temperature is minus 196 degrees centigrade. After 20 minutes dipping in liquid nitrogen, 10 minutes in room temperature, and then 10 minutes in distilled water. So it is a the principle is fast cooling, rapid cooling and slow thawing. By rapid cooling and slow thawing, there is intracellular apoptosis and intracellular ice crystal formation, thereby the tumor cells are killed. This is the philosophy of cryotherapy.
Any role of arthroplasty? Just like proximal tibia, you do wide excision and do arthroplasty.
This means ankle arthroplasty?
Yeah.
Sir, personally I have no experience, and in our training also I have never seen being in arthroplasty. Mega process is not available. This customized mega process is available, sir, but that results are very poor.
Kaushik, one little thing. When you get the sample back after cryo, how do you do any test to make sure there is no cell? Any way of scanning it, seeing that you're killing all the cancer cells? How are you 100% sure that all I did?
Sir, intraoperative, there is no possibility to check, because if we send the biopsy from the post, there is a option. You can send the post-operative from the post-cryotherapy specimen. We can send the biopsy.
Okay,
but the complete killing and complete necrosis, it takes 24 to 48 hours.
Okay.
So they will give, the histopathologist will give a viable tissue, viable osteosarcoma or Ewing sarcoma cells. That may be very shocking for the clinician, but ultimately at the end of 48 hours or 72 hours, that will be necrotic.
There is an oblique answer to it, that there has been enough literature evidence on those are not reimplanted onto the patients, but tested for presence or absence of malignant cells.
Yes. Thank you, sir.
Okay, thank you, Kaushik. Now we'll go to another difficult topic, pilon fractures, from none other than Rajiv.
Hi, so basically this is one of the IFAS talks. So what I have done is the IFAS talk, I've just put in some of my thought processes down. So this is a case where a 40-year-old gentleman, so I'll just go through the talk, and at the end we can just discuss the pros and cons of what happened. So 40-year-old male who fell from a height and a fresh trauma with an open injury with the lower tibia sticking out like that, and that's the X-ray. So what has happened in fact is that the talus has shattered here, the tibia is broken into 3 pieces or bottom end. This is one part which is stuck in the lateral gutter, the medial side is flipped over here, and this combination here, and the fibula is broken somewhere there, and this anterolateral area is completely smashed. Standard plan for any pilon fracture or periarticular bad tissues is span scanner plan. And remember, with a problem being with pilon fracture, you have 3 problems: soft tissue, the thing sticking out, metaphyseal combination, articular problem. So we have to deal each with a time. For soft tissue is span. Now regarding spanning, what you could do is you could actually, it's just not putting a X-fix on. You can use the X-fix to reduce the fracture. So important thing is to get pins in the calcaneum as posterior as possible, one in the cuneiform and one in the tibia slightly anterior. Reason being, you can use the bars to connect, and you can use the calcaneum tibia axis, make it posterior tibia, because what happens when the talus breaks, it breaks and comes in front. So if you have this bar behind, it pulls the talus back. So you're correcting the forward subluxation of the ankle mortise. Then you put this bar on. So with this, what happens normally is the talus dorsiflexes. You can plantar flexes using the front rod. And with the calcaneal navicular bar, calcaneal cuneiform bar, you can correct any adduction and abduction. So using the fixator, you can do the reduction on table, and because of the open wound, you take the opportunity to put some blunt instrument in to just flip the bones around to their position. So use that opportunity to reduce it. Give it a good wash, thorough debridement. So obviously span, debride, and then plan. Remember, over distract. You have to get the the coin sign. So you have to get the fibula down to exact length. Now comes the question. So this is what has been done. This is how it's crushed, brought out to length. So these little bits of bone has been pushed in and has been distracted out, and the forward subluxation, the dorsiflexion has been corrected using the distractor. Question is, fix the fibula or not? I think I bring the house here. First, the chairpersons. If you have a fracture, Pilon fracture, fibula fracture, would you primarily do a definitive fixation of the fibula on day one in today's age? Okay, so good soft tissues, you do it. So how many of you do a primary definitive fixation of fibula on day one? How many day one? How many of you wouldn't? Okay, why not? Good. So this is a recent thing that one, skin, as you said, soft tissue, because we are looking at, we have said the challenges are three: soft tissue, metaphyseal combination, joint destruction. Soft tissue. With the fibular incision, sometimes in a swollen leg, you might get it slightly more anterior. So if you have to do an anterolateral approach, it might be the bridge might be too close. That's one. Second bit is the most important bit. Fibula quite often is a tension failure, comminuted crushed fibula. You might fix that fibula in either malrotation or slight shortening. With the fixator on, you can't go in for at least 10 days to 2 weeks. Fibula becomes sticky. When you try to do the tibia, that malrotation and maldirection will prevent your tibial reduction. So the present dictum is, if you need some stability, just put a wire up, just to give stability, side to side stability. But try, especially if it's a standard transverse short oblique, you can do it. But if it's combination, don't do it in day one, because you might need to dial in either side. So you do the fibula, temporarily go back to the tibia, then go back to the fibula till you get an accurate reduction. Because if you reduce the fibula imperfectly, tibia will not reduce. So the 2015 paper said this, not to do it at the first stage now. And I have also changed my practice. Last 5-6 years, I'm not doing it on day one. Coming to assessment of the X-rays, what is important is to look at the fibula, look at the tibia fracture displacement, look at the articular combination and metaphyseal combination. Why? Is because you need to identify the tension failure and compression failure. Remember, Pilon is all about biomechanics. Where you put in the plate, how you do it will depend on which side is failed. So we look at this fracture here that we saw now, which has got, starting with Sir Chairs. So which one, is it a compression failure of the medial or lateral part of the tibia? The compression failure has happened where? The medial part or the lateral part?
Actually the pre-reduction X-ray tells you much more.
Agreed. So pre-reduction only showed you
in these after reduction, say
even with this is so obvious.
There is no comminution in the medial side. Okay.
So
that's the tensile side. And the comminuted side is the compressive side.
So this was for the juniors. Basically, the compression failure has happened. So whichever direction the talus goes. So if it's a valgus or outer, it is the compression side. And usually the bone is crushed on that side. If the talus goes medially, you see crushing medially, it is a compression failure on the medial side of the tibia. For the fibula, is it important?
Actually, the Pilon fracture itself is a result of classically teaching is that it's a compressive fracture.
Yeah, but
Compression fracture,
peculiar.
but unfortunately during these motorcycle accidents, the accidents happen in a random way.
Exactly.
So there is a Pilon component as well as a rotational
Rotation
component
and a
like
translation
ankle
component.
fracture. So it's a combination
Fracture.
frequently.
Absolutely.
Yeah.
So for the fibula, again, do you think any differences? Do you see any differences in the type of fracture?
In the fibula also.
Yeah. Is there a compression or tension failure?
Yeah. In this fibula, I'm not sure.
It's difficult to say if there's combination. If this
Can you show me the first X-ray, the pre-reduction X-ray?
Yeah.
Well,
oops. Yep.
I'm not sure also. Again, looking at the fibula, the short oblique fracture just above the tibia fracture finishes. So it may be a tensile fracture on the medial side.
No, again, is what happens with the tension. The tension, it will break near the syndesmosis.
Nearer this one.
It is higher up on the syndesmosis. It's more transverse. So remember that the AO classification has gone in reverse way. So a transverse fracture is a high energy fracture. Yes, a high energy fracture is
it's a slightly oblique on the
it is a reasonable transverse fracture. So which means that is a high energy fracture. High energy fracture is a compression fracture. So high energy is so you calculate this way. High energy is a compression fracture. Low energy is a tension failure. The failure of the fibula is also in compression here. So why I'm bringing all this up is then you can plan your what implant and where. One thing was missing in this presentation, IFAS presentation. Sorry, I couldn't put it. So I've just put it on because a CT is important to identify the fragments, posterolateral, medial, anterolateral, because CT gets you the gateway to how you go in. If your fracture exists towards the lateral side, use the lateral approach. Exists towards the medial side, anteromedial side, use the medial approach. So the way you fix a fracture is first get the posterolateral fragment, make sure that's reduced, then reduce the medial side, then get the articular fragment on the talar dome, then close the door from the front. The front is the door from which you go in. So this is the way you do the articular surface, put KOIs in, and then think about the plate. Now coming to the plate, what plate would you use on this? Asking the house. Would you use a, why?
Go in through the anterolateral approach, you can fix the distal, then you go take another approach which is posterolateral, then you can fix up all the fragments together.
This
and the medial malleolus you can go separate.
This did not need, this one basically did not have much of posterolateral, the posterolateral was stable. Go back here, posterolateral was stable. So I've got it as posterolateral as well. See that fragment was there against which you could build everything in. So I've got a picture there. So anterolateral plate, why? Any, yeah? Fine, that's the answer I was looking for.
And the base in the articular block will be based on the posterolateral fragment, which usually doesn't displace.
Absolutely. He's got it, nailed it. So basically, your plate should be where the compression failures happened. Whichever, so easy way to remember, whichever where the talus is moved, whereas the combination is, that's where you put your plate in. And it will be dictated by your entry, where the fracture exists. So obviously, in a fracture like this with anterolateral combination, compression failure on the lateral side, the fracture exists laterally, it's an anterolateral approach and anterolateral plating. And the fibula, again would be, you have to, because it is it's not a tension failure, you need a robust implant. So it has to be ideally a 3.5 LCP, sorry.
If it's a valgus failure, anterolateral plate. If it's a varus failure, medial plate.
As simple. So why is it based? It's because it's based on biomechanics. Biomechanically, compression failure side needs more stability.
Right.
The tension failure side needs less stability.
In these pilon fractures, there's a long segment for your plate fixation, and there is a short segment. Okay. If the short segment moves in a certain direction, you use your long segment to fix it as a butt press and push it in the.
So this is all.
You cannot pull it back because the metaphyseal bones are so weak, so you cannot pull it back.
There's a biomechanics behind it. Because the compression failure is the weaker side.
Yes.
So whichever side your building collapses, you put your support on that side. That is the reason we use the plate on the implant on the lateral side. So this is a thought process I want you guys to think about. Yeah, carry on.
Which way the articulate is communicated, whether it's the sagittal plane or the coronal plane, that will also decide your plate placement.
No.
Suppose you have fractures in what do you call it, in the sagittal plane. So if you put in an anterolateral plate, all your screws are going from anterior to posterior. It's difficult to hold the fractures that way. Suppose the fracture in the sagittal plane. If the fracture is in the coronal plane, in that case, anterolateral plate will hold better. Besides the biomechanical thing, even the articular segment decides which plate suits best this pattern, or maybe you have to put in two plates in that case.
This is mainly the articular block you're talking about.
Yeah.
So remember, in the articular block, you have to address it separately. So you might end up using multiple plates, because these two, you differentiate Pilon, as you know, Jida very nicely said, it's just not a drive force, it's a translation rotatory force. So the plate is for the metaphyseal-articular support. Now split we are talking about, the coronal or the sagittal slit, is the articular block. So that you need to reconstruct first, put your screws in,
that is the first
absolutely, that we have said first.
Yeah.
And then that you have to address as required. You put your plate, small little place as required in the articular block, and then this is connecting the articular block to the metaphyseal block. Okay? The CT scan, they didn't give me CTs for this. The CT of some other case. And present IFAS case, that's a problem. I had to do a IFAS case presentation, I was told. I was instructed to do the IFAS case presentation. So in this case, this was done, the medial side, there was a little medial malleolar fracture, which is fixed because it was comminuted, fixed with 2 K wires. And we have discussed this. And very important, again, remember is that the fibula being a compression failure, not the spiral fracture. This is a really transverse short oblique. This is a high velocity compression type of injury, so that needs a solid plate. So anterolateral, so first the fibula was plated, then anterolateral plating. So if you're doing fibula plating with the anterolateral approach, drop your fibula incision a bit more posterolaterally. So you have a good bridge of at least 4 finger breadths. Small piece of bone, clean wound, you can put it back on. Don't throw it away. It can act as a strut drop, but make sure it's spiked in both. Don't leave it loose, floating about. And this has been done, and this is an X-Fix was used to hold it down. Closure. Do you do anything special for the closure? Do you do normal stitches?
Unless I'm forced to. If I'm forced to, you can.
No, if you're closing the wound, for all my calculums, all my ankles, I do one specific type of stitch.
Okay.
No, okay. So I think we are running short of time. Donati Algova stitch. Donati Algova stitch. This has to be done for all calcaneums, all ankles, all pilons. So what you do basically is like you start from one side, take the subcutaneous from the other side, pull it around. With this, I would say maybe my ankle problem skin rates have gone down to about 5 to 10% compared to 30% before. So do a Donati Algova for juniors again. Donati Algova stitching, learn it, look it up. I've given you a pictorial diagram. It takes a bit of time to do, and when you take it out, it's a bit painful to the patient. But with that, your wound complication rate will drop down drastically. So mine has been a 20% drop. The skin bridge is shown here, at least 5 to 6 centimeter skin bridge between the lateral and the anterolateral approach. 3 months post-op, holding well. 5 months, bone has started healing, and he has started moving, walking, bit of a limp. The important thing in this case is plan. So before you start off, soft tissue, divide into soft tissue, and as Siddharth said, articular, and as I said, and we all discussed metaphyseal. Soft tissue, span, take an X-ray, scan. Don't do your scanning, don't do your articular planning before doing the X-fix. You won't understand what's happening. Fibula, yes, there is still a group that would do it immediate fixation, but now I have moved away from it, but I found out if I have malreduced the fibula, I find it difficult to do my TBI later on. I might have to redo the fibula, again it's a big problem. So I don't do the fibula now, I just put a wire up. Do the fibula, start with the fibula to get my length and rotation. I don't close the wound, they had closed the wound, I keep it, I don't put all the screws in the fibula, because I might need to redo it a bit. Come to the tibia. Start with the articular block, start with the back block. Build everything around the back block, and as Siddharth very nicely said, if it's a coronal splits, address each split, put small 2 millimeter screws into each split. Keep metacarpal plates, you just bend it and put it to hold it down. So when you're doing pilon fracture, keep everything available, including handset. That's very, very important because that is not there usually. Keep 2 millimeter screws because you might need them to get this. So get the articular block, posterior, get the medial side, tap the articular surface onto the talus dome, close the front, and then decide. Then look at which side failure you have decided. It is a lateral combination, lateral shift, anterolateral plating. Medial combination, medial shift, antemedial plating. Also soft tissues will dictate where you are going. Lastly, we are worried about X fixes, and I think there are enough studies to show even with a minimally invasive, proper articular reduction and articulated external fixator. Mike Saleh from Sheffield, he's an amazing guy. I mean, he was one of the first chaps when I was training there who started Elizorovs there. He's got the series, which amazing results. I think Doranagam from Royal Liverpool has similar results of nearly 90-95% success rates with Elizorovs and minimally invasive fixations, especially because they deal a lot with RF pilots, crash landing, parachutists crash landing. They have had results of 90% getting back to duty, active duty. Thank you.
So basically you agree to that it's a soft tissue injury with a few bone pieces inside.
Absolutely.
Thank you for a nice insight in pilon fractures. Now we have talus injuries. And is it a online lecture or what? Online lecture. So Dr. Siddharth Sharma will tell us on talus.
Good afternoon, everyone. This is Siddharth Sharma again from Chandigarh, and now I will be talking to you about a case of a talar injury. So this is a 22-year-old male who comes to our emergency after a road traffic accident, and as you can see, they have a tibia and a fibular fracture. This patient was planned for a tibial interlocked nailing. The interlocked nailing was done. The patient was made to stand and walk a few steps in the ward, but immediately he complained of ankle pain. So X-rays centered over the ankle were then obtained, as you can see here. And is everything okay? So well, there seems to be something going on at the level of the talus, and you can see that there is a fracture happening at the lateral part of the talar body. So what do you do next? Do we sit on it? Do nothing? Discharge as per usual protocol? Discharge with modified weight bearing? Maybe the patient is asked not to put weight on it, or get a CT scan. So in this case, when you can identify some problem happening at the level of the talus, it is better to get a CT scan so as to better identify the fracture pattern. So the CT scan actually shows that there is an osteochondral fracture of the lateral half of the talar body, as you can see here. Now mind you, this is a significant intra-articular fracture of the talus, and left alone, it has a tendency to displace. It can cause arthritis and all sorts of problems, and like any other intra-articular fracture, this needs to be anatomically reduced and rigidly fixed so that patient can have a painless, early, stable range of motion of the ankle joint. As you can see, this fracture is the fracture line goes from a lateral to the medial side, but then it is also going from an anterior to a posterior direction, so much of it is also in the posterior plane. So the next question is, how do we go about fixing this fracture, which is principally a lateral osteochondral dome fracture of the talus? How do we approach it? How do we fix it? These are all the options to us. So of course, non-operative management is out of question. Could you do a percutaneous fixation? Well, it is an intra-articular injury, and our goal is to do an anatomical reduction. So unless you visualize the fracture directly, either through an open approach or for people who know how to, maybe through an arthroscopic approach, you cannot be assured of 100% anatomical reduction. So this patient would need an open reduction or internal fixation and rigid fixation by means of screws. So in this case, because the fracture was lateral, we chose a lateral approach. Now you can see the previous incisions. So there is something going on at the level of the metatarsals where a K-wire was put, and then there was an open wound laterally which was sutured. But we chose to go by the anterolateral approach. And as you can see, this is the superficial peroneal nerve which was protected and retracted out of the way. And then you can see the fibers of the anterior inferior tibiofibular ligament, which is the AITFL. These fibers were then cut sharply with a knife. They were tagged. You can actually see the vicryl sutures which have been used to tag. The fibular K-wire was reduced. Now remember, this patient also had a fibular fracture. So we have cut the AITFL. The fibula was already fractured, and by means of this we could actually rotate the fibula externally. By doing that, you can see that the talus is exposed, and this Langenbach right angled retractor is actually retracting the externally rotated fibula out of the way, and by means of this approach we are able to see the fracture site very well. Now the fracture was reduced under vision and held in position with guide wires. Herbert screws were put in and they were countersunk to lie beneath the cartilage of the talus. This is what the final fixation looks like. One small buried wire was also used because it was a large sized fragment. And because there was an open fracture of the fibula, the wound was not very good. So the K-wire was put back in place. We did not plate the fibula at this point of time. The AITFL had been divided sharply. It was repaired with heavy duty vicryl, and you can see that at the end of the procedure the nerve is still intact. The syndesmosis was stressed because the AITFL had been repaired. There was no syndesmotic instability. So in this case, the osteochondral fracture healed uneventfully and the patient did well. At 2 years, I'm sorry I don't have the x-rays, but at 2 years there was no evidence of arthrosis and the patient was walking about without any pain. So this patient did well. Now this is a slightly unusual case in the sense that most osteochondral fractures are on the medial side, but sometimes you can have fractures like this which can be missed initially, and the idea of presenting this case was to show you that rarer forms of injuries like this can happen and they need to be anatomically reduced and rigidly fixed so that your patient has a good outcome. Thank you for your attention, and I am happy to answer any questions that you might have.
So officially this session ends here, but we would stay and call upon Dr. Amitabh Narayan Mukherjee to join us here for the next 2 talks, please. So Amitabh has agreed, and now we request Dr. Sudesh Saha to talk on midfoot trauma. Again, a big topic, and time is also very short.
Is the mic working? Yeah. Since morning, a lot of good learning, and then let's go ahead with some of the cases. We'll try to make it more interactive so that we all can learn. Okay. There's a 25-year-old gentleman, motor vehicle accident, foot pain and swelling over the midfoot, comes to the ER with this X-rays. I'm not just going to present this case, it should be more interactive. So I would ask Biplab to take this case. Any insights on these X-rays, Biplab? Any informations or any further investigations you want to do?
How is the soft tissue condition?
There is a foot swelling, there's no open wounds, and the swelling is specific to the midfoot. With these types of injuries, do you need to see something more?
I need to check the other bones also.
No, the injury is only specific to the midfoot. Not even the hindfoot. The hindfoot is absolutely fine.
It's a Lisfranc injury. Yeah.
You need any other films or any other investigations or anything in the clinical background?
It's a AP X-ray. I need other views.
This is what it was given, something like a AP, something like an oblique. Yeah.
Attempted oblique.
So that's a very good point to be taken. AP and a 30-degree oblique views are two important films which you can take, but the patient had come with these two X-rays. Anything you want to add, Girish?
This is a very obvious Lisfranc injury. So we don't need a stress X-ray. We don't need a MRI to look for the pure ligamentous injuries. We need a CT scan and a foot lateral view.
Foot lateral view. That's probably is the another point which we should take.
Yeah. So foot lateral view will definitely see. These are all the hyperabduction of the metatarsal. If you look at the base of first, abducted, subluxated. Base of second, subluxated. Third, out of cuneiform. Fourth, out of cuboid. Fifth, out of cuboid.
Everything has gone.
So everything has gone laterally. So that has created a lateral column injury as well. So next investigation will be the foot lateral view followed by the CT scan. CT scan for the planning, not for diagnosis.
Yes. So the points taken, patient comes with these X-rays. One clinical thing is you might need to look at the sole if you see for any ecchymosis, but for such an obvious injury, you are really not bothered about it. The second point is you need to have a lateral film and CT to plan further. Okay. The patient had a huge swelling. Now in a scenario where the patient had a huge midfoot swelling, what is your threshold? Would you go in to think about compartment and do releases, or you want to do something else? I have already mentioned everything is okay, but still, if the patient has a huge swelling, go the.
Just yesterday I delivered a talk on compartment syndrome.
Yes,
So
that's why I pointed the question straight away to you.
So I will be more biased because I know better here. And of course, there is a possibility of at least two compartments being, I mean, at least swollen up. Whether it has gone beyond the critical value, I don't know.
Anything to add, Rajiv? Or you just put in a well padded back slab and elevate the leg and wait?
If the patient is in pain or not responding to at least basic analgesics, go ahead and decompress.
That's the point to be taken.
You will never regret it.
Excruciating pain, not relieving with routine medications, you might think of release.
There are so many drawbacks on that concept also.
Okay, but in this case, everything was okay. So we don't want to go into the Lisfranc types, we have all discussed about it. We don't need to discuss this, but this is in addition to another case which will be there in the after one or two cases, then we'll discuss about the low energy. This is a very high energy. Any specific take, Rajiv, on timing of intervention? The next morning you want to intervene?
No, just wait for the swelling to come down at least.
You just want to wait for the swelling to come down?
Yes. If there's no compartment syndrome, I have no hesitation in giving a well-padded back slab elevation, analgesia, observe, let the swelling, because these skins are dead icy.
One point which Girish said, that you need to have a lateral view to see if any of the bones are jutting onto the skin. Then if that is the scenario, then you might have to go in early.
Absolutely.
Otherwise, probably you don't need to be that urgent.
And Sudesh,
you can wait for the slow.
Sudesh, if you think about compartment syndrome is happening there, don't elevate it beyond the heart level.
That's, yes. In doubt, don't elevate.
Okay. Incisions? Can we go back to the X-ray? You want to see the X-ray?
See, incisions you can start from the base of the first metatarsal, and either this or you can have a split incision in between the first and second metatarsal.
So, point taken, you want two incisions?
Yes.
Not one incision?
No, I would be comfortable. You can have one incision.
So the fracture pattern, what you wanted to specify is the fracture pattern decides the number of incisions. Preferably in these patterns, you might need you will need dual approach.
For that you need the CT scan first.
Yeah, we don't have it here. Anything in the inventory you want to add rather than the routine foot implants which you get? Anything additional you want?
I would keep, don't take me otherwise, I would keep mirrors in my hand in this case.
Before you want to add anything more?
Plate, screw and mirrors. And
plate screws, size 2.7, 3.5 or smaller ones?
2.5 and 3.7. Smaller ones you can always have to have because for the foot fixation of the foot plates.
All foot devices are 2.7, so you want the 2.7.
Yeah.
Do you need longer ones? Any opinion on that?
Standard foot set.
3.5 sets? Not needed. So the message is again 2.4 system should be with you and still smaller ones if you need be.
Keep the handset also ready.
Yes. Coming to the sequence of fixation. Rajit, again take please. Biplav, you can take sequence of fixation.
First the medial column, then I need
You straight away go to the column.
rigid fixation on the medial side.
Yes. Once you've got the CT scan, you first see the intercuneiform first. If the cuneiforms are sitting right, then straight away go to the column or go to the Lisfranc.
I'll fix the first metatarsal with the cuneiform first.
You want to fix the first metatarsal. The first medial column has to be restored to length, alignment, and then you want to fix the cuneiform, and then go to the third, fourth, fifth. So you would span the medial column with a plate. So the span will go from where to where, like first metatarsal to medial cuneiform, or still more proximally?
Initially, first metatarsal to the medial cuneiform properly reduced in a congruous position.
Okay.
Then after you fix it up, your length, alignment and axis is maintained. Ideally, everything should fall in place. If it doesn't, then you have to put a second incision and reduce it and put a small plate or a screw and then oblique screws.
Got your point. Biplav, you wanted to differ from what Amitabh said?
There is an oblique fracture in the second metatarsal also. That
Yes.
may cause some problem. So
There seems to be a combination in the base of the second metatarsal.
So that can cause some problem.
So
you have
does that combination change your plan of fixation on the second empty
doesn't
with
change
the
goal.
tarsal?
It doesn't change the goal, but yes, it can change the actual technique.
Maybe I have to do
Would like to do intra-articular screw fixation or span that phase? Probably spanning is one of the better choice with a dorsal device. Girish, you want to add something?
There are two ways to there are two ways to fix this injury. Yeah. So one is, which is the ideal approach, is take one inch. Sorry. Oh, sorry. Yeah.
Is the pointer come?
Pointer come. Yeah. Okay. So take a one incision here, direct medial approach, and take another incision dorsally between second and third metatarsal or over the third metatarsal. That also fine. Now this is your first incision, direct medial, and second incision between second and third dorsal. Now you put one K-wire in the medial cuneiform, one K-wire in the metatarsal, distracted. Simultaneously you do the reduction of
fourth and fifth.
Second, third and fourth also with the dorsal incision. So both the reduction has to be done simultaneously. If you just distract, it cannot correct the hyperabduction deformity of all metatarsal subluxation. So both the reduction, on one side you have seen the first TMT, on dorsal incision you are looking for second and third TMT. These all three metatarsal should be reduced together by putting a small corpse elevator. And then you distract while fixing. Now once you reduced TMT joint, now you distract the medial column. In the distraction you put a plate, long distraction plate from direct medial surface from cuneiform to base of first metatarsal. Now we are going for the fixation of second and third column injury. For the fixation of second and third column, you need a long 2.4 mm plate, T plates. Because look at the fracture of second metatarsal. You need a buttress plate on the dorsal surface from cuneiform to the shaft of the second metatarsal. Similar, you have to do 2 or 3 hole plate for the fixation of third tarsometatarsal joints. T
pattern
or,
plates.
Yeah. And for the fourth and fifth, you can put
just
a
stabilize
K-wires.
with K-wires.
Only K-wires, yeah. Thank you.
Well done. So a lot of messages. The crux of the discussion is medial column has to be put to length. If you have intra-articular fractures at the base of the second or the third metatarsal, which is the intermediate column, it is better off to dorsally span with a plate rather than giving intra-articular screws. These are 3 metatarsals, can be fused, can be fixed, but you need a flexible fixation for the 4th and 5th, which is the mobile segment. So, we have discussed, so there were 2 approaches, 5 centimeters apart so that the skin bridge is okay. So that is what we have discussed in details about this fixation. That's the follow-up. Do we need to remove any of the implants? If yes, then
just
when?
one point, Sudhir. Do we need to fix the navicular also?
Do we need to fix the?
Navicular also, as you have done.
This is not my case.
No, that's not
for discussion.
No, that's not that. That's the high point. I think that's a overkill. I think.
Fixing the?
In this injury, you can restrict your fixation up to cuneiform.
Right. Okay.
But if there is an NC joint involvement in CT scan, of course you have to go ahead.
Oh, you were talking about the length of the plate on the medial side?
The navicular has been fixed in this plate.
You don't need to go to the navicular probably. You can differ. You can stop at the cuneiform also.
Right. That's the point.
On the contrary, sir, you can use up to navicular because you are doing open adduction interfixation and you have to remove the implant. You are not doing fusion.
Right.
So you have to remove everything at the end of 6 months.
Most likely. But still, if a cuneiform is sufficient, then okay. If that is not
then
there,
you don't need it.
then okay.
Yeah.
Okay.
But the K-wires need to come out earlier.
Earlier, yeah. 6 weeks you can remove the K-wire. All the 3 implants, all the 3 plates should be removed at the end of 6 months.
6 months.
And what about the 5th metacarpal and cuboid joint? You can see there is irregularity.
Those are the flexible fixations.
Look
on
at the
flexible.
oblique view, sir. To look for the 4th and 5th, you have to see the oblique view. AP cannot give you the idea of 4th and 5th.
But still in the AP you can see there are combination and that things. So that is inviting if in future the osteoarthritis. So why not, whether we can go for fusion or not? That's the that's from expert from masters. Okay.
So I think to comment on 4th and 5th, just follow the oblique view. Yeah. Many times it gives us the overshadows.
30-degree oblique view probably gives me an idea of the alignment of the 4th to the cuboid and the 5th to the cuboid.
Yes.
See,
I think that message is very clear.
Biomechanical is a complete abduction injury where the whole forefoot went like that, and because there's been crushing of the cuboid. You can't do anything about it. You have to accept, sir, you can't be God. Yeah. So that crushed area is going to remain. Bit of foot pain is going to be there. Just warning, because this sort of injury, this sort of one side completely, so it's just gone like that, hit the cuboid and crushed it.
Yes,
is going to be there.
foot pain will be there.
Let's just accept that.
Sudesh. Okay.
Yes.
To get everything into.
To get to length.
So what about using a just distractor? Then once you have fixed everything, don't come up to the navicular. With the definitive fixation, you can come up to and manage only with the cuneiform.
A distractor will help you to aid in reduction and plating. You don't need to keep the distractor. Interoperatively you can use.
Later on you go for decisive final fixation.
And take off the... that's a very good method.
Sudesh, can we go back to the perioperative skin incision slide also? Skin incision slide.
Yes.
You see, this is probably good for a 25-year-old person.
Yes.
But this length of this tramlining is not good for, say, 45-year-old diabetic person.
Length of the incision?
Yeah, length and tramlining of this incision, because essentially it's a bipedicular flap. So if the
So,
ratio
so
is
that's
more
what
than 2 is to
Girish was
1,
talking about. You should have at least 3 fingers of mine is about 5 centimeters.
Length is also
5
important.
centimeters gap between 2 incisions is safe enough.
yeah, safe enough. If it
And
is the length
Rajita
is
already
also
talked
2 is to
about
1.
skin swelling to come down before you get the approach well.
Obviously.
Both the incisions, they have a different vasculosome, sir.
Yeah.
These two incision.
Yeah.
So one get the feeding vessels from the anterior tibial artery and what get from the posterior
That's the
tibial.
safe limit.
So
yeah.
that's the safe
but
limit.
if it is too long in a diabetic patient, in an older person, where
So
there's already vascular compromise.
even longer is better, sir. If you are doing with a shorter approach, shorter
No, I'm
this
not
thing.
talking about shortening the incision. I'm talking
Uh-huh.
about increasing the gap between 2 long incisions.
Between the two, yes.
2 long
Yeah,
incisions.
yeah.
Length has to be there.
So we are finished with one case, and to take home, we've understood classification and the types of Lisfranc, dual incisions, planning, direction of Lisfranc fixation screws. We haven't discussed much about it, but finally the take is probably from the second metatarsal base, which is the stronger bone, to a larger bone, that is the cuneiform, is a better way to go. You can go the other way also. But you need to remember, you need to keep your 2.7 implants and 2.4 mm implants. And for younger patient, non-comminuted at the TM joint, it is better to span the fixation rather than plan intra-articular or arthrodesis. But for older patients, you can think about arthrodesis. 4th and 5th, usually flexible, 1, 2, and 3 solid fixations. Thank you.
Thank you very much. And now we'll move literally forward to the forefoot. Dr. Girish Motwani, please come over.
Again, these are all the already sent slides, so not my case. Forefoot trauma should be more about the metatarsal fractures, should be more about the Jones fracture. But this time IFAS has decided to take some different case, so we will discuss this case only. 22-year-old male, he had a twisting, he had a 3 months back he had an injury while playing. The injury was managed conservatively, and this is the picture at the end of 3 months. So on the right side you can see there is a hallux valgus deformity and it is post-traumatic deformity. So anybody has an experience of seeing this deformity after any toe fracture or anything which is post-traumatic, because hallux valgus we all know, but post-traumatic hallux valgus, any experience you have seen?
Combination on the lateral side, they have a tendency to go into hallux valgus.
Perfect. So this is a similar case, sir. So this is the fracture injury, the same what you are saying, P1 base. This is sort of MCL avulsion injury. So that makes the fracture unstable. So anyway, question to panelists: if this injury comes to you on day 1, K-wire or strapping? Opinion of all 3 panelists, sir, starting from sir. Yeah, K-wire or strapping?
K-wire preferable.
K-wire preferable, sir. K-wire or strapping?
In this particular fracture, yes, K-wire.
K-wire.
In this particular fracture.
Okay, sir.
Because if the bone flake is un-K-wireable, then there is a different issue.
Immediate presentation of such injury?
This looks K-wireable fragment.
K-wireable, okay. So anyway, yeah. So who wants to apply the body strapping? Who will do the body strapping? Everybody know the answer. Okay. So this was. Yeah. So for all the lesser metatarsals, you can apply the body strapping, but for great toe, don't apply it because.
Excuse me, sir. Would great toe spreader will help here? No, no.
Spreader?
So great toe spreader. I'm just asking.
I don't know, sir.
Now the same thing which has been used for the hallux valgus for conservative treatment.
Yeah. So this is a fracture condition. I don't know whether that flexible splint will work or not. This injury, why this X-ray was kept in the today's presentation is, when you see this kind of injury, a base of P1 avulsion fracture with a great toe going into valgus, these are the cases where you have to keep a close watch, and you have to tell the patient to come to your OPD every week or every 15 days to see whether the great toe is going into the valgus or not.
Girish?
Yes, sir.
Is there any role of, theoretically, not in this case, theoretically, great toe spica plaster?
Yes, of course, yeah. This is, spica splint you can apply, yeah. Anything like it is basically a MCL injury, so you have to prevent the displacement, that's it. So the CT scan was done because it is already 3 months. You can see that that fragment is in non-union. This is a big fragment into the non-union. The MRI was done to see the quality of the MCL, so MCL was intact, but it was avulsed from base of proximal phalanx. So what are the options now? Conservative or fix the fragment with or without the MCL repair or something else. What can be done here? Or we should go ahead with the osteotomy of the hallux valgus. Osteotomy of the hallux valgus, sir? But it's a post-traumatic deformity, just 3 months old. Soft tissue problem. So only the soft tissue reconstruction, sir?
No, is the bone mobile at the fracture zone? If it is still mobile, then I would think about fixation distally. Otherwise, the proximal MCL reconstruction.
But this has already created a deformity. It has already created a deformity.
It's
so you need to do the
deformity.
Fixation using what, sir? Fixation using what?
So why don't we think of it like a shoulder tuberosity fracture? As the tuberosity gets pulled, the rotator cuff is pulling it off. So it is just not a fixation, don't say it. It's a combination of bony as well as soft tissue procedure. So go in, clean the trough, fix the bone with a mini fragment set, along with it, take the MCL and do a double row repair. Just go distally and give a stability distally.
Good idea, yeah. So there are many options, yes. This is one of the good options, that the principle is you want to get back the continuity of the MCL and you want to correct the deformity. So how can we do that? So this is how they have done. This is avulsion fracture, direct medial incision. Look at the non-union, intraoperative image, non-union fragment. It is attached to MCL, dissected out because it is non-fixable. So after this, 2 anchors were inserted. No, 1 anchor is inserted at the base of proximal phalanx at the site of attachment of MCL. This is the adding of Achilles osteotomy, because just repairing the soft tissue, there is a chance of recurrence because it's already 3 months old and the deformity was already developed. So they have added the Achilles osteotomy as well. That is a medial closing wedge osteotomy. Some people may say that is overcorrection. That may be good correction now, but it may be overcorrection. So anyway, this is a fixation done. The message we want to give from this is a follow-up X-ray which is showing a great toe. See, normally a great toe should have 5 to 10 degree of valgus. It is a straight toe. So you can blame this as a varus deformity also. If I am doing the case, I can do a augmented repair of MCL only. Yeah. So this is a 3 months follow-up. Anyway, the patient is doing well. 1 year follow-up. No any obvious varus deformity, but it's, I think, overcorrected. Look at the opposite side. It is overcorrected. But this is one of the way to manage. These are the various causes of post-traumatic hallux valgus deformity. 2 or 3 cases has been reported in the literature by similar technique. So the conclusion is avoid the body strapping. For all the youngsters, don't apply the strapping here. Keep a close watch on the lateral deviation. If the deformity develops, you can fix the MCL or you can fix the bony fragment. Achilles osteotomy helps to reduce the stress on the repair, plus minus for me. Thank you.
Thank you very much. Any questions from anybody?
What is the take home for these injuries? Would you plan fixation on day 1?
So that's what, close watch. So
you have to start with the conservative treatment.
What?
So basically, don't apply the plaster, but don't apply the strapping also. Just observe them. If they are going into the lateral deviation, then only they need repair.
Okay.
But there is nothing called thumb spica splint for the foot. But yes, you can. Huh? Bunion split also you can use. Yes.
Just because the numbers are so small and we don't just a discussion, we can just think once the swelling comes down, give a local block, do a stress X-ray. If it looks unstable, go and fix it. Because doing them acutely, you have a better chance of, I just said bony like tuberosities. I'm just thinking like a shoulder.
Yes. Your advice is also right. Because you are following the overall principles of instability. Yeah. I think it's a good idea. So if there is a avulsion fracture, you don't know whether it is from the complete MCL or some part of the MCL is still intact. So you can give a stress and check. If it is unstable, fix on day one. The good advice. There is no clear-cut guidelines. This case was put just to increase the awareness of prevention of these deformities.
So
but yes, this is a good option.
If the fragment is quite sizable, then probably the whole of the attachment is with the bone piece. So it will be unstable. In that case, it is fixable also because the size, so you fix it.
Perfect.
Like your olecranon fracture.
Early fixation is always easier.
Yeah.
Because there's a crater which you can put the thing into, the bone hasn't shrunk.
And better chances of bone-to-bone healing.
Perfect.
In this index case,
So
you
I
can
think-
see,
so I think
in the index case, you can see there is subluxation at a joint. So when there is subluxation of BS, so it's better why to be wait. So day one QR fixation is better. That is very simple thing, I think.
I think you guys were right. K-wiring on day one.
Okay, thank you. And this session is concluded. I think the whole lecture was session is over.
Is completed. Just one thing we just announced now. There is 4 workshop is there. So we will demonstrate hands-on. So please stay with us. But before that, I really thank Girish. He is coming so long. So I request our President, WBOA, please felicitate him. Girish, please. Yeah, please. Please, sir. So, along with our Howrah Ortho Club President and WBA President, Girish should be felicitated. So, this is, yeah. Thank you, Girish. It's a good interactive session. This is a small memento from us. Yeah. Huh? No, that I. So, right now we have here suprapaternal nail. Dr. Shutanu Haira is demonstrated here. There is CTEV, so Abhishek, both Abhishek is there with Balada. So see, and there is a hanging arm cast, none other than by Amitabhoda. He will demonstrate that. So these things will be right now. So please join here, who are interested. Please join with this is a day-to-day problem. CTEV, everyone do this plaster. So probably here is the best team who doing the CTEV plaster in daily basis. They are here. Bapada is here, senior most guy. Suprapaternal nail Sutanuda is here to demonstrate, and definitely Amitabhoda is here. So we arrange another table here. Please, I ask the ACT people. Yeah, please, here. So before going to start the hanging arm cast, I request Dr. Amitabh Mukherjee to show his slide, please.
I call it a forgotten. Hello? Hello? Good afternoon, my dear friends, my respected seniors, and my teachers also. Few of them are there. I call it a forgotten treasure, a forgotten art, the hanging up cast bracing. Initially, I say that I am grateful and I indebted for these writings from AO manual. These are the old AO manual, so I have not changed the fronts. Otherwise, if you do my presentation, I would have changed the fronts. This is a very small presentation. Functional, and I will read only the highlight points. Functional cast bracing, as you know, indication fractures for the long bone, especially for humerus I am there. Benefit is early mobilization, early weight bearing, and you can relieve the joints for joint stiffness. So principle is close reduction, immobilization, and functional cross bracing can be used in humerus and in tibia and in femur both. So contraindication, you must know contraindication very well. Unstable fractures, fracture with significant displacement, patient with poor bone quality, certain type of fractures like intra-articular fractures, don't go for there. So key consideration, regular follow-up. Regular follow-up is very mandatory. Adjustment of the brace that has to be done, patient compliance has to be there. So initial treatment is the alignment. Once you put the alignment, then you put a cast bracing, reduction, cast padding, you all know, reduction, application of splint and securing the injured arm. So aftercare is initial mobilization, brace and mobilization. Patient monitoring, healing assessment. Assessment of healing is there. And delayed union, you must know by 3 months if there is no radiological union, just leave it. So I say thank you with two people who taught me this. One is none else than Dr. Shailendra Bhattacharya, and another man who taught us much of orthopedics is Professor Dilip Pal. Both of them we have lost. Dilip Pal is no more from, I think, 2016, and Dr. Bhattacharya is 2018. I am really blessed to have learned this technique right from their hands, and they are one time jewels of this orthopedics of this fraternity. Thank you. So I will try to share my experience which I have been taught by them.
Thank you, sir. Thank you. So last things, on behalf of Howrah Ortho Club, our president, Dr. Jagannath Bhattacharya, sir, please conclude the session so that we can make it by next 30 minutes.
So we are going to conclude the session, a 2-day session. We had a very nice session over here, and we enjoyed. I think the delegates and all the faculty members, you've enjoyed the programs like that. And Howrah Ortho, organized by the Howrah Ortho and also the IFAS. Thanks to Dr. Abhijit Banerjee for organizing these programs nicely. And I would like to end by thanking everybody from our Howrah Ortho Club, and also the exhibitors, and also the delegates, and also the other persons who helped me. Thank you very much.
Thank you. So to 2 days program, we got 9 hours CME credit hours from University of Health Science. This is very important for us right now, because we need to produce 30 credit hours in our 5 years practice. So this will, I think, definitely will help everyone. So guys, when you leave the hall, please collect your CME certificate. CME certificate is here, already ready. Now we demonstrate 2 things. So here we focus the camera, which will be shown in the display board. The CTEV, which is in our daily practice, so we focus on camera over the CTEV hands-on procedure, and Bappada and Balala is there along with Abhishek, so and Anindo. So we just starting this. Ki bolo. Tu da chali da ki chalabe bolo ki do bolo. So here the CTEV, please come here. Few people have come here, CTEV will be here. Please come. Already bolechi ami Bimandaka bolechi. So this is a hands-on experience. You never forget in your life. Here is the senior-most guy who demonstrated this CTEV. I also learned from them.
Today we are going to demonstrate this suprapatellar nail. The thing about this is that normally we do, before the nail, this sort of nails came out from whichever company, we used to do tibial nailing from the infrapatellar region. Okay. So we enter here and then the nailing was done. But there are certain disadvantages of this. Certain advantages that you don't violate the knee joint, and the certain disadvantages that we sometimes if there is a wound here, sometimes if there is a proximal fracture, because this nailing infrapatellar has to be done in flexion. So it has to be done in flexion, and it is not
Those who are for the CTV workshop,
in flexion, especially
please come forward.
Proximal tibial fractures where it comes up due to the pull of the patellar tendon. So, and the other advantage of a suprapatellar nailing is that you can see the C-arm very well. So you can see a direct AP and a direct lateral. So this is the Medtronic system of suprapatellar nail. So in this, the first thing is what we do is we make an incision in the anterior part of the patella, in the anterior part of the quadriceps, about 5 to 6 centimeters above the upper pole of the patella. Knee is flexed in 30 degree of flexion. Then we have to introduce an
আমার মনে হয় ল্যাপটপটা নিয়ে ওখানে দেখালেই ভালো, ওখানেই বলি দিই, ওখানে ছেড়ে দাও। চলো চলো পড়ে গেল তোমার কারণটা
we have to use an
hello.
না ঠিক আছে, আমি I'll tell loudly for this. No issues. ছেড়ে দাও।
এখান থেকে বাজে লাগবে দেখতে, বলিস না করিস না। আচ্ছা, ওয়ার্কশপ is for technique of Monsetti, reduction, plaster, anatomy, and we have decided to go a little bit further. That is to how to identify early relapse, what are the causes of relapse, and what to do. But if time permits, we'll go for that. Before that,
নিয়ে নিন, বার করে নিন। না অফ করতে বললো, একটু ভলিউম কমিয়ে দাও একটু। So the thing is that this goes in and then this locks in this sheath, and this is the trocar. So suppose we have made the incision, then with this soft sleeve we go and make the entry point. Now the entry point is like standard as in most in our infratibial this thing, that it should be in the anterior, it should be a bit lateral to the intercondylar eminence, because the tibia is bowed in a little C fashion. This is a bone model, it is a straight tibia, but normally tibia is a little C-shaped bone. Anyhow, so entry point we can find, we can in sheath, we can put in a another, we take out this trocar, and suppose I should have taken out the trocar there only, just a minute. So the trocar was inside. So once we have got the entry point, then we take out the trocar, and then we put in a, this is a honeycomb. Honeycomb means multiple options of wires which we put inside, so that suppose our first wire, suppose we put in first wire and we are on the C-arm, we want to change the position. Okay. We are not satisfied with this, let this wire be inside, and then we can put one more wire over this. I mean, suppose we want to go more medial or whatever, so then we put a wire here. Suppose we want to go more anterior, then we put a wire here. Okay, so the first wire may not always be the perfect wire. So once the wire is, we are satisfied on the AP and lateral view of the C-arm, once we are satisfied with this wire, then we will remove the wire, and then we will put in the sleeve for the proximal drill. Okay, so there is, as like any tibial nail, there is a proximal drill.
Anomalies are usually DDH and
This
spinal
one.
anomalies, there may be cardiovascular malformation.
Drill kora ache already. Yeah.
And you have to know
So the proximal drill will go through the drill like this. Through the, see, this sleeve is always maintained. Okay, the sleeve is always, just see, yeah, sleeve is always maintained, and the outer soft sleeve and this, and then you go proximal drill. This has a stopper. it won't go more than that.
Maybe
Okay.
syndromic or some other
It
causes
stops
like
there.
that.
That means the proximal drilling is done.
etc.
And then we take it out. Once the proximal drilling is done, then we have to put in the long guide wire for reduction. Okay. So seeing on the C-arm, then there is a sleeve for this also. Any sleeve, no issues. Just for the guide wire to go in. No, এটা যাবে না। এটা দিয়ে যাবে? Okay. No, এটা আছে তো। Okay, I'll use the other end round, no issues. Directly थोड़ा वो होता है ना, if you run through the sleeve, whatever. And then you remove the sleeve, the guide wire goes in. The full thing is not. হ্যাঁ দিতে হবে জানি, এটা ওই এর ঢুকছিল না, এই বেরোবে না। হ্যাঁ, where is the sleeve for guide wire? Anyhow, we'll just go.
So now you have already heard about scoring of CTEV deformity, right? So we follow the score of Pirani. There are other methods, but we usually follow Pirani score. And on Abhishek will speak on that. And why scoring is needed? Can you tell? Anybody can tell. First is that interactive. When I say I did a fracture neck femur, and you also said I did a fracture neck femur, you need to say classification, displaced, undisplaced.
হাত বাড়িয়ে দিস ভাই, ব্যান্ডেজ আছে?
You will have to say something about that.
So
that is idiopathic Pirani 6/6.
সফট আছে, একটা ব্যান্ডেজ চাই, ব্যান্ডেজ বা ক্রেপ ব্যান্ডেজ।
See that whether scoring is gradually increasing. In recurrence, the Pirani score
So
will increase.
here I go. ঠিক আছে, করে নিচ্ছি। So basically this technique is called as functional cast bracing for fracture shaft humerus, and this can be used in both bone also. This is started by Sarmiento. It's around 30 to 40 years back. By hand of Dilip Pal, it came to India. Then it propagated in India through our respected Dr. Shailen Bhattacharya.
Hello.
So
what should be used and when it should be
now
used?
the thing is this: the fracture should be stable. An unstable and comminuted fracture or a fracture, intra-articular fracture, should not be included in this technique. So initially the starting days, this what you call these stockinates and all these things were not there. It was just plaster. Nowadays we have stockinates, so we can apply stockinate, or we can straight away go to the simple plaster. Even beside me we have Saroj Kaur, who has also seen this. So we just wrap, and while wrapping we ask please to hang, because gravity reduces it partially, so it has to be hang. The weight of the arm that reduces the reduction is there. There is always chance that this distal fragment will be displaced laterally. So while that is the normal tendency. With all pulls, the distal fragment will be laterally and the medial fragment will be medially, like as we have in subtrochanteric fracture in femur. The same principle holds here. So this will be there. So while putting a plaster, we'll just press it here. Then hath tulo baba. This is, we strap down the body, because this will be the anchorage of the functional cast bracing. We need a little bit of more now plating, and also I do also. Things have come a lot, but this is the time old technique, and that can be done in the everywhere. So this is the thing. Now 2-3 things ever rakho. The padding is
the bony part, the condyle should be given proper padding, because this is the part where the prominence, bony prominence can create a sore. So you have to be very careful about the condyle. So we are more or less done with the padding. As I was referring my presentation, padding is very important. Then you clean the flexor crease of the elbow. You should see here that the flexor crease is open. So you see the flexor crease is open. So every structure has 4 parts to support. One medial, one lateral, medial, lateral, anterior, posterior. Now we will make the cast for the lateral first, because this will be the longest cast. It makes me little bit sentimental, because as I am telling, this was simple and same words 30 years back, nearly 30 years back, what Dr. Sailen Bhattacharya told me. So for any cast technique, you must know at least you need 8 paddings, 8 folds. If you have less than 8 folds, it is not strong enough. More than 8 fold is not good, less than 8 fold is not good. So you must have the optimum of 8 folds. So this is one, that is the standard calculation of the length. One starts little bit beyond of the acromioclavicular joint, and another ends with the lateral condyle. That's the length of the lateral pillar. One. So now I'll take 4, 3, and this is 4, and then I will cut it. Now you can cut this, and you flex in 2. That makes 8. So that is the lateral support. So please, oh acha, it have also. So you must very carefully keep it. So this is the lateral. After lateral, you will make the posterior. So first is lateral, because when you will wet it, it should be in serial. So next is the posterior. It will from the tip of the olecranon to the again to the AC joint. I need 4 of this. 1, 2, 3. Hey Kingshuk bhai, arekta khule dibi. Classটা খুলে দে আরেকটা। এটা একটা কেটে দে, এখান থেকে কেটে দে। So this is 4 and this is 8. So lateral, posterior. Now we will have we had lateral, we had posterior, now we have anterior, AC joint to the crease line. 1, 2, 3, 4. देख दे भाई. So that 8. So that is the anterior. Now we have the medial one. That should be from the armpit to the medial condyle. 4, 1, 2, 3, 4.
Keep it as it is and put a ruler or something. See at which level it is bending. If it is close to 2.5.
দুজন মানুষের কথা খুব মনে পড়ছে এই মুহূর্তে, এক শৈলেন ভট্টাচার্য আর একজন যারা পুরনো দেখেছেন সেটা হচ্ছে রথিন মিত্র। রথিন মিত্র বলছেন যা করবে একটু ঘটা করে করবে, নয়তো লোকে থোড়াই পয়সা দেবে। তো দ্যাট ইজ দ্য থিং। সো উইল নাও অ্যাপ্লাই দ্য গ্লাসটা আছে না, ব্যান্ডেজ নেই তো, এটা দিয়ে করে দেবো। হ্যাঁ হ্যাঁ ব্যান্ডেজ থাকলে একটু দে
plaster. After what he said
ওটা
that
তো ওই
foot is prepared for
হ্যাঁ সফট না স্টকি নেট দিয়ে করে দেবো হ্যাঁ স্টকি নেট খুলে দেবো কিন্তু তাহলেই হয়ে যায় স্টকি নেট দুটো খুলে দেয় তাহলেই হয়ে যায়
এই কি পড়লো
ওদের ক্যামেরা পড়ে গেছে সো এগিয়ে দে ভাই হ্যাঁ যাকে হাতে যদি না লাগে তাহলে হলো কি সো সো দিস ইজ ওখানে থাক না এখান থেকে নিয়ে নেবো দিস ইজ lateral posterior anterior medial L P A M. So you put it time old technique, you put water then you use these two finger. People must have forgotten this. You must take out the all. So now I can ask what is the formula of plaster? How much H2O? Why it gets strong enough? Plaster as a component, gypsona, and how gypsona came in practice. That was in France. One fine morning, one plaster of Paris company was burned. The fire brigade they came, they put water, and next day morning they could find hard footstep in front of the factory. So that is at a kiolo, lateral. Now posterior.
usually it is 5 to 7
Again.
except premature child. If a premature born child, you wait for the body weight to be 2.5. Don't go for plastering immediately after delivery in a premature.
There must be a little bit space in between for breathing and compression. See, there is a space in between.
Those patients, there is very little amount
It's always anterior.
so there is a chance of so it is 5 to 7 days. Then how frequently?
So Krijodham again. So there is a place for breathing. একটু তোমার প্যান্টে লাগছে, I am sorry for that. ভাবো তোমার হাত ভেঙেছে আর প্লাস্টার হচ্ছে। Now I need a help. বেনু হয়তো এখানে একটু ধরতো বাবা। এই হাত তুলবে না। You don't move. এই ফ্ল্যাটটা ধরতে হয়। This medial side need to be given some structure. Then you come আরেকটা খুলে দিস। Pouring the bandage. So we are not having bandage here. So we are having what do you call? Stockinette acting as a bandage in a. So I will put this here. আরেকটা দিয়ে কিংসুক আরেকটা হয়ে গেছে এটা নে হ্যাঁ এটা বগলের তলা দিয়ে ঘুরিয়ে দে ওই বগলের তলা দিয়ে ঘুরিয়ে হাতটা তোলো এখান থেকে থ্যাংক ইউ আবার ছোট আরেকটা লাগবে যেহেতু এখান থেকে ধরি ঘুরিয়ে দিয়ে এটা তো ডেমনস্ট্রেশন এটা খুলে দিয়ে এটা খুলে দে
একটা স্টকিনেট দিচ্ছি একটা স্টকিনেট দাও
হ্যাঁ হাতটা এরকম রাখো
না একটা ঘুরিয়ে দিলে
so we'll give some time breathing time to let it dry it up. এটাই লাস্ট থ্যাংক ইউ ব্যান্ডেজ এই তো পাওয়া গেছে ব্যান্ডেজ থ্যাংক ইউ সো ভেরি মাচ থ্যাংক ইউ thank you Venu for giving me the opportunity to share some old techniques.
Old is gold.
Oh, that's our logo, na? Motto.
Old is gold.
Yes. So This is over. We should stick with, I have forgotten, একটু আছে না প্লাস্টার, ওটা আটকে দিতে হয়। Yes. এটা না ওই তো আছে। So this is also used to be in our old days. একটু কেটে নে, অল্প করে কেটে নে, এটা কেটে নে। We always, this is the sticker, main sticker. You put it in the water. This sticks like anything. This will not come out. This will not come out. কি সরোজ কাকু মনে পড়ছে পুরনো জিনিসগুলো? মেডিকেল কলেজে সেই প্লাস্টার রুম। হ্যাঁ স্লিংটা করে দাও, ওটা দাও। সিলিং একটা দিয়ে দে। হ্যাঁ সিলিং করবো কি করে? না থাক, আর কিছু নেই, এটাই থাক। এই সো উঠে দাঁড়াও। So you can see this is functional cross bracing, and you can see in the all side that even he can move. Now he can move. The fracture is stable. With every movement, the fracture get compressed. After 1 week, you have to take an X-ray. You have to feel this, that is it loose or tight. If it is loose, you have to reinforce by putting pressure better. 3 weeks, then 0, 1, 3. First day 1 after doing, then after first week, then 3 weeks, then 6 weeks you have to remove it and you have to put a fiber cast. 6 to 8 weeks. লাগাতে হবে। না না এই দেখো কাকু এরকম বললে হবে? Plaster removal. Plaster removal is after. হ্যাঁ কি বলবো? কি বলবো? এখন কেটে দেবো? এখন হ্যাঁ কেটে দিচ্ছি। না না তুই এমনিও করতে পারিস। হ্যাঁ হ্যাঁ
7 দিন ছাড়া এই যে মাঝখানে যে ইন্টারভিউগুলো আছে এগুলো কেটে দিয়ে আর লিকোপ্লাস দিয়ে টাইট।
তুই লিকোপ্লাস দিবি না, তুই ক্রেপ ব্যান্ডেজ দিবি। এখানে তো জায়গা আছেই তো, ব্রিদিং স্পেস তো রাখলাম। তুই ক্রেপ ব্যান্ডেজ দিলেই ওটা কম্প্রেস হয়ে যাবে। আর এই যে ল্যাটারালটা, এটা যখনই দিয়ে তুই প্রেসার দিবি তখনই যেটা এই ল্যাটারাল ডিভিয়েশন ছিল ওটা চলে যাবে।
একটু এই পজিশনে একটু
হ্যাঁ 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 ব্যালগাস।
এটা আমার সুব্রতার কাছে শেখা।
সুব্র আবার আমার কাছ থেকে শিখেছে, মানে খুঁড়ো খুঁড়ো। এই আমার ক্যামেরায় তুলে দে তো একটা, ওই ক্যামেরা বলছি ওটা কি বল, দূরাভাস যন্ত্র। কি? হ্যাঁ হ্যাঁ আর আমরা হিউম্যান লক ফক নেই। সিসাসের তো আমি একটা করছি, পেয়েছিস তো মেলটা? ওটা সার্ভেটা আমার দরকার। তোমার নেলগুলো গেল কিন্তু এই লোকজনদের শিখে। ছবি তোলো, ছবি তোলো, ছবি তোলো ভালো করে তোলো।
এরকম প্লাস্টার করার পর এরকম করে দেখতে হবে।
থ্যাংক ইউ।
পুরোটা ভিডিও হচ্ছে তো? হ্যাঁ কোথায়? এটা 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 হয়েছে তো?
বাস
ভালো করে এডিট করে দেবে বাবা, ইউটিউবে যাবে।
হয়ে গেল, তোমাকে খুলে দিই ভাই, যেটা খুলে দাও আমার। না না কেন,
আর জুড়ে গেছে,
আর জুড়ে গেছে, আর জুড়ে গেছে। যাক বাবা, নালফেল লাগলো না। কোম্পানি এখানে তাকিয়ে দেখলো যে এদের কাজ কি করে। প্লাস্টার হয়ে গেল, ঠিকও হয়ে গেল, ঠিকও হয়ে গেল। না এই কাঁচিটা দে রে। হ্যাঁ হ্যাঁ ও বাচ্চারা মারবে আমাকে। ওই এটা নিয়ে নি।
So as to
In Ponseti's technique, the first two casts are applied with forefoot supinated so as to bring it into alignment with hindfoot. The third cast is applied with forefoot abducted and simultaneous counter pressure over the talus. The fourth cast is applied with further abduction. The fifth cast is applied with foot abducted and dorsiflexed. Right. If it is dorsiflexed, it is okay. Then you can go for a sprint. Huh? Okay. Now, if the dorsiflexion is not possible above neutral, after fourth cast, a tenotomy is performed and the cast is maintained for 3 weeks. It is done only if the dorsiflexion is not corrected. Now, different methods of tenotomy. Percutaneous tenotomy by scalpel under local anesthesia. This is a standard technique by Dr. Ponseti. Percutaneous tenotomy by hypodermic needle under sedation, which I normally do. And open tenotomy under general anesthesia. I prefer a needle. Now the percutaneous tenotomy under sedation. What sedation we give? We give triclophos, pediclorin, 3 TSF before 2 hours of surgery. Now you see the child is sleeping. Now that is the needle on the right hand side, right? Now you see, the foot cannot be dorsiflexed beyond that. You see, when I am introducing the needle, I am filling the medial aspect of the tendo Achilles. I introduce the needle over there, anterior to the tendon. And you see, the needle is thus thrust upwards, posteriorly. And you see the tenotomy is completed. And you see, this is the final correction. Can you see? Before one and after tenotomy is completely corrected. Then you apply this past. Okay? Now, what are the complications? Now, there is very complication, very rare, but it can do. But if you see the anatomy of the ankle joint, beyond this tendo Achilles, there are 2 vessels and 2 nerves are there. On the medial side, there is tibial artery. On the lateral side, there is peroneal artery. On the lateral side, there is sural nerve. On the medial side, there is tibial nerve. Okay. So, while cutting this, you may damage the artery. So, it's a blind procedure. So, be very careful. Okay. So, now you can see one complication. After I did that, there was gross swelling over the ankle joint. Can you find it? This is a dangerous complication. But why? Because this might be a hematoma, might be an aneurysm. If it is aneurysm, the child's foot is gone. So early diagnosis of this hematoma is very essential. It's very essential to diagnose early hematoma. This is very rare. Out of 2,500 cases I have done till date, I have faced only 2 cases. And luckily, none of them came out to aneurysm. Both of them came down to hematoma. Okay?
Sir, but if you keep it in a cast for 3 weeks, how will you diagnose it?
How I diagnose?
After 3 weeks?
The patient will cry a lot because they were pressured, right?
Yes.
So within 1 week, I've got this solution. Now, open tenotomy under GA. Say if the patient is above 3 months of age, the patient came to you at the age of 1 month or 1.5 months. So you start doing plaster. So you have to do the plaster at least for 6 to 8 plasters. And then in those cases, which is above 3 to 4 months of age, don't go for tenotomy. I always go for open tenotomy because if you do by the tenotomy, it will be insufficient cut. So go for a small incision, you see, identify the tendon and cut it. It's simple. And just you can see. But every chance, what is that? There is a general anesthesia, but there is no chance of any vascular injury or nerve injury. There is the advantage of this technique. But it is expensive because you have to go do into a nursing home, right? And ETA under general incomplete. In this case, you see, after every correction, you can see 2 bands. Can you see the skin band? Here, neither you cannot do by tenotomy, neither by knife, or so you have to go for open incision. You can see the whole flap is there, and you have released the scar of the skin. because you have to release the scar of the skin also. And then you go for a elongation of the tendo Achilles. ETA has to be done in this case. And then that is the final result, right? Now, advantage of needle tenotomy over conventional tenotomy: quick recovery, low cost, outpatient maneuver, less chances of neurovascular complications. Disadvantage of technique: blind maneuver, technically difficult, not possible in rigid cases. Prevention of recurrence, this is very important. This splint, this is a very low cost splint. There are lots of good splints, but in my place, I cannot use more than this splint. This costs only 800 rupees. And you see that maneuver on the left hand side. Can you see the maneuver? This is the prevention of the recurrence. You ask the patient, mother, to do this maneuver 10 times a day. 10 times a day. Okay? And when the child starts walking, then you ask the patient and mother to sit like this in squatting position. Can you see? What is the advantage? Then the equinus will not recur. So two things are there. One, you have to continue this sprint, and how much hours he will sprint? Up to 6 months of 23 hours a day. And every 1 hour or 2 hours, you remove and ask them to manipulate like this. Right? In nature, you go to this. Okay? To prevent the recurrence of deformities in these poor children, free camps are done. That is a different chapter, so that you can bring back those patients, because they are very poor patients. So regular checkup should be necessary. And these are some clinical photographs. Back to the Anyway, it's not important. Could have shown some slide.
So you want to go back?
No, it's not coming. I don't
clinical
know.
photograph?
Yes, yeah. ওইখানে দেখা যাবে।
স্যার আমি দেখুন তো ইয়ে করে আসছে কিনা, জাস্ট আলাদা করে কি স্যার এটা আপনার ল্যাপটপ? হ্যাঁ। এখানে কি আলাদা করে ফটো আপলোড করা আছে?
হ্যাঁ, আপলোডই করেছি এখানে।
না না, দেখেছি প্রেজেন্টেশনের বাইরে কি আছে?
না না না, এখানে দেখেছেন। এখানে দেখেছি তাই।
স্যার লিংক করা আছে।
কিন্তু আমি ওখানে দেখলাম যে ওখানে বসে। If you have time, I can show you a photograph. No, I don't think necessary. Time show. Okay, there are some photographs there. Sorry, I can't show that.
So we can start with the plastering. So you got a basic idea how it is done. Okay. Take the foot which has that. How many people are there? One person will hold. Take it, please. Two people, so the role of the assistant, I think, is almost equally or even more important than the person applying the plaster, because he has to hold it in the proper reduced position. Yes, sir. First metatarsal. My second finger. Finger, not this side. You're supposed to hold. You have to go for the correction. Okay. My thumb will be. Okay. Okay. First metatarsal, index finger. Second metatarsal, around 4th or 5th metatarsal. Thumb, talus. Talus head you will be able to feel over here, and that should be other hand. No. 1, 2, 3, 4. So how to feel talus? If you have got that lobular hand, the head will be roughly little bit subluxed. Just in front of the fibula. Just in front. Just in front of the fibula. This. First cast is we are exaggerating the deformity. মানে আমরা supination-টাকে বাড়াচ্ছি. How we will supinate the foot? এই যে আমার তিনটে আঙুল আছে. How I will supinate my foot? এই force এই. ঠিক আছে, with the index finger. আরে এখানে না, এখানে first. metatarsal head-টাকে ঢোকাতে হবে. Index finger, first metatarsal head, this fifth metatarsal, this talus, and a lifting of the first metatarsal head. এই তিনটা ওরকম করে ধরলে আমি প্লাস্টারই করে করবো। তুমি যদি এরকম করে ধরো আমি প্লাস্টার কি করে করবো? আমাকে তো দিতে হবে অ্যাসিস্ট্যান্টকে প্লাস্টার করতে। এই হলো প্লাস্টার। প্লাস্টার যখন করবে আমার আঙুলের উপরে প্লাস্টার যেটা কেন করছে? আমার আঙুলের উপরে প্লাস্টার করতে।
There are two methods of plaster. One, depending on the size of the baby, right? If it's small baby, then you cut the 4-inch plaster twice, half. If it's a big baby, then cut it 6 inches.
Layer only one
Layer,
layer.
single layer.
Single layer. Important thing is, অনেক সময় কিন্তু we don't use this also. We use just the bandage. But you try always with the cotton. প্লাস্টারকে হাফ করবে। প্লাস্টার খুলে তো ঘুরে দেখিয়ে দিন না। না আরে পারবো না, ফার্স্ট এটা করে দেবো। একটা ফুটের একটা প্ল্যাটফর্ম বানাতে, হ্যাঁ এটা করে দিচ্ছি বাস। See, if I am holding it like this, na, so I got my assistant got enough space to roll it. So my axis of the foot and my hand are in the same. That is one axis. Foot first, not ankle. Foot first. 5 rolls in the foot. Foot. Active ankle and foot. Foot. 5 rolls in the foot. 5 এখন অ্যাঙ্কেল করো টিবিয়া করার সময় আসবে। অ্যাঙ্কেল করো, উপরে তো টিবিয়া করছো। নাও সি হিয়ার, এর পিছনটা, দিস প্লাস্টার শুড নট ক্রস দ্য পপলিটিয়াল ফসা। ঠিক আছে, আমি যে আমি 90 ডিগ্রি করবো ওখানে লাগবে। করো কিছু। এখন এটা হয়ে গেল, এখন ইউ ফ্রম দিস সাইড। এটা থাকবে। In this position we are switching the role. He is holding the. This is my grasp. This is my grasp. First metatarsal head with my thumb. এখন I have got enough time. Spread my grasp. এই extra space রেখেছিলাম উপরের জন্য, এটা lateral side আমি পেলাম and I fold it. ठीक है, এই থামটা ফার্স্ট মেটাটার্সাল হেড and I hold it supine. Spread the finger. You have to also think of that it doesn't click করলে কি হয়, এই হয়ে গেল। You have to remove the gap. Why? Because that will create a deforming force. Waiting করা যাবে many time in the PA we get this more thing,
and the plaster should extend like normally what we expect it to the like normal a Pilon cast, or when we are putting a plaster in the leg, what we do, we go it up to the metatarsal head. No, here you have to cover the entire toe also over here, okay, because at the end of the day it is not only a deformity of the foot, you have the tightness of the FHM and the FDL also over there.
So এখানে হয়ে গেল আমার cast.
It should be up to the toe,
So
the tip of the toes.
whether my cast is correct or my cast is wrong, whether my cast is good, bad, কি মনে হচ্ছে? Same line এ আছে, whether I am able to see all the 5 fingers or not, first point. Color of all the toes are pink or not, second point. Third point, toe movement হচ্ছে কি না, stroke a little bit. There should be some movement. Fifth point, whether there is swelling or not. And last point is excess cry. একটু বাচ্চা কান্নাকাটি করবে, but if there is excess cry with this, then to bivalve. First day যখন করা হয়, starting with the child will be fine because the child is under sedation and all. In the night the child will be. That is a very very important. First cast যখন হবে in the night, child will definitely cry. And the next thing, you will get a call from either mother or someone, child ঘুমোচ্ছে. This is very important. If possible, give your number. If possible. Otherwise, tell them to এরকম হয়. Because crying alone does not tell us that we have to bivalve the cast. But if the swelling and color change and everything, we have to bivalve the cast. This is half
And
cry.
sir,
Yes.
what do you mean by
First,
bivalve?
in cast, always the child will cry and he will not sleep. But most important thing is the coloration of the foot, toes. That you must inform. কালারটা ঠিক আছে, যাওয়ার সময় বলে দেবে, বারবার ওটাই বলবে, এটাতেই পেশেন্টের নর্মালি কাস্ট কেউ বলে না।
Mention in writing that if child cries excessively, if there is change of color tone, or if the plaster cast slips, then come early. Otherwise, after, as you said, 5 days or 7 days.
So now the special case, 3 মাস বয়স ছিল। Tell your case, কি কেস আছে?
3 মাস বয়সে এসছে
আচ্ছা এটা দেখি, আচ্ছা আমি একটু বলে নিই। So that was a idiopathic typical. This is more or like an atypical class because this is from medial side to lateral side. In those cases you have to correct because there are cases of first, second, third, fourth, fifth rows. All metatarsal cases. So you have to correct like this. All metatarsal together. Okay. Then you hold plaster. Sometimes in atypical club foot, it is very resistant to manipulation. So we may need a mid-term policy, or that is do a percutaneous Steinler plantar fasciotomy, tenotomy, and start Ponseti again. Because it is very difficult to correct the midfoot in atypical club foot. If it corrects by your manipulation, okay, otherwise don't hesitate. Take the patient to OT, do a plantar fasciotomy and correct the midfoot.
One more important thing, as they were mentioning, in case you get a white foot or a pale foot after the plaster, what will you do? You will remove the plaster right away, or we have bivalving is one, and other than that, any trick is there? How can you do that? Sometimes it is, you can just loosen it a little bit and the circulation might come back over time. So you can always introduce a artery and from there and just release it a little bit. Be careful, pointed head should be on the bottom. You should not scratch the skin and everything. Okay, so that's one practical technique which you...
Suppose you have done plaster, but you are in doubt whether the circulation of toes are okay or not. Then you can introduce one straight artery for shape just along the sole of the foot and just stretch a bit the lower part. By doing this, you can have a pale toes turning into a red one. But if the patient goes back home and next day morning that parents are saying that the child cannot sleep, he is crying continuously, then better you see the patient by yourself. And if is any doubt, remove the plaster. One more thing, suppose you have done one plaster cast Okay. এক মিনিট আমি এটা বলে নিই you have done one plaster cast, say after second cast you have seen that there is a slight amount of slip, you remove the cast and you've seen that you will see there is redness of the skin, some amount of sore and edema. So what will you do then? You have removed already. It has slipped a little bit. After removing the cast, you have seen that there is redness, some amount of swelling and some very mild skin breach. Will you continue the cast immediately or you do something? There is a term called cast holiday. Send the patient. कि तुम्हारा चले जाओ 7 दिन बाद you will be surprised to see that the foot is everything is okay then by that time, but don't do the cast immediately. Okay, thank you.
Another thing I want to show, I want to tell you, you all know the congenital heart disease, right? Congenital heart disease is a very problematic case and cost of the treatment of congenital heart disease is very high. But remember, the congenital clubfoot cost is not less than that, because you have to follow it for 5 years. So for 5 years, if you calculate the cost, so that is the important. So immediate and follow-up case is necessary. I'm going to show you another slide. This is some clinical photographs. You see, this is the clinical photographs. You can see this was now this child. Now the child is walking. This is a very satisfying motion for the patient. Okay. Fine, thank you very much.
এই যে এখানে আঙুল থাকবে আমার তুই পকেটিয়াল ফিজে দিয়ে দিয়েছো অরিজিনাল স্যারের টিচিং এলবো ফিজ আর পকেটিয়াল ফিজে দেওয়া যাবে না আমি আরামবাগ মেডিকেল কলেজ অভিষেক দা এরকম করে ধরলেও করবে আচ্ছা বলছে আগে স্যার বলুন না কি বলছে পাটা কোথায় আমি তো থামটা দিয়েছি হেড অফ দ্য টালাস অ্যাক্সেস অফ দ্য ফুট আর এই ইট হ্যাজ টু বি ইন দ্য সেম লাইন এরকম করলে প্লাস্টার করবে কি করে ও আচ্ছা 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 ওকে আমি যদি এরকম করে ধরি প্লাস্টার করবে হ্যাঁ রাইট টাইট হবে না আমি তাই ভাবছি ঠিকঠাক হচ্ছে না অ্যাক্সেস অফ ফুট আর এই অ্যাক্সেস অফ দ্য ফুট ইন লাইন ফিঙ্গার হবে আচ্ছা আচ্ছা ওই জন্য এটা খুলে গেছে ওটা একটা ওই মডেল সেকেন্ড মডেলটা একটা দিয়ে দাও তো এই দাও আমার অ্যাসিস্ট্যান্ট ধরলো এরকম করে আমি বললাম অ্যাবডাকশন করো অ্যাবডাকশন এই দেখো অ্যাবডাকশন এখানে প্লাস্টার করতে পারবো না না অ্যাক্সেস অফ দ্য ফুট ঠিক থাকতে হবে ও এরকম করে ধরে যাবে এই লার্নিং পয়েন্ট দাঁড়া এতে ইয়ে করতে দাও চলো রোল করো এটা আর দেখি এখন কি করলে ছাড়ো এখানটা লক করলে এখানটা লক না করলে কিছুদিন পর দেখবে ফুট টেপ হয়ে চলে আসছে এইভাবে ইয়েস ইউ হ্যাভ টু লক ইট এই লক হলো This is thank you sir. This has to be initially it should be POP and only POP because manipulation POP দিয়েই হয় after after that, once you become যেটা মানে আমরা করি যেটা এখন, you can put a layer of delta cast or a synthetic cast over it. It looks better and erosion বা plaster যে problem গুলো হয় সেগুলো পাওয়া যায়. But these plasters anyhow need to be removed after every 7 days. So cost of therapy and that over there, যেটা depends on that. You can decide. ঠিক আছে? প্লাস্টারিং এর তোমরা কি কি ইম্পর্টেন্ট পয়েন্টগুলো কি কি বুঝতে পেরেছো? What are the important points? হ্যাঁ, একটা মেটাটারসাল সেকেন্ডটা হিপ আর এটা হচ্ছে না ধরাটা খুব ইম্পর্টেন্ট। না ধরাটা তুমি ম্যানিপুলেশনের জন্য ধরাটা ওটা ম্যানিপুলেশনের জন্য তোমাকে ফুড ধরার সময় এইখানে এইখানে ধরে তোমাকে শুধু সাবজেক্টের দিকে ক্রিয়েট করে দেবে। এখানে ধরলে আমাদের ক্যাভাসটা কোথাও বলা হয় যে এটা ফার্স্ট কাস্ট যেটা আছে, ফার্স্ট কাস্ট কমন কমপ্লিকেশন উইথ দিস থিং যেটা বলেছে এখানে ফিঙ্গারটা এখানটাতে থাকবে। ডোন্ট গো ফর এনি ইমিডিয়েট কারেকশন লাইক দিস ইন দ্য ফার্স্ট কাস্ট ইটসেলফ। You are supposed to only supination like this, okay, and try to straighten out the medial border সবথেকে প্রথমে, ঠিক আছে? Don't pay much attention over it. You can do it a little bit over time. We have this thing. করে common problem with parents is that they will tell deformity বেড়ে গেছে. That you should be counseling করে তারপর first class একটা করবে. That is what you need to understand. আচ্ছা বুঝতে হবে। first deformity by এখানে একটা ঠিক আছে। first class এর job করতে আর সেকেন্ড ক্লাস করতে সেকেন্ড ক্লাসটা একটু ক্যাপাসিটেশন হয়ে গেছে অ্যাবডাক্ট করতে অ্যাবডাক্ট এখানে টান দিবি এরকম করলে এখানে ধরো হ্যাঁ এই সব হ্যাঁ একদম সব হবে এটা বিশপ আমটা কোথায় থাকবে আমটা এই দিকে কেলেসে মানে এইরকম থাকবে এটা ওইদিকে এক সেকেন্ড ঠিক আছে তোমার ফিঙ্গারটা বরাবর এইখানে এটা থাকবে ঠিক আছে তারপরে তুমি এখানে একটা পাবে এটা মোড করো এইখানে ধরলে হবে সামনেটা মোড করো পিছনটা মোড করো এখানটা মোড করো এগুলো সব মোড করতে হবে করুন না এটা হচ্ছে ফার্স্ট মেটাটারসাল এরকম রোল করে পুরোই রাখবে হ্যাঁ আর এখানে এখানে মোড করো এটা মোড করে যত ভালো মোড করবে স্লিপেজ তত কোনটা মোড করবে তোমার কম হবে দেখে নিচ্ছি এটা কি হবে এটা ইউজ করেছিস ইউজ করে ইউজ করে আমি ছবি দেখে দাও কত টাকা আপনি পর্যন্ত করা আছে এই প্যাডটা দিলে না না মাইক্রো এটা আলাদা একটা প্যাড পাই এখানে এক্সট্রা যে উপরে জায়গাটা আছে না না ওটা মানে মানে সেকেন্ডটা করতে সেকেন্ডটাই লাগবে সেকেন্ডটা লাগবে না ওটা শুধু দিয়ে দেব ক্যাভাস কারেকশন একবার তুমি হাত সরিয়ে নাও একবার পুরোটা কম্পেয়ার করলাম প্লাস্টারের আগে এতটা আছে প্লাস্টারের পর কিন্তু এতটা হবে এতটা হবে ঠিক আছে উই আর সুপাইনেশনটা বাড়ালে বেশি চাপ আছে সুপাইনেশনটা বাড়ালে you see the difference first class for আগে first class for এখানে তো এই অ্যাঙ্গেলটা এখানে তো প্রচুর কম্প্রেশন ধীরে ধীরে ঠিক হয়ে যায় আমাদের প্ল্যানটা কি আমি ফ্যাকাল্টি নয় কি এটা পুরো আঙুলটা চেপে বসছে এরপরে চলে এলো পুরো আঙুল চেপে বসছে এই কার এখন কি হলো হ্যাঁ এটা কে করেছে স্টেজ না 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 চেপে বসছে না এই যে আমি দেখছি আরেকটা কে করেছে এটা অন্য কাছে করা যায় নরমাল এটা তো ওটা ইয়ে কর মোল করে দেখ হচ্ছে কিনা মোল কর জল দিয়ে মোল করতে হবে best thing would be first layer of POP followed by this layer. That is what you would add. POP is always more moldable than this. Ideally, select the POP. Acha, complications of casting. First thing, the most commonest thing is you have to understand there are the cotton layer on the side of the thigh as well as towards the foot side should be properly and it should be everted over there, because in case they get some scratch or some abrasion or something during the plaster removal, again you have to send the child for a plaster holiday. you will be delayed, number one. ঠিক আছে? Number two যেটা হচ্ছে সেটা হচ্ছে যে another thing is obviously the use of proper diapers and everything. Though it is for 7 days, I have had patients যেখানে পুরোপুরি urine soaked বা stool soaked wet plaster নিয়ে এসেছে and then they had maceration inside, again we had to delay it for 7 days and that. ঠিক আছে? Second thing, during cutting of plaster, ঠিক আছে, while we are removing the plaster after the first cast or after the plaster and that, যেটা oscillator যেটা আছে সেটা টেকনিক্যালি ইউজ না করে প্লাস্টারটা ওয়েট করে তারপর রিমুভ করাটা ইজ আ বেটার আইডিয়া। আগের দিন ওয়েট করে এসে পরের দিন লাগাবো ওয়েট করে, হ্যাঁ, দ্যাট নিডস টু বি ডান। আরেকটা সফট বিকজ পুটিং দ্যাটস অন, ঠিক আছে। দেয়ার ইজ ওয়ান মোর টেকনিক ফর প্রিভেন্টিং দ্য স্ক্র্যাচ ডিউরিং দ্য প্লাস্টার রিমুভাল, যেটা এনকে দাস স্যার করেন। সেটা হচ্ছে যে একটা ওই পাতলা যে আমাদের ক্রেপ যেটা থাকে, ফাইন যে ক্রেপ থাকে, সেটা দিয়ে ওটাকে অনেক সময় দ্যাট অ্যাক্টস অ্যাজ এ মানে ওয়ার্নিং যে উই নিড নট, দ্য প্লাস্টার কাটার নিড নট গো বিয়ন্ড দ্যাট রেড মার্কিং এন্ড দ্যাট।
আগেকার দিনে যখন প্লাস্টারটা না ভেতরে একটা ব্যান্ডেজ দিত,
সেটা
অস্ট্রেলিয়ার শটটা চলছে, ওটা ব্যান্ডেজটা স্টপ,
ঠিক আছে।
আগে তো আমরা ভেতরে
ওকে,
অর্গানাইজিং সেক্রেটারি আমি অর্গানাইজিং সেক্রেটারি কিছুতেই নেই সব চলে গেছে লোক। আচ্ছা,
okay, any more questions, any questions or anything you want to ask?
Deformity in CT, CAD
none.
Deformity in CTV and how you are correcting it. CADE
For
internal rotation of the
TBA.
how you are correcting it. যদি যখন আমরা প্লাস্টার করলাম তখন আমরা প্রথমে আগেরটা করলাম, এরপরে we are to put the forward at 90 degree. When we are giving it a 90-degree angle, you external rotate it. ठीक है? So do a little external rotation. So the fifth deformity, that is the internal tibial torsion, will get corrected with that.
And how tibial torsion যেটা হচ্ছে লাস্টটা কি করে, last plaster, what is the supination of the foot, last plaster before you go for a tenotomy, what is the final corrected position of the CTEV? 70 degree of abduction. Okay, so ওটা থেকে invariably we get a tibial torsion অনেকটা ওটাতে আমাদের কারেক্ট হয়ে যায়। ঠিক আছে, ওকে, থ্যাংক ইউ সো মাচ। ওকে,
এই পুরো গ্রুপটা একটা ছবি তোলো,
What percentage of your patient needed tenotomy? What percentage? More than 99.
ছবি উঠিয়ে দাও একটা, ছবি উঠিয়ে দাও।
আরে সিটিভি গুলোকে হাতে নিয়ে তো কি তো ব্যাপারটা যে হচ্ছে এটা আমার নেব।
থ্যাংক ইউ।
এই গ্রুপে খবর দাও, কুইক তোমাকে বললাম এখনই সব ছবিগুলো, হ্যাঁ এসডি কোয়ালিটি করে হোয়াটসঅ্যাপ গ্রুপে না লিংকটা দিয়ে দাও, সবাই মোলটা লিংকটা দিয়ে দিতে সবাই দেখতে পাবে, ঠিক আছে? থ্যাংক ইউ। যতক্ষণ পর চাবি যাবে তোমার মোটামুটি কমপ্লিট র্যাপ আপ।
Hello.